Health will now come to order. The clerk will call the roll.
Click.
Present.
Campos. Present. Collier. Here. Jeton. Here. Johnson. Here. Price.
Here.
Smith.
Here. A quorum is present. As a reminder, if there's anyone who wishes to testify on any of the bills we'll be hearing today, you must register on the electronic witness affirmation kiosks outside the hearing room before you testify and indicate which bill you'd like to testify on. As per the committee posting, I will limit testimony time and the number of witnesses to ensure consideration of posted and pending business, especially if testimony would cause the hearing to extend into the next calendar day. I would like to inform everyone that the public comment portal opened when the hearing was posted on Wednesday afternoon. Any Texas resident is welcome to offer their comments on the portal. Each member of the committee is able to view the comments as they are posted. The comments will be posted and available on each bill's webpage after the portal is closed. Okay. The chair lays out House Bill 2553 and recognizes Representative Stuckey to explain the bill.
Thank you, Madam Chair and members. House Bill 2553 is an effort to put physical therapists in par with chiropractors who are currently allowed to see patients without a referral for a primary care physician. This idea was brought to me by a constituent who is a doctor of physical therapy working and serving rural Texans in Wise County. Since filing the bill, I've heard from stakeholders who worked together in 2019 to create a compromise in the statute. This compromise allows a physical therapist to see a patient for 10 consecutive business days or 15 days at the highest education level. I'm working on a committee substitute that builds up the successful expansion of patient access from 2019 and would expand access to 20 consecutive business days. There are witnesses here today to testify about the work in 2019 and why they are concerned about expanding access for patients. They will talk about the safety of patients. In my mind, there are three reasons to support HB 2553: accessibility, safety, and accountability. I want to make clear this bill is not and will never be about expanding the scope of practice for physical therapists. Ultimately, HB 2553 is about expanding access, which reduces the cost of patients, especially rural Texans who travel farther to get the care they need. When it comes to safety, there have been 0 reports of physical therapists harming a patient. In fact, a doctor of physical therapy is trained in differential diagnosis, imaging, pharmacology, and evidence-based practice, just like a medical doctor or a veterinarian myself. These are all necessary skills to identify red flags that determine if a physical therapist is the correct individual to treat the patient. As for accountability, in addition to the reporting standards in statute, the committee substitute will still create a pathway for a patient to see a physician after 4 weeks of physical therapy if the issue is unresolved. I believe this bill is a sensible step in the right direction for Texans who don't have the time or money to waste on getting a referral. I'm happy to answer any questions at this time. If not, I reserve the right to close.
Questions, members? All righty. We will begin public testimony and reserve your right to close.
Thank you.
The chair calls Jimmy Widmer. Up next will be Michael Gilhode, followed by Blake Hudson. If you'll state your name, who you represent, and your position on the measure.
Good afternoon. My name is Dr. Jimmy Widmer, and I'm an internal medicine physician from Temple. On behalf of the Texas Medical Association and its more than 57,000 members, we thank Chairwoman Click, Vice Chair Campos, and the members of the Public Health Committee for the opportunity to respectfully testify in opposition to House Bill 2553.
Excuse me, you're testifying on behalf of yourself.
And myself, yes,
okay,
ma'am.
Thank you.
Thank you. First, I would like to personally thank Dr. Stuckey for being a strong supporter of medicine and always having an open door policy to his physician colleagues. TMA has several concerns with this legislation, however. The bill would erase important patient safety protections found in a thoughtfully crafted law from just 2 sessions ago. In 2019, organized medicine and physical therapists reached a significant compromise, allowing direct access to physical therapists, but with essential and purposeful time limits to ensure patients requiring a medical diagnosis would receive the care they needed. Now, just 4 years later, the proposed legislation would erase this compromise and water down patient protections. Under the existing law, a patient can seek direct care from a physical therapist without an accompanying referral for 15 business days of treatment for physical therapists who have completed the highest level of training. This translates to well over 3 weeks of direct access when the weekends are considered. Meanwhile, physical therapists who have not completed the advanced training are granted 10 business days. The 2019 compromise created these limits because a simple injury should resolve itself during this time frame. If the injury does not resolve, something more serious could be driving the patient's symptoms, and they should seek the care of a physician for proper evaluation and medical diagnoses. For many injuries, an improper treatment delay can lead to long-term damage. Physical therapists play an important role in the team-based care model. However, the reality is that physical therapists are neither licensed nor trained to offer a medical diagnosis. This could involve a history in physical, lab work, specific imaging, or an intense understanding of how another part of the human body's system could be the underlying etiology for the pain. For more complicated injuries and ailments that do not resolve within a few weeks, it is clear that the medical diagnostic tools of a physician are necessary for appropriate patient care. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Questions, members? Ready. Thank you.
Thank you.
Michael Gilhode, followed by Blake Hudson.
Thank you. Hello. My name's Mike Galehood. I'm the president of the Texas Physical Therapy Association, and I rise in support of this legislation.
Thank you. Please begin your testimony.
I also am on faculty at UT Health San Antonio, where I've taught physical therapy to our students, to our Doctor of Physical Therapy students for the last 20 years. We rejoiced in 2019 when Texans were finally able to access a physical therapist without a referral from a physician, because it allowed those folks who had straightforward aches and pains to come get the care that they needed without the unnecessary time and expense of a physician office visit in order to get the referral and end up in our offices. I can tell you that I personally took advantage of this law by starting pro bono clinics in San Antonio, where I live and practice. We have one at Haven for Hope, the largest homeless shelter in San Antonio, at Alpha Home, where women are recovering from substance abuse, and at the San Antonio Refugee Clinic, where folks with aches and pains can come and see us without having to have a physician refer them. Many of these folks are uninsured and don't have access to physicians. So it's been great for that, for my own personal practice. Obviously, this isn't about money. I'm doing this on a pro bono basis. Physical therapy and our bill in 2019 really addressed the triple aim of healthcare, improvement and reform, which is to increase access, decrease costs, and improve patient outcomes. As far as access goes, physical therapists can often see people same day or next day, whereas we all know with general practitioners and especially orthopedic specialists, it can take 1 to 2 months to get in to see those people in our larger cities, in our urban areas here in Texas. Decreased cost, we have mountains of data showing that patients who access a physical therapist first without referral spend on average much less per episode of care than those who go through the referral route. They are rarely referred for unnecessary imaging or opioid medications, prescriptions. Patients who see a physical therapist first have an 89% lower chance of getting an opioid prescription for their back pain. All of these are examples of research that has come out in the last 10 to 20 years. Patient outcomes, obviously getting the right provider to be able to take care of that person is what we want. And in terms of downstream costs, the patient's hospital readmissions go down when they have early and easy access to physical therapy. and healthcare expenditures go way down. As far as the two arguments of safety and overutilization, Representative Stuckey did an excellent job of outlining that there have been 0 complaints in the 4 years that we've had our direct access provision here in Texas. There's also 41 states that have either no restrictions on access or a 1-month, 30-day access law. There have been 0 complaints nationwide against physical therapists for reasons of patient safety. In terms of overutilization, which is another argument that has been brought forward, again, we have research that combats this notion. Patients who access a physical therapist first actually utilize fewer patient visits than those who go through the referral method of accessing a physical therapist. As far as imaging and other suggestions that patients need a medical diagnosis, physicians' own practice guidelines state that imaging is not a frontline modality for simple cases of low back pain, ankle sprains, neck pain, shoulder pain, knee pain, that should only be attempted after a trial of conservative therapy. So we are following the same guidelines that they do in terms of medical screening to make sure patients are appropriate for our services. As far as the argument about medical diagnosis, remember we can receive referrals from dentists, podiatrists, chiropractors, nurse practitioners. None of those folks are applying a medical diagnosis to our patients when they refer patients to us either. So as the law currently is written. With that, I will close, and I welcome any questions you might have.
Questions, members? Thank you.
Thank you.
Chair calls Blake Hudson. On deck next will be Chase Bearden and Alina Scholler.
Good afternoon, Chair Click, members of the committee. My name is Blake Hudson. I'm Director of Public Affairs for the Texas Association of Health Plans, testifying opposed to the bill's file. So when this bill was passed a couple sessions back, there was sort of a deal made, and that was 1, that this would not change scope of practice, and 2, that it wouldn't impact insurance coverage. And we sort of feel like that deal's been broken, and the arguments have changed quite a bit. So we've heard arguments that now, with this direct access provision, that these providers have become primary care providers and should also, for the purpose of health insurance benefits, be treated like primary care providers. That creates a number of problems. We also have, we have heard separately that, and have some concerns about the way this is playing out, that physical therapists are deriving something like 50% of their revenue from this direct access period. So the concern is there's maybe some cramming of patients into this open period that might be inappropriate. That combined with what's being requested in terms of what's being sort of argued in terms of health benefits changes as well is very problematic for us. So unfortunately, we are opposed to the bill now and concerned about any further removal of physician oversight of physical therapists because of what we're seeing sort of a bigger picture play out on this. That's all I think I have to add. I'll take any questions if you have them.
Questions, members?
Thank you.
Thank you. Chase Bearden, Alina Scholler. Kimberly Moyers. Kimberly Moyers.
Oh, that's Alina.
Waiting on the first person you called. I'm Alina Scholler. Testifying in opposition for 2553. Good afternoon, Madam Clerk.
She's representing.
And you're representing?
Texas 400.
Okay, thank you.
And we're opposing House Bill 2553. I'm coming from the perspective of a physician who actually hires, employs, works with physical therapists every day in the practices that I own. We work as a multidisciplinary team, so I know how the spectrum of physical therapy and medical physicians work together. So I want to come from that perspective. But I also want to give you 3 reasons why this bill really should not move forward. First, we've already made that compromise, as discussed, back in 2019 with House Bill 29. And that was a rare compromise for scope of practice issues. And physical therapists and physicians came together to make this bill work. So here we are again, just 4 years later, and it's disappointing to see this crop up again. I heard that the committee sub would allow for 20 business days rather than 15, and it doesn't sound like much, but 20 business days is 4 full weeks without a physician seeing a patient that could potentially have a big issue that needs to be addressed rather quickly. So what could go wrong? Bad outcomes. There are quite a few, not just orthopedic injuries, but other medical issues as well that need to be addressed quickly, and that time period is just a bit too long. Stretching that out further can put patients at risk. Just a few examples, you know, we have neurologists that send to physical therapists, neuropsychiatrists that send to physical therapists, hand surgeons, plastic surgeons. So it's not just orthopedic surgeons versus physical therapists here. It's actually a multidisciplinary group of physicians that regularly refer to physical therapy. And those could be medical problems that can be missed in that 4 weeks. So the timeframes are really important. Things like syndesmosis injuries, scaphoid fractures, even a calf sprain that turns out to be a deep venous thrombosis that needs to be treated, or a balance issue that's sent to a physical therapist but turns out to be a neurological tumor. Those are just a few of the many kinds of medical issues that could be missed and where time is really of the essence and needs to be treated rather quickly. I also wanted to touch a bit on, I heard somebody mention, or I think it was Blake, about the cramming issue up front. When you're billing insurance, a lot of times you want to get as much billed in those first 120 days as possible. And that is an issue if the physical therapists are seeing the patient before the physician, then there might not be money left over, so to speak, with their insurance company. And finally, it's really a rare event when the Texas Association of Hospitals and physicians come together on something. So that might be a red flag to think about too, when you have both these organizations actually agreeing on something. That's a rare thing. So that's really something you shouldn't ignore. So we respectfully oppose this bill. Thank you.
Questions, members? Thank you.
Thank you.
Okay, Chase Bearden or Kimberly Moyers? Is there anyone else wishing to testify on, for, or against House Bill 2553? Chair recognizes Representative Stuckey to close.
Thank you, Chairman Click. From what I just heard, it sounded to me like an insurance issue and a billing issue, not a quality of care issue. There, like I said earlier, there has not been one complaint by the board against the physical therapist to this point. Number two, I'm a veterinarian, not a real medical doctor, but I've had 40 years experience. All of us know if you have fasciitis, tendinitis, myositis, those things take at least 2 weeks and many times up to 4 weeks to get better. So to cut them off at 2 or 3 weeks instead of give them 4, I don't believe gives medically the opportunity for them to see whether they're going to get better or not. Again, these physical therapists are trained in differential diagnosis, imaging, pharmacology, and evidence-based practice. So if the bag was opened on letting them see patients without a medical doctor first, this is not about changing the scope. It's about giving them the right opportunity to see the improvement that they should get before they refer on if they need to, whether they need an MRI or something else. So I respectfully disagree with Ms. Schultz and Mr. Hudson on these things. And Dr. Widmer, I appreciate him very much. In fact, I appreciate his uncle, who is a federal representative, Dr. Burgess, and a friend of mine, and they have a lot of medical doctors in their family. But again, this is about just expanding it to a reasonable period of time. 20 states have no requirement to see a medical doctor at all. 21 other states have 30 years plus. There's only 9 states that still restrict them under 30 days. I'm asking now that we have doctors of physical therapy that are trained in differential diagnosis, imaging, pharmacologically, and evidence-based practice to have 4 weeks or 20 business days in order to see a patient, especially in rural areas of Texas where they may have to drive 1 or 2 hours just to see a physician. And with that, I thank you, Chair and members, for your time today. Again, HB 2553 is about expanding access to patients. I believe that we should remove barriers to care, especially where there's a strong record of serving patients without zero safety concerns. So I ask for your favorable consideration of HB 2553, and I close.
Thank you. If there's no objection, House Bill 2553 will be left pending. The chair hears no objection. House Bill 2553 is left pending without objection.
Thank you.
The chair lays out House Bill 3468 and recognizes Representative Capriglione to explain the bill.
Chairwoman Click, members, thank you for the opportunity to address the committee today. This bill accomplishes 4 main objectives. First, this bill gives ownership of health information back to the patient. Next, it specifically prohibits information blocking, which is a practice that interferes with, prevents, or discourages access, exchange, or use of electronic health information. Third, it provides state-level enforcement mechanisms for information blocking violations. And finally, it creates medical record request deadlines and fee schedules for all covered entities to ensure timely access to such records. Currently, if a patient in the state of Texas were to request a copy of their health records, there's a chance they may experience information blocking. As a result, many individuals are unable to access their health information to seek secondary opinions for permissible and desired uses. Numerous complaints have been raised by those unable to access their health records in a timely manner in order to achieve a given outcome, mainly being as a result of information blocking. Through HIPAA and the 21st Century Cures Act, the federal government prohibited information blocking, designated durations for which these requests must be completed, and guidance on fees for accessing those records. However, the federal government has yet to promulgate a rule that would contain the enforcement mechanism necessary to provide financial penalties for violations of the new information blocking rules. Therefore, as no penalties are being pursued, there is no incentive for compliance. House Bill 3468 does what the federal government is currently failing to do by increasing state penalties in addition to the federal penalties. Overall, this law would give patients ownership of their health information and ensure their ability to access them in a timely and affordable manner. With that, I'm happy to answer any questions. Reserve the right to close.
Questions, members? We'll reserve your right to close and begin hearing public testimony.
Thank you.
The chair calls Judy Powell. Judy Powell. Adam Meyer. Okay, Judy's, that's Judy, I'm sorry. Right after her.
Okay. I rushed over from the other building.
Okay, I show you is Judy Powell with the Parent Guidance Center, and you're for the bill. Is that correct?
Yes, correct.
Thank you.
Hi, my name is Judy Powell, and I'm Communications Director and founder of Parent Guidance Center, a statewide nonprofit organization that helps parents involved with the child welfare system. I've been advocating for parents for 19 years now in CPS cases, and also consulting for their attorneys on these cases. Medical CPS cases are something that I've been taking up in more recent years, and so this bill is very important when you have a medical CPS case. Medical CPS cases include allegations of things like shaken baby, abusive head trauma, Munchausen by proxy, or medical child abuse, and fractures. Those are just to name a few. Oh, sorry, I'm out of breath. So in these kinds of CPS cases, medical records in this bill are vitally important for parents and their attorneys because records are the only way that a parent can potentially exonerate themselves and prove their innocence, get second opinions when necessary, or hire specialized expert witnesses for their case. In other scenarios outside of CPS, a person might need their records for other reasons, like parents with children with disabilities. They might need certain records for schools to prove out some of the special needs and accommodations. People with complicated medical issues, that some of the stuff you heard earlier, maybe they need to go out of state. I knew someone that took their father out of state for like a specialized prostate surgery that could only be done in Indianapolis, and they actually asked him to bring his radiology because they were having trouble getting it from the doctor themselves since they were out of state. And then there are new apps now that people can use, especially in complicated medical cases, where you need those records and they'll populate them and then they'll give you access. And so you can go to a doctor's office, pull it up, email what they need right then and there. So in real time, the doctor that you're seeing and consulting with can have those records. Over the years, I have literally never in a CPS case, and I don't use the word never very often, but I have never gotten the full record from a children's hospital in a CPS case. And I mean never. There are different games that hospitals play, and I feel like this is a really important bill, and I'm going to name some of those things that they do. Sometimes they'll completely block their parent and deny their record when requested. They will shut down or block parents from portals such as MyChart, and those keep valuable appointments that CPS and different attorneys need to prove out, different appointments that they needed, and that all disappears when they don't have the option to look at that portal. Another thing that happens is that hospitals will give the incomplete record, even though you've checked every box, I want everything, and they'll just give you a piece of it, and then you don't know till later if you have a consultant like me to say, no, that's not your full record, let's subpoena that and see what we get. Other times we'll get like paper copies when, bigger hospitals for years now, they've been under the federal law for EHR, electronic health records. So I laugh when I get a new case and I say, let me guess, your records are fuzzy, crooked, and scanned in. So anyway, these things are very important. One time in one of the lawsuits, the judge actually slapped down and said, I want this mom to have every record, even if it's on a paper napkin, because he was so angry that the hospital had not given those records. So the thing that happens in a CPS case when you don't get those records, you're delaying the reunification of a family. And so that is very important to families and children when they're separated in a CPS case, to be able to get those records, maybe get the experts and exonerate themselves when they've been falsely accused of child abuse. And so we feel like this is a really important bill. The bottom line is the federal law already says we need to do this. And so a bill like this is going to help states actually follow that federal law and stop them from not following the federal law. So it's the law, and this bill will help them follow it. Thank you.
Thank you. Questions, members? Thank you.
Thank you.
Adam Meyer. Up next will be Jackie Schlegel and Rebecca Galinsky. Please.
My name is Adam Meyer, and I'm in favor of House Bill 3468. Thank you, Madam Chair, Vice Chair, and members of the committee for giving me an opportunity to support passage of House Bill 3.
You're representing Cicero Action, is that correct?
Yes, ma'am.
Already, thank you, I'm sorry.
No worries. Thank you, Madam Chair, Vice Chair, and members of the committee for giving me an opportunity to support passage of House Bill 3468 by Representative Capriglione. I'm a senior fellow and legal counsel for the Cicero Action, a nonprofit that advocates for entrepreneurial solutions to public policy problems across the country. Prior to joining Cicero last year, I previously served as the Health and Human Services Cabinet Secretary in the state of Montana and also Kentucky. Texans want lower healthcare costs, better health outcomes, more convenient interactions with their healthcare system, and better access to care. Innovation, and innovation-driven competition will help Texas patients reach these goals, but the market can only foster these important outcomes if patients and clinicians have access to their health data and the ability to seamlessly transfer such data to whatever hospital, doctor, application, or insurer they choose to use. And once patients have access to the ability to transfer, patients may then provide their data to innovative companies, technologists, and cutting-edge applications that use those data to offer valuable and personalized services to patients. Electronic health record interoperability is critical to improving outcomes and efficiency in healthcare. Electronic health record, or EHR, interoperability means different EHR systems can seamlessly share and exchange patient health information. Benefits include improved patient care, reduced healthcare costs, increased efficiency, improved patient engagement. But some healthcare companies and healthcare vendors refuse to share information with patients or make it very difficult for patients to share that information with others. This practice is known as information blocking. Congress attempted to stop information blocking, and the 21st Century Cures Act, passed in 2016, but the necessary regulations to enforce that law have never been drafted in Washington, meaning the rules have no teeth. House Bill 3468 offers an immediate solution. Texas can make clear that patients own their health data and provide state-level enforcement to ensure Texas patients do not face information blocking and move Texas towards the goal of interoperability. In support of House Bill 3468, I would mention a few key points. First, patients want this. A survey conducted by Pew Charitable Trust found that 81% of American adults want providers to be able to share data with other providers. The majority of patients also want the ability to download their health records into an application on their cell phones. This bill strengthens patient ownership of their health information and enhances access for patients and those acting on their behalf. In addition to patients, many innovators and EHR vendors stand to benefit from improved access, which would increase competition in this market. Finally, the bill is aligned with federal standards and leverages existing state processes and infrastructure, mitigating any increased administrative burden for compliance. By incorporating the federal information blocking rules, it doesn't create inconsistent requirement for vendors. It also uses the existing complaints, investigation, and enforcement framework outlined in Chapter 181 of the Health and Safety Code that is already in place for patient privacy. Thank you for your time, and I'm happy to answer any questions you might have.
Questions, members? Thank you. Chair calls Jackie Schlegel, followed by Rebecca Galinsky. Good afternoon.
Hello.
I show you registered as Jackie Schlegel with Texans for Medical Freedom and yourself, is that correct?
Yes, ma'am. That's
And you're
correct.
for the bill.
I am. Thank
Great.
you. All right. I am the executive director of Texans for Medical Freedom, the state's largest and most active nonpartisan medical advocacy freedom organization. Texans for Medical Freedom is a member-driven organization dedicated to educating and advocating for all Texans' right to informed consent. We represent our diverse supporters who share our values with dignity and respect. We empower individuals to become politically involved, ensuring that our medical freedom remain a right that is free of consequence or interference from government or bureaucracy. In addition to my professional work as a medical freedom advocate, my true passion and drive comes from my experience as the parent of a young adult with complex medical and special needs. Throughout both of these experiences, I have personally mentored and advocated alongside hundreds, if not thousands, of families as they navigate complex bureaucratic institutions to find the best care for themselves and or their loved ones. At the heart of many of the issues of the families I work with are these medical records. These medical records are heavily utilized. I mean, I might actually say my life depends and revolves around these medical records in our day-to-day for patient care, communication, legal documentation such as guardianship, billing, reimbursement, state services, school intake, care coordination, long-term planning. These are essentials for families like mine who rely on a team of professionals to coordinate a comprehensive care plan for an individual with complex medical and or special needs. Having ownership of these health records that our families so heavily rely on provides a pathway to better health outcomes and quicker access to care. It will allow families to quickly and efficiently transfer their data to the appropriate provider. Time and efficiency improve health outcomes and are at the heart of appropriate care coordination. I believe that House Bill 3468 will improve patient engagement, empower individuals in taking ownership of their health care, and will encourage and strengthen individuals and their chosen medical providers to create personalized treatment plans. I'm very grateful to Representative Capriglione for bringing this bill forward, and I hope the committee will agree that Texans deserve ownership of their health records and vote yes on House Bill 3468.
Questions, members? Thank you.
Thank you.
Rebecca Galinsky. Rebecca Galinsky. Okay, is there anyone else wishing to testify on, for, or against House Bill 3468? Chair recognizes Representative Capriglione to close.
Chairwoman Clegg, members, thank you for letting me present this bill to you. At the core, what this bill says is that constituents, our voters, people in Texas deserve the ownership of their health information. This is already the law in New Hampshire. While there are federal laws to try and address this, they're not being enforced. By passing this legislation, we'll make sure that electronic health information, your medical records, belong to you. That I have,
Representative Jones.
I've got one question. When I was reading it, I see where it says that I guess a covered entity may ask for the patient to submit records either electronically or in writing, and they may not do it facsimile. My question is, what about people who don't have access to the digital divide? So will you always have the opportunity to do it in writing?
Yeah, we don't have facsimile probably because no one has a fax, and we want to make sure it's secure. We do have in the bill right now that if those records are in paper format, you'll be able to get the paper format version. If you have them electronic, you'll be able to get them electronically, right? So what we're trying to say is in the format that they're in is the format you should be able to plug it in.
So I guess my only question would be if I'm a person who doesn't have access to like a smartphone or a computer, I don't own a computer, so a thumb drive won't help me. Can I get them in writing? Not in writing, on paper is what I'm asking.
So the way the bill is that it would be in the format that you have it in. Because let's say, for instance, I don't know, you get an MRI or you get a CAT scan, and an MRI might be 20 gigabytes of three-dimensional, topographical information. So you probably can't get it in paper, you know what I'm saying? So what the bill does is says in the format that it's in. Obviously, if you go to the doctor's office and they write down a prescription and you get that kind of information, you'd be able to get that information because it's already in paper. Hopefully one day everything will be digital and easier to do. And even though it's not this bill, hopefully we'll get everyone the access that on broadband or otherwise that they deserve.
Thank you.
All right.
Any other questions, members? Ready? Thank you.
Thank you very much. I close.
If there's no objection, House Bill 3468 will be left pending. The chair hears no objection. House Bill 3468 is left pending without objection. The chair lays out House Bill 4758 and recognizes Representative Theory to explain the bill.
Good afternoon, Madam Chair and members of the committee. I'm here today to bring your attention to a matter of rising concern amongst parents, schools, and the medical community. That issue is the alarming and rising use of vaping products by children. Vaping among Texas high school students has increased by 135%, and more than 1 in 5 Texas high school students are now reported as smoking e-cigarettes. Even more alarming, over 20% of middle school students in Texas have already experimented with vaping. House Bill 4758 takes decisive steps against this rising epidemic that is afflicting our youth. It should also be noted that coincidentally with these rising statistics, there has been a strategic and overt marketing effort of vaping products targeted to entice children. This bill seeks to correct this problem by encouraging responsible marketing. Specifically, members, I hope you have the one-pager that's been passed out in front of you. If you take a look at it, you'll see that various e-cigarette manufacturers are packaging products containing nicotine to appear nearly identical to candy, juice boxes, and other treats that highly appeal to children. The intentional similarity in packaging between e-cigarette vapor liquid and edible children's snacks, such as cookies, milk, and apple juice, are a direct appeal to our children to begin smoking and ingesting these substances. This bill would prohibit the marketing of certain e-vape products which contain cartoon images and packaging designed to resemble candy, food, or juice, and designed to appeal to children. While this legislation is only 1 page in length, it has the ability to save thousands of children from the harms of use of nicotine addiction. The Texas legislature has already demonstrated leadership in regulating cigarette retailers. It is now time for us to take the next necessary step with the passage of HB 4758. Oh, members, I want to pause. Did I say I was laying out the committee substitute?
We don't
Oh,
have
you
it.
didn't?
Yeah, but you can talk about it and explain what the substitute is, but we don't currently have it.
Oh, I'll skip it then. I thought you all had it. Okay.
You can explain the changes you're going to make
Okay,
to
let me
it.
make sure I have them. Well, I digress. I'll lay out what the bill does, and then I'll go through those line by line. Members, in summary, HB 4758 represents an important step forward by encouraging responsible marketing and strengthening the regulatory framework of e-vape products. This bill will help reduce the potential harms associated with vaping use and promote public health. And with that, members, I reserve the right to close. Oh, I do have the changes, if you'd like me to talk about them.
Okay.
Thank you, Madam Chair. The committee substitute amends the relating to clause to include the advertising of certain e-cigarette products, and it replaces each word that said container for the word product. The new amended language prevents retailer from marketing to advertising, and it basically clarifies the intent of the legislation. It also substitutes the image of a celebrity and image of a food product in the list of prohibited characteristics of an e-cigarette container. And with that, members, I reserve my right to close.
Representative Tinderholt.
Thank you, Madam Chair. How are you today?
I'm doing well, Representative Tinderholt.
Good. So I want to be clear because I've talked to several people about this. When I first saw this, I thought it was specific for flavors. It's not flavors, is that correct?
No, sir, we're not prohibiting the use of the flavors. That issue has been taken up federally, but it has not been decided, so I didn't want to overreach. There are adults that like the flavors. This is actually, it's not what's in it, it's the outer packaging. If I may, I want to show you something, members, and I can pass this around. For example, this is called Candy King. Then this is the least of what's out there. It literally looks just like the Sour Patch. My daughter saw it because I bought this to bring it to you all, and I had it on my island, and she was about to drink it. She grabbed it immediately. And she's like, oh my God, I want this. And I was like, no, Claire, this is a harmful cigarette product. Now, it does say it contains nicotine, but it's literally called Candy King. There was another one I saw called Cookie King. There was another one called Peanut Butter Monster Jam. If you look on the one pager, there's even one called Mother's Milk, made by Suicide Bunny. They put the emu girls on there. They put all kinds of cartoon images. I mean, it's really, if I may be frank, quite sick. But had my 10-year-old daughter drink this, she would have died. She cannot open this. But when I told her, she said, God, it looks delicious. So we know now that why middle schoolers and high schoolers are so attracted to these products. The names of them alone. And so to answer your question, Rep. Tinderholt, it's not solely what's in it. It is just the packaging and the systematic marketing of the products to kids that we're trying to prevent. Thank you, sir.
Other questions, members? All righty, we'll reserve your right to close and begin public testimony.
Thank you, Madam Chair.
The chair calls Charlotte Owen. Next on deck will be Daryl Sarif.
Hi there.
And I show you registered as Charlotte Owen
Correct?
with the American Vapor Manufacturers Association.
Yes.
And you're for the bill, is that
Yes.
correct?
Yes.
Okay, please begin your testimony.
Okay, I didn't know this was going to be heard today, so this is kind of off the cuff, but I represent manufacturers across the country, and we try very hard to be good actors, and we are absolutely for smart and good packaging. Our whole goal is to stop people from smoking, not indoctrinate another set of smokers, or vapors. So we are absolutely for it. I have not read the committee sub, but Representative Theory has been very good at working with us on this. So we have a meeting next week, so she's doing wonderful. Any questions?
Questions, members? Ready, thank you.
Thank you.
Daryl Surratt.
Good afternoon. My name's Daryl Surratt, and I am one of the manufacturers that manufacture heavily in this business. My company generates over $500 million in sales based right here in Austin, Texas, and we sell worldwide. We've all made mistakes, and we correct them. I'm here to support this bill 100%. More importantly, Theory, I want to thank you because what you're trying to do here, the federal government has tried to do, and they failed miserably. So right now, my question would be, let's pass it, but then what does enforcement look like? Because without it, it won't do us any good.
And you're representing the American Vape Corporation?
American Vape Company, which is local. And as I said, we're a big player in the space, and we try to do everything right. We do believe in helping people stop smoking, but we are fighting an uphill battle with this packaging. We want it gone. We fought to get it gone. We're a great resource to help people and show what the industry is meant to do, which is not to sell to minors, which is only to sell to people that are trying to quit combustible tobacco.
Questions, members? Thank you.
Thank you. Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 4758? The chair recognizes Representative Theory to close.
Thank you, Madam Chair. Members, I'll just be really brief. This bill amends Subchapter H, Chapter 161 of the Health and Safety Code by imposing limits on the use of targeting techniques that appeal to younger audiences. For the public health aspect, members, the limitations are positioned to tangibly decrease adolescent e-cigarette use in order to decrease the adverse health effects of nicotine addiction, heart disease, lung damage, bronchitis, and something that you may have already heard of called popcorn lung, which is a direct product that kids are experiencing now, and cognitive defects. So with that, members, and to answer the gentleman's question, the teeth behind it would be a Class C misdemeanor. And with that, I would love to have this committee's full unanimous support, and I respectfully close.
If there's no objection, House Bill 4758 will be left pending. The chair hears no objection. House Bill 4758 is left pending without objection. The chair lays out House Bill 4481 and recognizes Representative Smith to explain the bill.
Thank you, Madam Chair. May I sit here? Thank you.
Certainly may.
Members, Madam Chair, Vice Chair, in prior sessions, we have worked hard to pass laws that help keep nicotine products out of the hands of children, while also exploring ways to keep potentially harmful products off of the market. HB 4481 creates a definition for alternative nicotine products, also known as ANPs. These are nicotine products that do not fall under cigarettes, e-cigarettes, or other tobacco products that are currently found in statute. Creating this definition and placing it with the list of statutory requirements of other tobacco products and e-cigarettes will prohibit sales of ANPs to persons under age 21, require sellers to check the photo ID of ANP purchasers, add ANPs to the signs required at all retail locations, making clear that the minimum age of purchase for ANPs, like tobacco products and e-cigarettes, is 21. Prohibit self-service displays of ANPs, and prohibit distribution-free samples of ANPs or coupons that can be used to obtain free ANPs. In an attempt to prevent the sale of unregulated and potentially dangerous products in stores, HB 4481 also creates the e-cigarette and alternative nicotine products directory. This would require manufacturers of e-cigarettes and alternative nicotine products to submit a certification to the Texas Comptroller's Office confirming that, 1, the manufacturer agrees to comply with the state's existing tobacco product regulations and the Health and Safety Code, and 2, the manufacturer's e-cigarettes and AMPs are in compliance with marketing authorizations requirements imposed by federal law. To be listed in the directory, manufacturers of e-cigarettes and AMPs would be required to pay an initial fee of $1,000 per stock keeping unit and would have to pay a fee of $1,000 per SKU annually in subsequent years to retain their listings. The Comptroller's Office would use all fees collected to pay for administration and enforcement of the directory, including by making block grants for local law enforcement agencies. After having discussions with interested parties and business owners, there have been good conversations on the possibility of tweaks to this bill. To be very clear, the intent of this bill is to ensure that no harmful products are sold in stores while making it harder for children to gain access. I look forward to further discussions on how we can make these goals a reality. Thank you for your consideration, Madam Chair. I believe there may be some testimony, and I reserve the right to close.
Questions, members, for the author? All righty, we'll reserve your right to close and begin public testimony. Chair calls Charlotte Owen. Next will be Daryl Sarif after Charlotte Owen. I show you registered as Charlotte Owen, the American Vapor Manufacturers Association, and yourself, and you are registered against the measure. Is that correct?
Correct.
Okay, please begin your testimony.
My name is Char Owen, and I'm the president of the American Vapor Manufacturers Association. I'm here in opposition to Bill 4481. This bill is a vendor bill and will close all shops and small manufacturers in Texas. This bill is a tax to remove small business. It relies on the FDA, which has proven its inability to manage the PMTA process that it created. They have increased their numbers from 500 to 1,100 employees and still can't handle the submitted PMTA requests. Some manufacturers that filed in 2020 have heard nothing from them or were rejected based on errors in FDA forms. We will fix our form and you'll need to reapply is their response, but that will put you back at the end of the line for review. The U.S. House Oversight Committee is investigating the FDA and found the FDA had not clearly defined the most basic elements of its tobacco and nicotine regulatory programs. Chairman James Comer expressed deep concerns that the FDA's decision had been influenced by political concerns rather than scientific evidence. I have helped over 200 file at least part of their PMTA and have seen this happen personally. Texas cannot currently rely on them to decide if Texans lose their businesses or their jobs. The fiscal note says it can't be determined, but if approximately 3,000 small businesses close, that's a negative for Texas. Also, a directory would not help the comptroller find clones. Clones have the same names, packaging, and everything is identical, so the comptroller would need to come in, pull the product off the shelf, go to the manufacturer's website, type in the number for every product. When the manufacturer responds back, that's the only way to tell if it's a clone. A clone manufacturer is not going to register. Measures can be taken to reduce clones on the market and lower youth use in Texas, and the AVM would support those, but this bill doesn't do that. We applaud Texas legislators for making a significant difference in youth vaping in Texas without passing regulations that would close Texas businesses. A 50% decline in youth vaping from 2014 to 2022 is an accomplishment to be proud of for us. I am from Texas. My fourth great-grandfather owned property right here on the Capitol, Samuel Gocher. I take it personally. Texas is my place, and I'll protect that. But this is not the bill for that. Thank you for your time, and I welcome any questions you have.
Questions, members? Representative Tinderholt.
Thank you again, Madam Chair. How are you today?
Good.
You know, we've known each other a while. You brought a whole bunch of hand sanitizer to law enforcement up in our area, and I want to say thank you for that because I never got to thank you.
You're welcome.
How many products do you have specifically? Like how many flavors?
We only have roughly 60 products. However, by the FDA's definition, that would be 36,000 SKUs.
So how much would it cost you to keep your business open as a small business?
Roughly 4 million, and we gross about 400K per year.
And,
So as soon as the bill is enacted, we are gone.
and I want to be clear, you know that I've never smoked, I don't do this stuff, but I'm a small business
Yes.
champion. I like small business. It's about 80% of Texas economy is small business. So I have a guy in my district that has about 300 flavors. I don't know how many SKUs he has, but if you just did the flavor alone, that'd be $300,000. Is that?
Unobtainable, yeah.
And so I think my concern is, and I think you guys have concerns, with the PMTA and with the $1,000 per product, right?
Mm-hmm.
So I haven't talked to the author yet, and we'll talk later, I'm sure, but I'd almost like to consider something with PMTAs, if you're submitted with the PMTA, that you can be on the registry while you're awaiting your stuff to come back. But then comes the $1,000 per product. And maybe you can help people understand, I'm just gonna use non-scientific, non-vape terms, because I just don't know.
Okay.
You buy the stuff, the juice, whatever it is that you smoke.
Mm-hmm.
I think the bill is intended to try to make sure we're not buying that from China or different places that's not FDA tested and
Right.
it's not healthy. So if I get that stuff brought in, and I don't care if it's a vial or a 50-gallon barrel, I almost think that should be one SKU. And then
Be a brand, yes.
and then the drops that go in it, because I've watched the person, I was so intrigued, I wanted to go see how they do this business, and he's very involved politically and wanted me to come see it. All the droppers, the flavoring came from pretty much one source.
Mm-hmm.
But he'd have to do 300. And I'm guessing there'd be more SKUs than that somehow, some way. But at a minimum, he'd get charged $300,000. And I'll tell you, when I was in his business, I'm not gonna say who it is because I don't want him to get offended, but I'd be surprised if he takes home 50 grand a year for himself. He does it because he's really involved in that community.
I haven't taken a paycheck from my business in over a year.
So I think I'm getting to a question for you. If something were done with this bill where if you've submitted for PMTA and it's in wait,
Mm-hmm.
and if there were more reasonable ways to charge the $1,000 per product instead of the way that you and I have just talked about, would you be opposed to having a registry to keep the healthiest it can be, right? Healthy product that you know has been tested, that is not gonna be stuff from overseas that's significantly worse?
We would love that. We would also like other measures so that way we could,
So tell me what those, you and I haven't talked, I'm just curious,
Right,
what other measures?
another measure is very similarly, you could use some kind of a stamp or whatever to clarify that was an approved product. But yes, you are right. If they're in the PMTA process, they are a good actor in the industry, and that we approve of wholeheartedly.
Is there anything else? The reason I'm saying that is it's always good to try to get people on board with a bill like this. So when it gets to the floor, you can get as close to 150 votes. And I think vendors being involved and making sure it's safe is important. Is there anything else that you can think of that would make this a better bill, that would make you more excited about it passing?
I think we should be doing the fee for that should be by brand, in other words, for company. It is very difficult, even if they have 100 flavors, they could be a very small mom and pop shop. And 100 recipes is not out of the realm of possibilities, and so you're asking that person to have $100,000 on hand, and as you say, they probably will not have it.
And that's what I was saying, like if it's the same manufacturer of all the flavors and the same manufacturer, a different one for all of the what is that stuff called, by the way?
E-liquid.
What is it called?
E-liquid.
I won't remember that. I just want to find a way that's healthy, that's safe for a registry, where it doesn't destroy small business.
I would say by brand would be, the best way to go about it, because if I walk into a place and I see, Bob's E-liquid, and that's on the registry, I know I'm fairly, they're in that PMTA process, and that gives me more of a warm and a fuzzy. That means I've at least attempted to go through the FDA's. The FDA knows my recipes. They know what I put in that bottle, and they'll flag that bottle right away, and flag that right away, and it'll come off the market. So as long as they're inside of that PMTA process, I think that's where that PMTA portion lies.
And when we talk through this, and you and I will probably talk later, and I'll talk with the author, but I want to make sure there's a significant decrease in the ability for someone to cheat too. So just kind of think through that on whatever's done, because if we're going to have a registry, we want it to be valid and health conscious when we do it, so.
And that's us. We really don't like bad actors in the field. It's a black eye for us. So we don't want them either. We don't want China just putting things over that aren't filed, because that's our black eye.
Right.
Every industry has them, but we'd like to stamp ours out as much as possible.
Thank you for answering my questions.
You're welcome.
Representative Smith?
Yes, ma'am. Good to see you again.
You too.
And I appreciate you coming by my office as well to discuss these issues. It's been very helpful. Just to make sure we're all on the same page, what's your understanding of what a stock keeping unit is?
A stock keeping unit.
A SKU?
Oh, a SKU. Okay. So a SKU, if we're talking FDA terms, a SKU is any recipe that could be any size, any nicotine strength. But if I have whatever, if I have apple, if I have that in 30 mil, a 10 mil, a 60 mil, a 120 mil, those are all different SKUs. And if I even have that in a 0 nicotine, that is, again, a separate SKU. So it doesn't have to even have nicotine in it to be a separate SKU. I could have 5 different nicotine strengths, 5 different bottle sizes. So every recipe that I have, you now have that 15 times. So, and that is clearly defined by the FDA. That's not how I interpret it. That's how they interpret it.
I see. Okay. And so that's how you're arriving. So you have this many of these variations in your shop that it would be,
Yeah.
how much?
36,000.
36,000. Okay.
Even a different bottle type. We have 2 different kinds of bottle types. One would be PET, which is very hard, and one is softer LDPE. Both are child resistant, but even a different bottle type in the FDA's eyes, those, if I use the same one, now I don't have 15, I have 30, because if I have 2 different bottle types, the bottle type is another SKU as well.
Okay. Well, I appreciate your attitude about the necessity or the need for this. So working towards that end, do you have a suggestion as to what type of fee that would be fair?
Well, I think per brand would be the way to go most of the time. In other words, if I walk in somewhere and I see a brand, I can check the registry. Okay, and you heard Escobar's testify, is Escobar's on that registry? And if I, as a retail establishment, want to purchase an Escobar's and have it in my shop, I can go to that registry, look, yep, they're there, so they're okay for me to sell. I know it gives me some confidence. So by brand would be, I think, completely acceptable.
Okay. So, but, and I don't operate in this world, but tell me, so how many different variations are there, let's say, in connection with the average brand?
Generally, a brand will only have 1 or 2 brands. You may have a black label brand, or you may have, but most mom and pop small shops have 1 brand. Some have several, but, for the sake of saving money, I'm sure they would condense that. But mostly you'd have 1 or 2.
Okay. All right. Thank you for your time.
I have another question, ma'am.
Representative Tinderholt?
Thank you. So I'm trying to wrap my head around this too, because you don't vape, I don't think, right? No. So we don't vape. We're new to this.
Okay.
So am I hearing that, let's just use the guy in my town that I talked to, John. A brand might be that he ordered the what's that stuff called? E-liquid?
E-liquid? Mm-hmm.
He might have bought 2 different e-liquid sources, and he's got 300 flavors that are black brand and then 300 just regular. So he would have
2 brands,
2 brands for all 600.
yes.
How do you keep him, the individual, from importing fake stuff after he gets registered? I think that's the key, is how do you make sure that the stuff they're selling is not Chinese imported stuff that's never been tested? Like,
That's kind of the problem with the bill. It doesn't do that. It doesn't address that at all. So that's kind of the problem with the bill.
but I think that we agree that doing something is
You would have
important.
to do something with the package. So they would have to be issued something for the package.
So the store would be issued something for every one of their products, but then would
Or
you need an
manufacturer.
enforcement arm with
For
it?
the manufacturer, yeah.
Would there have to be an enforcement arm? I'm,
Oh, absolutely. The comptroller would absolutely need to enforce that. So, that's another negative event that will happen is it's gonna be a financial thing. Because when you're talking about the $1,000 and the $500, technically for us, that would be a new tax for us that we would pay yearly. And that would hopefully offset some of the comptroller's cost. for
so when
doing
you talk about that, real quick, so if you have the 2 brands, black and the other 300 flavors, I might have 150 flavors over here, but I have 10 sizes of each, so that's 1,500 SKUs. And if you did something different, to add something a little different to them, that would add more SKUs every single time. I'm guessing, I don't think the author wants to put anyone out of business. So I think as we're asking questions, I'm talking to everyone out there, as we're asking questions, I think the key is gonna be to find a way to do a registry that's solid, that protects people, at the same time that doesn't put people out of business.
Yeah, it's extremely hard when you're talking about things like this because it's hard to legislate bad actors because they don't generally go by the rules. So you have to kind of find things like packaging because you're not just talking about walking into a vapor shop, you're talking about every convenience store has them. It's a huge swath of a lot of industries. So the comptroller's gonna also have to enforce this at all the convenience stores as well.
But the good news is the bad actors probably aren't here today, you are.
You're not.
And people like you that are here that can help this go from good to great, right?
We try.
So, thank you.
Thank you.
Any other questions, members? Okay, thank you for your testimony. The chair calls up Daryl Surf.
Thank you. And it's Daryl Surf. Kind
Surf.
of hard to pronounce, but it's there.
Daryl Surf.
Thanks for having me again. And I want to talk about this particular bill.
Sir, you're here and you're neutral on the bill, is that correct?
I'm for the bill with some changes.
Okay, hold on a second.
If somebody can convince me. This is my first time here, so if I
Well, you-
check
you
neutral and I
registered-
shouldn't have, then I would be for the bill with
Okay,
changes.
but you registered as neutral.
Okay.
So are you neutral or are you for this?
written.
I'm-
As
Written and before.
I'm for it with changes.
No,
As written.
I'm against it then.
No,
no.
as written
As-
and before
as-
us at this moment.
As
What-
written
what's
as
his position?
before this moment, what is your position?
Against.
You are against it.
I'm against.
And he gives me permission to change this.
Do you give us permission to change it?
I do.
Okay. And can you confirm who you are here on behalf of?
I'm Daryl Surf. I'm here with American Vapor Company, and I'm a manufacturer and an owner of one of the largest brands in the country.
Okay.
So I want to start by saying this particular bill is devastating to small business, as was discussed. We were a small business. We started 11 years ago with $13,000 in cash and $15,000 on a credit card. Today, we do over $500 million this year, $500 million last year. So we're fighting for our lives right now. What I would tell you is, as a big business owner, which we are now, we have 200 employees in the United States, and we have well over 1,000 in China. When we talk about China, we have to be very careful because it isn't just China. They make great quality. My facility is bar none the best pharmaceutical lab grade you could ever see. So I just want to suppress that. When we talk about why we're here, it's about the registration, and the FDA did do a PMTA and a registry right there. The problem is the FDA has not enforced any of it. So we're being flooded with all the child marketing, illegal products, and people that just frankly don't care what the government says. They still import it because they're making millions of dollars in imports, and there's very little damage done. When you do a pre-market tobacco authorization, you're saying I'm a good player and I want to abide by the laws. And what that includes is you have HPHC testing, which is your chemicals for the harm that could be caused when the product heats up, but chemicals inside it and everything. And then you have longitudinal studies which address the youth vaping. My company has spent $7 million this year just to try to abide by the government rules. That doesn't count the lobbyists that we pay for these kind of things. That's just the government, PMTA, HPHC, and longitudinal studies. So we're heavily vested, $7 million, and it's an ongoing battle. Personally, I want to thank lawmakers responsible for bringing something to the floor like 4481, but it needs changed. The FDA has failed to do it. We need to get it done. Foreign manufacturers and USA brands that could care less about the FDA laws is what's causing all these bad products to enter the market, and we need to stop that. We all know about the Elf Bar and the debacle. They were removed from the market, but not because of registration, because of a trademark issue. When we talk about these bills in the registration, it's extremely important because if you're going to register, you have all our data and you know that we're going to comply with what we want to do. $7 million is a big number. When we talk about this, it's at a crisis level because we don't want anyone to go out of business, but we also want to fight for the business. And when we talk about it, what's most concerning about this bill is I'm not real sure who authored the whole thing or who's behind it, but it looks like a bill written by Big Tobacco because it's designed to wipe out all the small businesses, including this big one right here, because of the funds, the $1,000 per unit. That would cost me, with my company, well over $2 million to register those numbers. It's not doable. When you think about Big Tobacco, that's what caused the whole crisis with combustible tobacco. Now they want to write bills that give them the savior, what helps people get off combustible tobacco. And I'm not for that. What I'm for is complete regulation, but smart regulation, and more importantly, enforcement, because the enforcement is not happening at the federal level. We have to deal with clones constantly, which are poor quality devices, because the government's not stopping it coming in. So that's through United States Customs. So the more registrations that we have or registries within the state level, we have more resources to come at elected officials and say, hey, we have this law. How can I help you enforce this law? Because right now it's not being enforced. And there's a lot of problems. We need this fixed. So there's room for everybody here. What I'm here to say is we need the registry. We support the registry. We don't support 1,000 per unit. We do support a reasonable amount. And then probably the most offensive thing in here is the $1,000 penalty. Who cares? We're talking about millions of dollars. A $1,000 penalty will not stop a thing. The Chinese companies today, the FDA, if they give you an MDO, it's $19,000 penalty per SKU. Who cares? They still don't care. Because if you're like me, you're manufacturing and selling $500 million, I'll pay you $19,000 penalty all day long if I'm a bad player. So if we're gonna have a bill, it has to have teeth. These are not teeth in any way, shape, or form. This is a free get out of jail ticket for $1,000. Make sense? But to reiterate, we're for registry. We're not for the destruction of all the small businesses that have fought hard to provide this alternative solution. We would like to be a part of the solution. We'd like to help any way that we can, and that's why I'm here.
Thank you, sir. Any questions? Representative Smith?
Mr. Sheriff, thank you very much. I'll say the same thing to you that I said to the last witness. I appreciate your attitude about this bill, and I appreciate you coming forth with some detailed complaints about it. Given the fact that there's going to have to be some type of enforcement, and that enforcement's going to cost money, and sometimes these fees help us pay for it, not only the setting up of the directory, but also the enforcement. Do you have any idea as to what would be reasonable on a per SKU basis?
You know, per SKU is very difficult. I wish the state would just come up with a sales tax for a vape. That's the bottom line, because the more you sell, the more money the state's going to generate. Then they can take care of these agencies, the comptroller, whoever it may be. Louisiana, they use the state troopers as the enforcement. I own retail there. You don't mess around with Louisiana. So Texas should be a lot better than Louisiana.
Okay.
But you don't mess around in Louisiana. They have the enforcement. To answer your question, I don't know a per SKU price. I think it should be maybe based off of the brand, based off of revenue generated as a percentage. I don't know the answer to that, but without funding that, no enforcement, this would be worthless either way. So we have to fund it, and I'm game to fund that at whatever my fair share is, as long as the state is guaranteeing we're going to have enforcement. That's my biggest concern. I visited with the FBI and many other agencies about the fraud that's committed in this industry, and it's all on deaf ears. So it's very concerning to me. It's a huge fraud.
All right, now there is
100%.
a provision in here concerning the penalty that you addressed a moment ago as being inappropriate or
Yes, sir.
lacking. To make sure we're on the same page here, it says in the last sentence of the paragraph dealing with that, it says each sale of an e-cigarette or alternative nicotine product that is not listed in the directory shall constitute a separate violation.
Yeah.
And were you aware of that?
I am aware of that.
Still
but
think that's inadequate?
The problem is a major company with a major brand may only bring in 5 SKUs. That's it. Or one device, one SKU, 10 SKUs because it's 10 different flavors. If you're going to allow me to do that and I can pay a $10,000 penalty, I'll buy you a steak at the same time.
Okay.
Because that's how bad actors are. That would not be adequate. 1,000 per SKU is not adequate.
Even for the business that actually sells it on the ground?
The business that sells it on the ground, absolutely, you're right. A local store, $1,000 penalty per SKU, that's fine.
Yeah.
The big picture is not the small stores, it's the big distributors and the multi-million-dollar warehouses that are housing millions of dollars of illegal product. Even under today, they never filed for a PMTA and they have no intention of filing. They're taking it for all the money they can, and nobody's acting on that. Today, I can give you a list of those places, and if you charge them $1,000 each, that'd be great, but at the end of the day, it's just a car to them.
Yes.
It's just $100,000. It needs to be there may be differentiation between a retailer and an importer, wholesaler, and distributor. Because the importer, wholesaler, and the distributor are the ones breaking the laws at the massive level. The stores are the ones that are trying to do it right. The distributors that are just lining their pockets, they don't care about $1,000. It has to be much greater. I'd say lock them up. I don't care. I mean, I'm passionate about this, and I apologize, but my brand is cloned. In the U.S., fighting a clone, even with trademarks, is difficult because we're in a business that not everybody likes. In China, I have an arrest within 2 weeks the moment I find them. They're sentenced to jail within 90 days, and they get 3 to 5 years. We don't get that here. And those are the same people that are bringing in defective products and dangerous products. And it needs to stop.
I understand. Well, thank you.
Thank you.
Other questions, members? Ready, thank you.
I was just getting ready. Thank you.
The chair calls Desiree Castro. Next on deck will be Holly Veal. Good afternoon.
Hi, good afternoon. I'm Desiree Castro with the Texas Food and Fuel Association, and I'm here to testify in support of HB 4481. Our members own, operate, and supply over 12,000 convenience stores. And so a product directory for e-cigarettes and alternative nicotine products, this will help retailers understand what products comply with state and federal law. And right now, there's many illegal products on the market. And so, retailers they need a mechanism and they want to understand, make sure they're in compliance. And so this bill would do that, and so that's why we're very supportive of it. And we appreciate Representative Price for filing this legislation.
Questions, members? All right, thank you.
Thank you.
Chair calls Holly Veal. Next on deck will be J.R. Gonzalez. I show you registered as Holly Veal with Cormark, and you're for the bill, is that correct?
That is correct.
Thank you. Please begin your testimony.
My name is Holly Veal, and I'm here today on behalf of Cormark to urge you to support HB 4481, a product directory in Texas. Cormark, headquartered in the DFW area, employs over 900 Texans and distributes nearly 10,000 SKUs to more than 3,000 locations in the state of Texas. Although vape and e-cigarette products have been shown to be substantially less harmful than traditional combustible cigarettes, consumers continue to face unnecessary risk due to the confusing landscape of approved products. In addition, the complexity and lack of enforcement has created a competitive disadvantage to law-abiding corporate citizens and allowed the demand to funnel into non-compliant products serviced by smaller distributors who lack the resources to validate legality. Currently, many vapor and alternative nicotine products in the Texas market are in violation of the FDA law. These products are hard to discern for retailers and consumers due to the sheer number that have been rejected and still remain under review by the FDA. The adoption of a product directory in Texas will allow responsible distributors and retailers to know what's compliant and what's not. In addition to protecting consumers, a product directory would facilitate an equal playing field for all distributors in the state and protect Texas businesses from federal enforcement for unknowingly distributing or selling non-compliant products. Right now, we have no clarity and may be enforced against at any point. This proposal is good for Texas because most distributors in our state want to abide by the rules. We just need a mechanism to understand what products are legal for distribution and sale. The product directory will provide wholesalers with the information we need to ensure that we are distributing compliant products and avoid penalties. The proposed product directory will also help fund the equitable enforcement across the state. Registry fees and violation fines will help support enforcement efforts needed to ensure that all distributors are compliant, the only way to ensure that consumers are buying approved product. An organized and regulated market will facilitate the long-term sustainability of a category that, as mentioned before, has been shown to be substantially less harmful than traditional combustible cigarettes. In conclusion, I urge you to support HB 4481, a product directory in Texas. It will create an equal playing field for all distributors and retailers, providing industry members with information that they need to distribute and sell only compliant products, and help fund the equitable enforcement of those efforts. Thank you.
Questions, members? All righty, thank you. Chair calls J.R. Gonzalez, followed by Shell Hamill. Good afternoon, Mr. Gonzalez.
Good afternoon, Madam Chairman and members.
You registered on behalf of the Texas Association of Mexican American Chambers of Commerce and yourself,
Yes, ma'am.
and you are for the bill, is that correct?
For the bill, that's correct.
Thank you. Please begin.
As introduced, J.R. Gonzalez with TAMAC, the Texas Association of Mexican American Chambers of Commerce. We are a statewide organization that is 48 years old. Now, as we look at this bill, we are in favor of it because, one, we just want to make sure, first and foremost, that people are safe. We're not against business, and we're a chamber of commerce. We just want to get it regulated. As e-cigarettes is the second largest tobacco form in the United States and continuing to grow, it's like the wild, wild west out there. You just don't know what you're getting. So we believe we have some sort of registration, some categorized. You're going to have bad actors. No matter what situation you have, you're going to have bad actors. But if we don't start taking steps to start regulating, who knows what's going to happen? I say who knows what's going to happen. One, I'm concerned about not only the health of our consumers, but also the growing product and what it's going to incur. If there's no regulation whatsoever, Granted, there's a lot of stuff that's not in place yet and a lot of improvement that needs to be done, but if you just let it kick the can down the road and don't do anything, it's just going to get worse. Now, I know, like a lot of you, have been very fortunate to have traveled in different parts of the world. I'm very careful when I consume a product and when I'm in a foreign country. When I'm in the United States, I have some degree of peace of mind and confidence that what I'm consuming is going to be safe because there's FDA, there's regulations, there's things in check. So all I'm asking is that with the registry, with some sort of degree of regulation and some degree of check, that our consumers not only know that they're getting a safer product, but retailers also who do not want to participate with bad actors, at least they know too that they're getting a product. What that actual regulation looks like, I'm not quite sure, but there has to be, as said earlier, there has to be some teeth in it. We have to get some regulation, and whether it be something as simple as a stamp to go in on the different lots, there has to be something that this stuff is regulated. If it's not regulated, it's just going to get worse.
Questions, members? Thank you.
Thank you very much.
Shell Hamill. On deck next will be Kathleen Russell, followed by Greg Wilson.
Good afternoon. My name is Shell Hamill, and I am the National Legislative Director and the President for the Texas chapter of Smoke-Free Alternatives Trade Association, otherwise known as SFATA. And we are against the bill. However, we have reached out to the bill author and hope to continue to work with them on this bill. Thank you guys for hearing this, Chairman Click and Chairman Smith and the rest of the committee members. Serious concerns with this bill. HB 4481, if passed, would decimate an entire industry in the small business arena, eliminating over 10,000 jobs and over 100,000 in tax revenue for the state. Furthermore, the fiscal note that's attached to this bill that would be minimal for revenue based on these losses. In 2021, the FDA issued marketing denial orders to millions of vapor products in the U.S., all within a very short period of time. This was clearly a rubber stamp denial method, as later many lawsuits ensued. And the FDA has indicated that it will undertake a more thorough review of the products denied through this mass denial process. Many of these lawsuits are still pending, with several courts forcing the FDA to conduct new reviews of the company's PMTAs, which is a pre-market tobacco application. The FDA has only officially approved 20 products to date. Many of these products are big tobacco and your smaller, other small tobacco. In February of 23, the FDA announced a new CTP, Center for Tobacco Products Director, and a new FDA commissioner. The new commissioner announced a plan to improve the review process of tobacco and vapor products, promising better communication and transparency on product reviews. This was in response to a recent report released by the Reagan-Udall Foundation that recommended that the FDA clarify its rules regarding oversight and e-cigarette reviews, including its shifting scientific standards that vaping manufacturers say have undercut their applications. This report from the Reagan-Udall Foundation shows glaring proof that the FDA has failed in its job to correctly review these applications, as well as provide guidance for small businesses. Furthermore, 3 members of the Committee of the Oversight and Accountability have submitted letters to the FDA asking them to address this very issue regarding the review process and the MDO's market denial orders that were given specifically. As you can see, the onus is on the FDA to improve its product reviews for these applications. SFATA members have always been good actors in the industry, and they've gone through the pains of PMTA submissions, spending an enormous amount of money, countless hours at a computer submitting data, science, product evaluations, ingredients, and seeking legal counsel as well. We believe that this bill is premature until the FDA has improved its processes and conducted fair reviews of these applications. Clearly, they need to, as my grandfather would say, lick this calf over again. And and I think that I would ask the committee to please allow this new commissioner the time to do that.
Your time has expired. Questions, members? All righty, thank you. Chair calls Kathleen Russell. Next on deck will be Greg Wilson. I show you registered as Kathleen Russell, and you're representing yourself, and you're against the bill. Is that correct?
Yes, ma'am.
Okay, please begin your testimony.
Okay, well, first, I'd just like to thank you for allowing me to present my testimony today. I'm a small business based out of Burleson, Texas. 10 years this year will be my anniversary, so I'm pretty proud of that. I'm also registered with the FDA as a manufacturer. This is a really difficult process. It's expensive, it's time-consuming, and it's stressful. But I'm proud to say that I was able to at least get started with this process, and I take it very seriously. Our goals always have been to keep this out of the hands of minors. So everything in the first part of this bill is absolutely I'm in agreement with. But the fees that I've had to pay just to test a single product for the FDA is already at least $2,500 per product I have to register. And so adding an additional $1,000 to every product I've already registered with would just be an additional financial burden, unfortunately. And it's already just such a struggle for us to have to jump through these hoops with them. I guess thank you for hearing my testimony today.
Questions, members? All righty, thank you. Greg Wilson. Good afternoon. I show you registered as Greg Wilson, and you're representing Altria Client Services, and you're neutral on the bill. Is that correct?
That is correct.
Okay, please begin your testimony.
Thank you, Madam Chair, members of the committee. My name is Greg Wilson. I'm the Vice President of Regulatory Affairs for Altria. Altria does not currently have an e-vapor product before pending in the PMTA process with FDA. However, we do have what this bill calls an alternative nicotine product, and I actually spend most of my days working on tobacco regulatory issues, and I heard a lot of questions about the PMTA process, excuse me, and I thought it would be helpful maybe to clarify some of it, what that process is all about, because it seems to be an important part of this legislation. And so just to give you a little bit of background on that, the PMTA process, there is basically what many people would call kind of a grandfathered period of time. If a product was on the market as of 2016, a PMTA application had to be submitted to FDA by September 2020. And those products, if a PMTA has been granted, obviously could continue to be marketed and sold. But for those products where the PMTA is still pending, they are permitted to be sold in the marketplace right now as well. So we're talking about kind of the products that are in this grandfathered period. If there's a new product after September 2020, a manufacturer would have to file for that and wait for FDA authorization before it could enter into the marketplace. So we're really talking about the products that are kind of out there during this time period. So I wanted to make that point because I think there were some questions about how the PMTA process worked earlier.
Representative Smith.
Thank you for being here today. You heard some of we have folks that generally believe that this is a good idea, that there's a need for it, that it'll help keep us safer, have safe products out there on the market. But there's consternation, obviously, about the fee that's been in the bill. Do you have an opinion one way or the other about the fee on a per SKU basis?
I don't. I think that's a decision I think that this committee could evaluate and determine what's the appropriate fee. So I don't have a particular point of view on the fees.
You have any opinion about what would be appropriate on that?
I think it's important that there is both a registration fee, just so that there is some mechanism that allows for some funding for the comptroller's office to then do the enforcement. And I think it's equally as important on the back end that there is a penalty. But again, I defer to the committee as to what the appropriate amount would be for that.
Okay. Thank you very much.
And I just wanted to offer, if I could, that the PMTA process, the ultimate decision that FDA is making when it reviews a pre-market tobacco application is, and this is a statutory standard, whether the product is appropriate for the protection of public health. And so if they grant a PMTA authorization, they're in essence saying this product is appropriate for the protection of public health. In other words, it presents significantly less risk than cigarette smoking, and that's a good thing. And so for those products that are authorized by PMTAs, I think we want to know which ones have made it through that process or which ones are pending in that current grandfathered process. And I think that's important for Texas wholesalers and retailers to know which of those products that they could or should be selling. And I think ultimately it's important for consumers here in Texas to know that products that are on the shelves that they are considering purchasing have successfully navigated that process and have cleared that important threshold.
Other questions, members? Ready, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 4481? Chair recognizes Representative Smith to close.
Madam Chair, Madam Vice Chair, thank you so much for the time today. Appreciate all the input from the witnesses. I think it's clear from what we've heard today, Madam Chair, that there's a definite need for this legislation. And I really appreciate the attitude of folks who have come forward to try and make this a better bill. I'll commit to them that we'll work all together to try and make this workable. No one's wanting to put small business out of business. And so with that, I'll just close.
Alrighty. If there's no objection, House Bill 4481 will be left pending. The chair hears no objection. House Bill 4481 is left pending without objection. The chair lays out House Bill 2079 and recognizes Representative Jatan to explain the bill.
Thank you, Chairman. Members, I'm here to lay out House Bill 2079, which allows pharmacists to test and treat patients for flu, strep throat, and COVID-19. Pharmacists are currently allowed to administer CLIA waived tests to patients and routinely do so for things like the flu, strep throat, and COVID-19. Waived testing is designated by the Clinical Laboratory Improvement Amendments of the Food and Drug Administration and as simple tests that carry a low risk for an inaccurate result. Pharmacies performing CLIA waived tests have a CLIA waived certificate of waiver obtained by the Centers for Medicaid and Medicare Services and approved by the Texas Department of State Health Services. Under the authority granted by the Federal Public Readiness and Emergency Preparedness Act, the PrEP Act, and the emergency use authorization for Paxlovid, pharmacists were granted the authority to order and furnish the antiviral drug Paxlovid following a positive test result, COVID-19, in certain circumstances. This authority was granted in recognition that pharmacists were highly trained and qualified and can follow the clinical guidelines to safely and effectively furnish this medication to patients in a timely manner. Last session, this committee supported legislation that would have granted the pharmacists the authority to test and treat for flu and strep throat, two conditions with similar symptoms to COVID-19. As someone who has previously worked as a store manager for a large chain pharmacy and was cross-trained as a pharmacy technician, I can attest that there is a need for this kind of increased access by patients. If a patient is sick on a Friday night, or his or her only option might be to wait until Monday morning and hope to get an appointment with a physician, whereas the pharmacists are open late and on weekends. Additionally, half of adults and 60% of children in Texas do not have a medical home and might forego treatment altogether or end up in higher cost treatment settings like urgent care or emergency rooms. Members, this is a common sense bill that will increase access to high quality health care while lowering cost to patients. Did we have a committee sub? Do you have the committee sub? No? All right, with that, I'm happy to answer any questions. Otherwise, reserve the right to close.
Do you have a sub that you're working on that you might want to explain?
The only difference is going to be that it's alleged council draft.
Okay. Ready? Questions, members? Okay, we'll reserve your right to close and begin our public testimony. Chair calls Debbie Garza. Up next will be Randy Martin and then Valerie Smith. I show you as Debbie Garza, and you're registered on behalf of the Texas Pharmacy Association, and you're for the bill, correct?
Yes, ma'am.
Thank you. Please begin.
Good afternoon, Madam Chair, members of the committee. Again, Debbie Garza. I'm a pharmacist and the CEO of the Texas Pharmacy Association. Pharmacists are the state's most accessible healthcare providers. Texas has more than 5,000 community pharmacies, both independent and chains, and nearly 30,000 licensed pharmacists. Most community pharmacies, as Representative Jaton said, are open on weekends, evenings, and some are even open 24 hours. In many rural and medically underserved communities, pharmacists are the only healthcare provider. Last session, as you just heard, this bill, which was House Bill 2049, was voted out of this committee, and it would allow pharmacists to initiate treatment for flu and strep. But since then, because of the PrEP Act, pharmacists have been able to prescribe the antiviral medication Paxlovid to treat patients with mild to moderate COVID-19 infection under the authority granted through the Federal PrEP Act and Emergency Use Authorization, which expires next year. The language in this bill that Representative Chon laid out mirrors that authority granted to pharmacists under the federal authority. The symptoms for COVID, flu, strep throat, even seasonal allergies and cold are often similar, and patients actually wait many times before they get tested. The diagnostic test and the equipment to analyze such tests used in pharmacies are the same as those used in doctor's offices, urgent care centers, and emergency rooms. These tests are waived under the Clinical Laboratory Improvement Amendments, or CLIA, of 1998 because they are simple to perform and have a low risk for an incorrect result. Antiviral medication must be started soon after symptoms begin in order for the treatment to be effective. For example, within 48 hours of flu symptoms or within 5 days for COVID-19. Pharmacists are only authorized to furnish medication for COVID-19 as mentioned, not the other two conditions. Allowing pharmacists to initiate treatment for flu, COVID-19, and strep throat would help patients get quick access to care, feel better faster, and help lower healthcare costs. Pharmacists both being able to test and treat for these conditions would improve treatment rate and reduce contagion, thereby increasing workforce productivity and decreasing the spread of disease. Passage of this bill would also provide critical access points for patients who do not have a primary care doctor, as you also heard, which is nearly half of the adults and 60% of kids in Texas, and would allow sick individuals to access care at convenient pharmacy locations rather than clogging up physician waiting rooms or emergency departments. With this legislation, we would be able to conduct in accordance with clinical expert guidelines developed by infectious disease experts. Many states have passed similar legislation, including Arkansas, Iowa, Kansas, and Florida. We urge Texas to do the same. I ask your vote in support of House Bill 2079, and I'm happy to answer any questions you may have.
Questions, members? Thank you.
Thank you.
Up next is Randy Martin, followed by Valerie Smith.
Good afternoon.
I show you registered as Randy Martin.
Yes, ma'am.
And you're representing the Texas Society of Health System Pharmacists and yourself?
Yes, ma'am.
And that you support the bill?
Yes.
Okay, please begin.
All right. Thank you all. I'm the president for the Texas Society of Health System Pharmacists. I'm also a clinical pharmacist and a former pharmacy educator. I used to serve as the Associate Dean for Clinical Affairs at the University of North Texas Health Science Center and trained hundreds to thousands of student pharmacists. Part of my rationale for wanting to support 2079 are many of the reasons laid out by Debbie Garza, and I fully agree with everything that she said in her testimony, so I won't repeat all of that. One of the biggest things to point out is that CLIA-waived tests are simple and they have a very low likelihood of error. And that's one of the things that makes these so appealing. It's also important to note that pharmacists, just to reiterate from what Representative Jaton said, is that these tests are already being administered by pharmacists. So the missing element here is actually getting the drug to the patient in a timely fashion. Most of these disease states, all three of these in fact, if we get treatment to these patients faster, they have a lower likelihood of having severe symptoms, they're less likely to be hospitalized, and we have less lost work days. So this is very critical, especially when we consider that pharmacies, as Debbie mentioned, are far more accessible and available than their nearby physician office. One thing, as a former educator, I did want to point out that pharmacists are educated and trained to prescribe these medications. It should be noted that under collaborative drug therapy management, which is engaged widely across the state, Hundreds of pharmacists already do this. They're just simply limited by the practice sites that they're in. So they're trained to do it, they're educated to do it, they're capable to do it, and they're ready to do it. I want to thank you all for your service and your time, and I'm happy to answer any questions.
Questions, members? Thank you.
Thank you.
Dr. Valerie Smith. Next on deck will be Raj Shadua. Dr. Smith, it looks like you have registered more than once.
So I am testifying on another bill today, but representing a different set of organizations.
We have you registered as representing the Texas Pediatric Society, the Texas Medical Association, the Texas chapter of the Academy of Family Physicians, the American College of Physicians in Texas, and yourself. Are those all correct?
Those are correct for this bill, yes.
Okay, and you are against the bill?
Correct.
Already. Please begin.
Thank you, Chair Click and committee members. My name is Valerie Smith, and I'm a practicing pediatrician in Tyler, Texas. Thank you for the opportunity to provide testimony on behalf of the Texas Academy of Family Physicians, the Texas Pediatric Society, the Texas chapter of the American College of Physicians, and the Texas Medical Association in respectful opposition to House Bill 2079, which would allow pharmacists to furnish certain prescription medications without a physician prescription. We would like to thank Representative Jatan for his willingness to meet organized medicine on this issue. You have been a champion on many medicine issues, and we appreciate both you and your wonderful staff working with us to see if we can find an appropriate path forward. While proponents may refer to this proposal as test and treat and appear that it's narrowly focused, we believe that this is more akin to diagnose and prescribe and constitutes the practice of medicine. Physicians treat the patient, not the test. Strep and flu tests do have false negatives, and this proposal does not provide the nuance necessary for other diagnoses that may be present at the same time as a positive test. Also, if a patient presented to a pharmacy with a problem that they thought might be strep or flu and the tests come back negative, how are this patient's underlying problems to be addressed? Further, this proposal does not account for an individual patient's past medical history, the severity of the patient's health issues, and whether the patient has one or more chronic conditions that require a physician's expertise. For example, let's consider a child who could present for a flu test at a pharmacy under this legislation. Not all children with the flu need or would benefit from antiviral treatment, depending on their personal risk factors and the length of time they've had symptoms. This could lead to the overprescribing of medications when not clinically indicated. Other children, for example, those with asthma, would need additional assessment and treatment. A child with asthma needs a careful lung examination, likely needs their routine asthma medications adjusted, may need additional asthma medications prescribed, and will need careful follow-up. All of this is regularly provided in a physician's office, but would not be provided to a patient if they were prescribed by a pharmacy under this bill. If this care model becomes established and accepted, it will create a path for patients to bypass the benefits of a physician visit and further increase the fragmentation of care. Physicians and pharmacists already participate in collaborative care models that utilize the education and training of pharmacists to monitor, advise, and adjust patient medication management, particularly in the treatment of chronic conditions. Protocols for this level of engagement are more than appropriate and are consistent with a broad team-based approach to care. There are many avenues of care available to patients: the traditional primary care physician's office, urgent care centers, retail health clinics within pharmacies, and even telemedicine services. We do not need another route that provides incomplete care for patients. Again, I thank you for the opportunity to provide testimony in opposition to House Bill 2079 and welcome any questions.
Representative Collier.
Thank you, Madam Chair. I should ask this to the pharmacy, but hopefully you can try to address this question that I have. So you talked about the flu, and there could be other things. I remember there was a Tamiflu shortage. Maybe a medical professional will know what the best alternative is or what other avenues a person can take to address their flu symptoms. But under this bill, would a pharmacist be able to make the next best prescription, I guess. I don't know. I'm just trying to figure out, how do they decide what the plan is if they're not medical doctors?
It's a good question. I will say that Tamiflu shortages are very common during the peak of flu season, especially when we have a particularly bad flu season. And so it is really important to be thoughtful about prescribing the medicine, not to everyone with the flu, but the people who would most benefit from it. Those with chronic medical conditions that put them at risk, or who are in age ranges that would put them particularly at risk. So for the flu, that's very young and very old. And those are things that we think about in the physician's office on a regular basis when trying to make good decisions about allocating care.
So I thought I heard somebody say that they can do this for COVID-19, but my understanding, there's probably only 1 or 2 drugs that would be prescribed for that.
Yes, so the public health emergency allowed pharmacists to do this, to provide an additional access point at a time when our healthcare system was overwhelmed and access points were really challenging. And I appreciate pharmacists coming to the table and trying to help us deal with this public health emergency. But these issues are routine issues that we see regularly that aren't part of the public health emergency.
Sure. So if somebody says they did the test and they said they have strep throat, and is there some, I don't remember if I saw that in the bill that it says, well, this is what you prescribe for strep throat.
So there are protocols for what you would prescribe for strep throat, for example, that also include, for example, if a patient had an allergy to the primary medicine usually prescribed, or even, for example, amoxicillin, which is one of the primary medications we use to treat strep, there have been shortages of recently as well. Those pieces do. What this doesn't do, though, is, so for example, when I see a child in clinic and treat them and do a rapid strep test, I also perform a physical examination. It's not uncommon for that child to also have an ear infection at the same time. Even though the medication is actually the same to treat those, amoxicillin is the primary medicine, the dosage is not the same for those. We prescribe at a higher dose to treat that ear infection. So a child who had both, who presented to a pharmacy and tested positive, would receive an inadequate amount of medication for what they actually had.
Okay. And then the other part in here was they would be required to notify the primary care physician within 14 days of the, I guess, administration of the medication. Does that seem sufficient?
So that would be helpful for something like strep throat, potentially, where we would want to follow how many times a child had had strep throat to see if they might eventually need their tonsils or adenoids taken out. But that would, for example, the child with asthma, that would not be helpful at all. Because that child with asthma who's at high risk of complications from the flu, who is going to need soon follow-up, is going to need follow-up in 48 to 72 hours, not in 2 weeks.
Okay, that's what I was wondering about, the 14 days. Maybe that's too long for that. Okay, thank you.
Other questions, members? Ready, thank you. Oh, I'm sorry.
Hello.
Good afternoon.
So, good afternoon, Madam Chair. My name is Rod Chadua, Dr. Rod Chadua. I'm a pharmacist and the managing partner of Renew Pharmacy, which operates 8 locations in Dallas-Fort Worth Metroplex. I appear before you today to testify on behalf of the Texas Pharmacy Association and myself in support of House Bill 2079. I did want to kind of address some of the comments, actually, that the previous speaker had stated, but I'm going to go through my testimony and then just add it in there, if you don't mind. Patients come to me every day when they do not feel well, seeking recommendations for treatment for common illnesses. In my pharmacies, we currently perform CLIA wave tests for influenza, strep throat, and COVID. If the patient is positive for COVID-19, pharmacists are currently able, under temporary federal authority, to determine whether a patient is eligible for treatment with the antiviral medication Paxlovid. We've kept over thousands of patients actually out of the hospital system with this Test and Treat federal program. Eligible patients have a consultation with a highly trained pharmacist, which is a doctorate program, who will ensure that the patient does not have medical conditions or take other medications that could cause an adverse reaction with the medication. Additionally, The pharmacist will review patients' labs to determine kidney and liver functions to ensure clinical guidelines are followed prior to furnishing the medication to the patient. We want to continue to provide these services to our patients. If the test result comes back positive for flu or strep throat, currently the only medications we can provide are over-the-counter options for symptom relief instead of the first-line recommended antiviral and antibiotic prescriptive medications, respectively. The patients must then go to a physical office, urgent care center, or perhaps even an emergency room to receive yet another CLIA-waived test before giving a prescription to treat the condition. And I'm sure my guest before would probably recommend that getting therapeutic treatment quickly, specifically with these three areas, are extremely important, and the protocols set in place for flu and strep have been around for years, and they're very structured on what a pharmacist can and cannot do. On the matter of drug shortages in this aspect, this is something that pharmacists deal with daily and quite honestly, quite frequently with a lot of the supply issues with drugs coming in, especially with the antibiotics that they were talking about specifically on strep. So it's a normal process for us that if there is a shortage on a medication or if there's a problem with the medication, that we're in constant communication with the provider to change that. If the test, pharmacists understand when to refer patients to physicians and will not put the patient at risk. The other aspect, that if a patient comes in and they test positive, for example, they don't test positive for COVID, but they test positive for flu and strep, then there's nothing we can do, and we have to let them go. And in one situation, actually the patient, we follow up with the patient 48 hours, 72 hours, and then again 5 days if they have not actually had discussion and gotten involved in care with the provider. One situation that happened, the patient was actually hospitalized after we provided multiple locations for them to immediately go see a provider. With flu and strep and COVID-19, fast identification and treatment is imperative to help the patient recover sooner and reduce disease spreads to others. Patients need to begin treatment soon after symptoms begin. This is often not possible via traditional physician practices do not offer extended or weekend hours for which appointments can be tough to secure. In the situation I expressed earlier, which is one time only, this was an event that happened on a Saturday. And we again called the patient on Monday to ensure that they got into the provider's office and then followed again throughout the week. Sadly, that patient actually was admitted to an emergency room, mother of two. Pharmacists are highly qualified to initiate treatment for flu, strep, or COVID-19 based on a positive test result. Pharmacists receive 6 to 8 years of post-secondary education that includes 4 years of intense doctoral level training. Pharmacists' curriculum include extensive coursework in pharmacology, clinical patient care, patient assessment, drug selection, and more. And pharmacists are trained to de-prescribe and not over-prescribe.
Super, your time's expired. Representative Collier.
Thank you, Madam Chair. I want to follow up on the questions that I had for the previous witness.
Yes, ma'am.
But something you said, it sparked another question. You said that if there's a shortage of a medication, you call the doctor.
Correct.
Why do you call the doctor?
Just to make sure, so for example, in strep does have a protocol on, and it's only specific for strep A. They do have a protocol for the first.
But why do you call the doctor? I just want to know why is it that you have to call the doctor? Is it
usually
because they
that
wrote the
individual
script?
has a primary care provider, and if it's outside of that protocol, then we're going to engage with the physician.
Okay, so you couldn't just automatically just say, I'm going to give them a different medication?
Not if it's off that protocol.
If it's off that protocol?
Correct. There's a very strict guideline protocol that's utilized in multiple states.
Well, no, you said that if they don't have it, if they don't have the medication.
If that medication is in short supply.
Yes, so you call the doctor
Yes, ma'am.
and you say, I want to prescribe this, or do you say, do you have another medication? How did that work out?
So in most common, we speak and consult with the provider, asking them exactly what they would like to change the alternate to. But a lot of times we'll have a list of alternates. And most often they're going to go with the recommendation of the pharmacist on the alternate medication.
So when you call, you say, Dr. Jones, we don't have Tamiflu, but we have Flutam. I'm going to prescribe that. You okay with that?
Usually it's whatever alternate there is.
I just made up I don't know what
There's very
the
few
alternate is.
alternatives for Tamiflu, but what we would do is we would recommend that currently Tamiflu is not available, but we can provide a compounded medication, or we can make a medication from what's the Tamiflu product that is available. So we go through those recommendations.
And then the doctor has to say yes or no.
The doctor has to approve that, correct?
So it's not the pharmacist who's making the final decision?
Correct.
Okay. So then let's go back to I just wanted to make sure I cleared that up. There's a reason for that, because that's what they're practicing medicine. The doctor is, not you.
If it's outside of the defined guidelines, correct. We're not practicing medicine. We're going based on the defined guidelines that an individual in their office would follow as well.
Okay, so then let's go back to if they don't have the medication and, you were using strep. You said there's strict protocols on how you can treat strep, right?
Correct.
So A is the first drug, amoxicillin or whatever, and then B is this one. If I have an allergy, it's this one. And so under the bill, you would be able to set whatever that alternative would be, or are you just stuck with amoxicillin?
No, there is a series of medications on that protocol for amoxicillin, because there is sometimes you'll have a penicillin allergy. There's something that'll need to be substituted on.
So under this bill, you would be able to determine what the best course is for that individual, for that patient.
Yes, the exact same protocol that they would utilize actually in a practice.
Okay, so, but under this bill, you're not consulting with anyone, you're just saying, oh, you have an allergy to penicillin? Okay, I'm gonna make the decision and prescribe X. And, right? That's what this bill would do.
Yes, ma'am.
So it's
Defined
giving
under
you
that
prescriptive authority for flu, codifying COVID, and then strep,
Yes, ma'am, under that protocol.
under that protocol. And is there a provision in there that says you must go see your doctor after that?
So there is, again, I don't know the specifics of that language, but I know in 14 days, the physician has to be notified. There is already currently in there where the patient has to be engaged 48 hours after any kind of therapy is administered, and then follow-up areas after that.
Meaning that the pharmacist would have to call and say, are you okay? And everything, right?
The post questions, correct?
Okay,
Post-therapy questions.
okay, all right, thank you.
Other questions, members?
Thank you.
Thank you. Okay, the chair calls Anisha Malhotra. And up next will be Kelly Cox.
Good afternoon, Madam Chair Click, Vice Chair Campos, and committee members. I'm Dr. Anisha Malhotra, and I'm here on behalf of Texas 400 and myself to respectfully and strongly testify in opposition to House Bill 2079. I want to start, so I work in the emergency room. I want to start by saying that I deeply respect and am thankful for my pharmacy colleagues. Their expertise is necessary and specific, but it is not in the practice of medicine, which is what this bill is allowing. I have spent a total of 11 years studying and training to be given the privilege of caring for, examining, diagnosing, and treating patients. Medical school taught me the deepest possible understanding of the human body. It also taught me how to correctly perform a thorough physical exam, how to order or not order the correct tests or imaging, labs or imaging tests, how to interpret the results, and how to appropriately treat the patient. Perhaps most importantly, physicians are uniquely trained in the differential diagnosis, which is a list of all the possible diseases the patient could have based on a comprehensive evaluation done by the physician. Pharmacists have a rigorous education, but it is in the understanding of medications and how they interact with the body. They are not trained in the aforementioned skills. This matters because a sore throat is not always strep throat. Someone said earlier that strep presents similar to cold and flu, which isn't actually completely true, and that's exactly what I'm concerned about. The other things that I think about as an ER doctor when someone comes in with a sore throat is it something more dangerous, such as a retropharyngeal abscess? Could it be HIV? Could it be gonorrhea? Could it be cancer? Could it be thrombophlebitis? That's just a few things that I can mention right now. So to quickly arrive at the correct diagnosis, we have to first know all the possible diseases and also know how to properly examine the patient to rule in or rule out those diseases. So my other concern is someone had mentioned that they would have to call the doctor anyway. So why are we adding this additional step for the patient? If they're misdiagnosed, also, they're going to end up needing to see the physician anyway, or worse, end up going to the ER. They will end up paying more in both time and money in the name of access. My other question is, when something serious is missed, who is going to be held accountable for this? Pharmacists do not have medical malpractice, and patients are going to have zero recourse. All healthcare professionals are an important part of the team, but I urge you to remember that our skills are not interchangeable, and there is a reason medical training is so long. I also had some comments about the prior testimonies. Am I allowed to respond to that at all?
And it's more questions on my end. So someone, I think the pharmacist had mentioned reviewing patient labs before deciding to proceed with the treatment. So my question is, where are they accessing these labs? Because I work in the ER and I very often don't have any access to labs. So I have to order them during that visit, right, to determine if I can give a certain medication or not. My other question is, how will the physician be notified? Is this going to be a call? Is this like an official email? Is it an Instagram DM? Like, what is it going to be? And then my final question is the idea of them following up with the patient over the phone. It sounds good in general, but my concern is, what are they going to follow up? Because they're not necessarily qualified to decide over the phone if someone is clinically doing better or not. I mean, I can barely do that without a physical exam.
Questions, members? Ready, thank you for your testimony. Next on board is Kelly Cox, followed by Saba Rizvi. I have you registered as Kelly Cox, and you're representing Market or Walmart, and you're for the bill, is that correct?
Yes, ma'am.
Ready, please begin.
Good afternoon, Madam Chairman Click and distinguished members of the Texas House Committee on Public Health. My name is Kelly Cox, and I represent and appreciate the opportunity to testify in support of Bill 2079. As a health and wellness market director in a rural setting, I'm proud to be part of a team that oversees over 600 pharmacies in the state of Texas, 42 of which are in the committee's districts. Our pharmacists, pharmacy technicians, and interns serve millions of patients in Texas every year. We serve children, we serve parents, adults, and elderly in the rural, urban, and suburban areas. Our frontline role in healthcare shows us that a great opportunity exists to further serve your constituents in this fundamental aspect of their well-being. In case of acute, non-chronic medical conditions like influenza, strep, and COVID, early diagnosis and treatment is the most effective method to prevent complications and expensive medical treatment bills later. However, we know that the high cost to healthcare prevent patients from seeking immediate medical attention, not to mention healthcare prevents patients from seeking medical attention, not to mention millions of uninsured Texans for which healthcare is often unattainable. We'd like to help fill this as an adjunct to help fill the gap in healthcare. The solution to the problem involves Texas pharmacists to do what they do best, which is serve your constituents at an affordable cost and at a time that fits within their busy family schedules. Let's remember, more than 90% of Americans live within 5 miles of a pharmacy, making pharmacies an ideal healthcare access point. House Bill 2079 incorporates clear and concise language that will allow Texas pharmacists to practice in line with their training and their education. It allows us to order and perform low-complexity clinical laboratory tests, and based on the results, order and furnish treatment for strep, influenza, and SARS-CoV-2 or related viruses or illnesses. I commend Representative Jetton for his vision and leadership in our important bill. I thank you for the opportunity and ask for your vote in favor of House Bill 2079. Questions?
Representative Price.
Thank you, Madam Chair. Doctor, I see you, well, let's see, Kelly, I'm sorry, they changed it on me real quick. You reside in Brenham, is that right?
I reside in College Station.
Okay.
Brenham is one of my areas of,
Where you work?
yes,
Or-
sir. I have pharmacies there in Brenham.
Okay. And so I'm just curious, because I also represent an area not unlike that in terms of demographics and rural communities served by pharmacies there. What are you hearing from your patients and also, on this issue? What kind of feedback do you get from your patients, first of all?
A lot of our patients struggle to be able to get into practitioners during the regular business
And
hours.
why would that be?
Doctor's offices are typically open 8 to 5. Our pharmacies are open later,
Okay.
sometimes till 9 o'clock. So it gives them the ability, when they're working all day, to be able to come in and see the pharmacist in the evening hours.
Okay. And so what, if any, feedback do you get from them?
We do get feedback. A lot of times they come in and they tell us, we can't get into the doctors. What can we do? How can you help us? And that's the feedback that we typically are getting from a lot of our patients. A lot of patients don't have family practitioners, and the reply is go to the emergency room, go to an urgent care, where the bills just absolutely are expensive, and a lot of it is unattainable for a lot of the patients that we deal with.
Okay, thanks, Kelly.
All right, thank you, sir.
Other questions, members? Thank you.
Thank you, ma'am.
Saba Rizvi.
Good afternoon, Madam Chair Click, Vice Chair Campos, and the committee members. My name is Dr. Saba Rizvi, and I am testifying today in opposition to HB 2079 on behalf of Texas 400 and myself. I strongly oppose this bill, which would allow pharmacists to diagnose illness using CLIA-waived tests and then furnish certain prescription drugs based on the results of those tests. The old adage in medicine is that we treat the patient, not the test. This could not hold more true than what's being proposed with HB 2079. Medicine is not protocolized. Many common medical conditions mimic more insidious and dangerous health problems. This is why a complete examination of the patient by a physician trained in gross anatomy, physiology, pathology, and pharmacology is absolutely needed to diagnose and treat, not just singularly knowing pharmacology. For example, a sore throat could mean a patient has a peritonsillar abscess. This condition is not simply treated by medication, but would require surgical drainage. Another example would be seemingly a simple sore throat that comes in and is actually epiglottitis, which is a flap of cartilage in the back of your throat. Swelling of the epiglottitis could mean you have airway compromise and severe airway breathing problems that could be life-threatening and deadly to a patient. The pitfalls of misdiagnosing illnesses based solely on rapid tests are vast and very dangerous. Negative test results create a false sense of security in patients, leading them to believe that they don't have to see a doctor. This could be very dangerous, especially for conditions that require prompt medical attention. Patients get the negative flu test. Now they think they don't have the flu, but they may have pneumonia, they may have a lung abscess, they may have many other things. We understand that there is an economic pressure to test and treat patients so that the pharmacy steers the patient towards purchasing medications based on positive test results. It is also important to understand that most commercial pharmacies are now owned by PBMs or pharmaceutical benefit managers. Pharmacists are employed and act as agents of these companies, which are again profit-driven. In other words, they make money off of selling customers a pack of cigarettes or selling them a pack of azithromycin. I don't remember CVS or Walmart taking a Hippocratic oath. There's a complete conflict of interest in both being the doctor and the apothecary. There are perverse incentives, and I would argue that we need to caution against using tests in order to sell more drugs to patients. I respect my pharmacy colleagues, and I bet many of them don't want to play doctor. Pharmacists play a crucial role in our healthcare system. It's important to understand their limitations and their training and expertise. I don't think that simply saying that pharmacies are open late is any sort of solution. These tests need to be done in conjunction with a clinical evaluation. I would take any questions if you have any at this time. Thank you.
Questions, members? All righty, thank you. Thank you.
I do want to ask a question.
Okay, Representative Collier.
Thank you, Madam Chair. I just want to, I was trying to figure out where we're seeing the difference on what the pharmacist can do. So I was trying to look up the definition of a pharmacist. And I just want to make sure that this is your understanding. It means a person licensed by the board to practice pharmacy. And then it says pharmacy means a facility at which a prescription drug or medication order is received, processed, or dispensed. So under this bill, is it your position that it's exceeding that definition of what the pharmacist can do?
Yes, absolutely. It's exceeding their scope and exceeding what they can do.
All right, thank you.
I have questions.
Representative Jatan.
Yes, thank you. Thank you, Chair. I appreciate you coming and testifying. We usually find ourselves on the same side of issues, and it's unfortunate we're on the opposite side of this one. I do want to point out that I believe pharmacists are trained in optimization of medication and to improve health outcomes. And I think it's much more than just facilitating a pharmacy. Is that your understanding?
My understanding is, well, you can facilitate better health outcomes, but you also have to put in safety regulations and look out for the ultimate safety of patients.
Perfect. And I agree with that. And so when we look at test and treat, what this bill says it does, we're looking at 3 specific tests: CLIA test, CLIA tests. And within those 3 tests, if it tests positive, there is a set of guidelines that have to be followed. There's a protocol, and this medication is given. And so I struggle with the accusation that they're out for money, and this is a play for money. Because at the end of the day, they're not, I don't think that they would go and fake a positive test to be able to prescribe a certain medication. Would you agree with that?
You know, a positive test there could be certainly one condition that positive test is, obviously showing a positive for, but there could be multiple underlying conditions as well that are not diagnosable or missed based just solely on that test. And as far as protocols are concerned, yes, there are certain protocols, but they are, taken in conjunction with the overall clinical picture of the patient. Yet, you have a positive strep test and you you go down a certain arm in prescribing a medication or prescribing a certain type of antibiotic based on the patient's age, their comorbidities, their physical exam, their other medications, their co-interactions with other medications, whether they're a dialysis patient or not. I mean, there's just a laundry list of things that we take into account as physicians that I cannot imagine seemingly a pharmacist would be able to take into account or have access to.
Right. So when they're, when they're right now only able to prescribe Paxlovid for COVID vaccination, or a positive COVID tests, when we're talking about, them being owned by PBMs or, only out for the money, then how are they? This is what I'm struggling with. You made some accusations. I just want to clarify.
Paxlovid, I would argue, and it was under emergency authorization, correct? Sure. Sure. And then even the manufacturer of Paxlovid has a huge exclusion criteria of what patients cannot get Paxlovid. So it's not as simple as saying, we should be able to give Paxlovid for seemingly a self-limited illness now, which COVID is and has become. So
sure.
I don't believe that those two things are.
I understand what you're saying about all of that. And there's a realm of training and things that go along with how doctors diagnose and prescribe. I think there was accusations made that I'm just trying to get some clarification.
I would say that there are certain insidious, there are certain the ownership of pharmaceuticals and pharmacies needs to be taken into account. They are selling a product. Physicians don't sell a product. We're not out there selling medications. They're selling lots of other products in their store shops besides just, medications. So there is an incentive there. There's a perceived or real conflict of interest that needs to be addressed.
Okay. Thank you.
Thanks.
Other questions, members?
I do.
Representative Tinderholt?
Thank you, Madam Chair. She walked away. She doesn't want to talk. If you don't want to talk to me, I'm used to that. It's okay.
I apologize, sorry.
So what's the main difference between what a doctor learns about pharmacy and what a pharmacist does? Is it for someone that just doesn't know? Do you guys learn the same thing?
So we have a requisite training in pharmacology in medical school. That it's at least about 2 years long, depending on how the school structures it. But we learn quite a bit of pharmacy, or pharmacology, I should say, and we learn drug-drug interactions, and we learn different disease processes and how they can be treated with different remedies. Does that answer your question?
Yeah, I don't know if there's a huge difference between what they learn and what you learn.
Oh, we learn anatomy, we learn pathophysiology, we learn, a host of other things. We learn pathology, which is a big part of our curriculum. So not just pharmacology, not just
So do you guys have any, when I first looked at this bill, I kind of thought, hey, this is kind of neat, but I have concerns that this might grow over the coming years. Do you guys have concerns about that at all? That it could grow to where they can do more and more and more stuff and it opens up scope? Is
Yeah.
that a concern of yours at all?
That is a big concern. That is. And another concern would be that, it's not as simple as prescribing a medication to a patient, and then, patients can have adverse reactions to these medications that need to be dealt with.
It's interesting you say that. That's part of the reason I asked about it. And I'm new on this committee and I'm learning, but I went to the pharmacy one time to get over-the-counter stuff, told them that I take blood thinners, and they gave me something that made my blood go to a 6.0 INR, which can kill me. So I was really concerned that I specifically said, hey, I'm on blood thinners, and I need something because I feel horrible, but it can't interact, and they gave me something that directly interacted with it, and I didn't know if I just had bad luck that day, or if they train you guys differently on interactions.
That's a big concern. We have at our disposal the overall picture of a patient at their chart. We have their past medical history, we have their previous medications, their allergies, all the health information that we would need to make the most informed and safest determination as to what they need as far as a remedy or treatment. I can't imagine, and then we'd have the benefit of doing our own physical exam on our patient too. So we have a wealth of information, which you can't, curtail with just doing a quick 2-minute consultation and a swab on somebody's throat. You cannot take away all of that information and integration of that information and making a health decision with just one swab test.
But I'll tell you, I don't know where I am on the bill. I'm concerned about scope creep, like the scope of pharmacies changing over time. Historically, since I've been here, when people get their foot in the door, it grows, even if it's not purposeful growth, it just happens, people author bills. So I'm concerned about that, but I was just more concerned about the difference in training between, so what I'm hearing is, you're the whole person concept, you know me, you know my chart, you know my background. The pharmacist sees a test, asks me a little bit about my background and gives the medication. Is that kind of what I'm hearing from you?
Correct.
Okay, thank you.
Thank you. Any other questions? Thank you. Thank you for allowing me to testify.
Have you ever contacted a pharmacist to ask them for a consult on what to do with a particular patient?
I have, yeah.
And, I can think of several circumstances when that might occur, but can you kind of give us an example?
Sure. Most of my questions, and I'm an ER physician, I'm sorry if I didn't introduce myself as such earlier. Most of my questions center on dosages, because I hate calculating dosages. So, or, if somebody's renal function is impaired, for example, and a drug won't be excreted, like in a normal patient, then I'll ask about a dosage different. They're very helpful. Absolutely, I have the utmost respect for what our pharmacy colleagues do. I just think that there are limitations to their level of training and what they do, and just that I can't step into their role, they cannot step into mine.
One of the other examples of times that I've seen those types of consults occur is when your patient is taking a thinner like Xarelto, and they may need to go to the OR, and bridging them with an injectable med from the Xarelto.
I'm sorry, you were asking a question?
Bridging them for surgery,
Right.
with a different drug.
Right.
To do that. And, I've seen the physician contact the pharmacist on that for advice on how to best prescribe, the bridging therapy.
Correct. Yes, and oftentimes blood thinners are very complicated and patients undergoing, preoperative care for certain things. They need to be taken off anticoagulants and/or bridged to Lovenox or other medications. So that's certainly something that we do collaboratively with our pharmacy colleagues.
Are there ever times when you might prescribe a medication based on lab results?
Solely based on lab results, no. Nothing comes off the top of my head.
So what setting is it that you work in?
And the emergency room.
Okay.
I don't think I've ever just looked at a lab and treated a patient.
Okay.
I've always made it at least a personal endeavor to make sure I look at the entire patient and their history and everything.
Okay. Have you ever been in a situation where somebody came in on a prior shift and that provider has left and lab work comes back and you're left to evaluate that?
Yes, plenty of times. Yeah, and it's difficult. And a lot of ER physicians will tell you that the most, medical negligence or acts of medical negligence happen to occur during our shift change or handing off of patients. Again, because there's a blinding that happens when you're not the primary person who evaluated that patient and ordered the studies and then looked at the results, and then everything you did with the physical exam to take care of that patient holistically, there's a gap there. And it's oftentimes where, patients unfortunately undergo, or might suffer the consequences of.
Thank you.
Thanks. Any?
I have a one question.
Representative Campos.
Can you tell me, and I'm just curious, what about individuals that are uninsured? That don't have insurance?
So emergency rooms, we don't require you to have insurance per EMTALA. I mean, we see all comers.
Okay.
I never know the insurance status of any of my patients.
Okay, thank you.
Thank you.
Sir, anyone else wishing to testify on, for, or against House Bill 2079? The chair recognizes Representative Chetan to close.
Thank you, Chairman. Members, I just want to reiterate the scope of this bill. What it does is it provides for a test, a CLIA test, that is highly accurate, that when someone is diagnosed positively, will go through a protocol of what prescription it makes the most sense for them. When we're looking at the average case, someone with cold or flu-like symptoms, and I think most of us would enjoy the convenience of being able to go down to the local pharmacy, which 90% of Americans live within a couple miles of a pharmacy, to be able to check to see whether or not that is flu or strep or COVID. And I think that's important and a huge benefit to Texans, especially when we're looking at preventing the spread of these viruses, these illnesses, to be able to go in, get the test, and if tested positive, to be able to get quick treatment, so that not only are we reducing the severity of the illness, but also the spread. And so for most people, especially when we're looking at communities that do not have access to a physician, don't have the time to take off for half a day or day to go see a physician, to be able to quickly be able to determine their illness if they have one, and to get back to work or whatever they're doing, taking care of their kids, is a great benefit to Texans. I think that we have pharmacists that are highly capable of performing these tests and highly capable of diagnosing and understanding the situation, and to prescribe these medications, in addition to that, being able to follow up in the same way a doctor would. If a doctor prescribes and in a couple of days there's still illness is still progressing or is causing other illnesses or symptoms, they're able to further care for that patient in the same way pharmacists are able to determine if there is continuous decline or issues and refer them to their physician. The idea is not to replace a physician, but to allow for faster care for Texans. And so with that, I'm available to answer any questions. Otherwise, I close.
If there's no objection, House Bill 2079 will be left pending. The chair hears no objection. House Bill 2079 is left pending without objection. The chair lays out House Bill 594 and recognizes Representative Shaheen to explain the bill.
Thank you, Chair Click, Vice Chair Campos, members. Currently, Texas only allows pharmacists to deliver telepharmacy services in rural areas of Texas. House Bill 594 would greatly expand patient access to essential pharmacy services by expanding telepharmacy services across the state of Texas. To make sure we understand what we're talking about here, telepharmacies act like traditional pharmacies, except with advanced technology. They are managed by remote pharmacists with pharmacy technicians at the actual dispensing site. The pharmacist reviews prescriptions and counsels patients from a remote location. We currently allow this in our rural areas in Texas, and many states across the nation acknowledge the rapid change in the pharmacy operating models and have lifted many telepharmacy restrictions. During COVID, many healthcare services turned to telepharmacy to reduce delays in providing medications to patients and to meet the requirements of social distancing. It was quickly discovered that telepharmacy provided patients with more efficient access to medical care and reduced cost. Another benefit is the expansion of hours a pharmacy can open. Due to recent pharmacist shortages, CVS, Walgreens, and Walmart announced at the beginning of this year that they were cutting their pharmacy hours because of the shortage in pharmacists. The problem we have in Texas is state law imposed numerous restrictions that limit the availability of telepharmacy services. Currently, Texas prohibits remote pharmacies from operating within 22 miles of physical location. So House Bill 594 seeks to end barriers on telepharmacy and make it available throughout the state of Texas, not just in our rural areas. Telepharmacy is proven to be safe since it's allowed in our rural parts of our state and is present in 28 other states. Illinois has the most telepharmacies, and they are distributed evenly between rural and urban settings. With that, Madam Vice Chair, I'm open to any questions. I reserve my right to close.
Thank you. Are there any questions for Representative Shaheen? No questions.
Thank you.
Thank you. We'll begin testimony. The chair calls Mayamuna Bruce. Thank you for being here today. I show that you're registered as Mayamuna Bruce.
Yes,
is that correct?
Maymuna.
You're for the bill and you're with Telepharm, is that correct?
Yes, ma'am.
Thank you. You may begin.
Chair Click, Vice Chair Campos, and members of the House Committee on Public Health, my name is Maymuna Bruce. I am a manager of regulatory affairs at Telepharm and a licensed pharmacist. I would also like to add that I was born and raised in Lubbock, Texas, and I have family all over this great state and some who are also pharmacists, so it's really good to be home. Telepharm is an innovative pharmacy software solution that facilitates telepharmacy operations nationwide, and we write in support of House Bill 594. Telepharmacy provides the ability to restore and establish pharmacy services, offering patients in underserved communities access to the professional care they would otherwise not receive. Telepharmacy is utilized at a remote site pharmacy, which is a brick and mortar pharmacy, just like a traditional retail pharmacy. It does not require any change in scope of practice. A pharmacist still provides the same services they do at a traditional retail pharmacy. They just perform them at a distance using technology. In short, telepharmacy increases pharmacy resources in underserved areas, offering convenient dispensing and access to a pharmacist to patients in both urban and rural settings. Today, Texas law allows for telepharmacy at a remote site, but the law currently includes several provisions that limit this practice. The malice provision, or the minimum distance between a remote site and another pharmacy, is the greatest hurdle impeding the use of telepharmacy. Of the 27 states that currently permit telepharmacy and in various practice settings, 20 have less restrictive language than Texas. A NABP task force found removal of these restrictions result in an increase in access of pharmacy services with no impact on existing pharmacies. And telepharmacies make up on average 2% of all pharmacies in states with states that do not have those restrictions. As a result, NABP, which is the National Association of Boards of Pharmacy, wrote model language without these restrictions to help guide states. Texas currently has 118 pharmacy deserts across the entire state, leaving 132,000 Texans without accessible pharmacy care. This legislation gives the pharmacist the ability to utilize telepharmacy and open a remote site pharmacy to improve access to pharmacy care services in such areas. It is time Texas eliminates these burdens to patient access. Thank you for the opportunity to comment in support of HB 594, and I welcome any questions.
Any questions? Thank you for your testimony. The chair calls Carter High. Thank you for being here today, and I show that you registered as Carter High. You're against the bill, and you're with the Texas Pharmacy Association and yourself, is that correct?
That is correct.
Thank you, sir. You may begin your testimony.
Good afternoon, Madam Chair and members of the committee. My name is Carter High. I'm an independent pharmacy owner and president of the Texas Pharmacy Association. I'm testifying today on behalf of myself and the TPA, or Texas Pharmacy Association, in respectful opposition to House Bill 594. The original legislation authorizing telepharmacy included guardrails intended to limit the scope of the model to its intended purpose. This was to allow a brick and mortar location to operate in rural areas for patients to pick up prescriptions where the economics would not permit a pharmacy to locate. The mileage restrictions were crucial to ensure that telepharmacies were operating to serve that purpose. Telepharmacy is somewhat of a misnomer. This is a remote dispensing site with a technician and no pharmacist. Prior to the advent of telepharmacy, patients could receive prescription medications at their home through the mail or delivery, and pharmacists could counsel patients by the phone or other video communication system. What telepharmacy legislation really authorized for medications to be dispensed at the location without requiring a pharmacist to be on site, provided that a certain software system be implemented to allow pharmacists to supervise from another location. The initial legislation was intended to provide patients an access point in rural locations not currently serviced by pharmacists, but House Bill 594 removed those guardrails and allow these entities to operate anywhere in the state. This would also allow telepharmacies to dispense Schedule II narcotic substances, which is prohibited under current law. We do not believe that repealing those requirements would increase access to high-level care pharmacy and could potentially jeopardize the continued viability of pharmacies by allowing these operations to open without requiring a pharmacist to be on site. Additionally, we believe that allowing opiates and other Schedule II narcotics to be dispensed without a pharmacist being physically on site runs counter to this legislature's goal of addressing the opiate crisis. We understand that telemedicine has proliferated since the beginning of COVID-19, but we hope this committee keeps in mind that telepharmacy is really a misnomer and does not accurately reflect the patient's ability to receive their medications at their home or have virtual interactions with pharmacists. It's really about the ability of brick and mortar locations everywhere in the state to dispense drugs without a pharmacist, and for that reason, we respectfully oppose the legislation. Thank you.
Thank you. Are there any questions? Thank you for your testimony.
Thank you very much.
You're welcome. The chair calls Nora Bletcher. Thank you for being here. I show that you registered as Nora Belcher, is that correct?
That is correct.
You are for the bill, and you're with the Texas eHealth Alliance?
Yes, ma'am.
Thank you, ma'am. You may begin your testimony.
Thank you very much. Good afternoon, Chair Campos, members of the committee. I'm delighted to be here in support of Representative Shaheen's House Bill 594. I want everyone to make a note that I work with other legislators besides Representative Price, who I can see laughing at me a little bit from behind the dais. We actually wanted, I'm going to start by thanking Representative Shaheen for his leadership on this. He came across this issue without us having to go ask him to file the bill, and that felt really good, because sometimes when you work on something, you feel like you're the only one, which is how I felt working on telemedicine in the 90s. You can get a little disconnected. So we've really appreciated his support and his staff support. I think I want to make 3 quick points. Number one, the board rules and the law require a telepharmacy to have continuous supervision by the pharmacist. So the fact that the pharmacist is not physically there does not mean that the pharmacist does not have eyes on what is happening. So I think that that's a really important distinction. This is an electronic system, audio and video communication, and virtual counseling of patients. So this is not just software that's watching activity. This is interaction between the remote side and the telepharmacist. Telepharmacy is a mode of practice, just like telemedicine and telehealth. So that's my first observation. My second observation would be back in the 90s, again, when I first started doing telemedicine when I was 12, is what I like to tell people, we had a requirement that telemedicine had to be affiliated with an academic health science center. So that really froze a lot of physicians out of the ability to do telemedicine from their practice because they had to have this relationship. The mileage restrictions here feel a little bit like that to me. It's an artificial restriction on the market, not necessarily meeting each individual community where it's at, but instead making a choice about distance that may or may not work depending on where you're at. I also would say that one of the things we learned during COVID was that distance is distance. Even a little bit of distance can be a problem for someone who doesn't have transportation, doesn't have a way to get where they need to go. And if people don't think we have transportation barriers in non-rural areas, I would make a joke about Austin's public transportation system, but that would probably get me in even more trouble. So I will just say it's not always available when people need it. So we need to bring services closer to folks where they're at. And we believe House Bill 594 does that. And with that, I will close. I'm happy to take questions.
Thank you. Any questions? Thank you, ma'am, for your testimony.
Thank you all very much.
The chair calls Samuel Sheets. Thank you for being here. And you are registered as Samuel Sheets, is that correct?
Yes, ma'am.
And you're for the bill?
Yes, ma'am.
And you're with the Americans for Prosperity and for yourself?
That's correct.
Thank you. You may begin your testimony.
Thank you, Madam Chair, members of the committee. I'll be very brief here. Representative Shaheen did a great job introducing the bill. We are fully supportive of this legislation. This is a good old-fashioned case of increasing the supply and access, increasing convenience and availability and access to prescription drugs and pharmacies across Texas. The details I do want to add are that if you see the fiscal note, which was just released, we're expecting estimate-wise 5,790 new pharmacies, which are expected to come online with this. That's a significant jump. Other states, other very rural states that have done this, like North Dakota, they were one of the very first states to do this. They saw an increase of 94 new pharmacies come online, able to serve an additional 80,000 folks. So this is a significant jump. Like I said, supply and demand, increasing access and convenience. Very little about this bill changes current law. Excuse me, I had to run over here, I had to feed the meter outside. Basically, the duties that the pharmacists and the technicians are allowed to perform do not change. The storage and record-keeping requirements do not change. The security requirements do not change. Just the supervision requirements using remote technology is the only significant change, plus that elimination of the mileage barrier. So we think this is a great bill. This can help a lot of people, particularly in rural Texas. Happy to answer any questions. Thank you.
Any questions? Thank you for being here, sir.
Thanks.
That's it. If there's not anyone else here to testify on HB 549, I will call Representative Shaheen to close.
Thank you, Madam Vice Chair. I'll just say, it's always a challenge when we're talking about changing business models and the advent of technology. We did this with taxi drivers and Uber not too long ago. At the end of the day, there's other states, several other states that are far ahead of us. This is very safe alternative, and it does expand access to much-needed medication to our constituents. With that, madam, I close.
Thank you, Representative. If there is no objection, House Bill 594 will be left pending. The chair hears no objection. House Bill 594 is left pending without objection. The chair lays out House Bill 2814 and recognizes Representative Shaheen to explain the bill.
Thank you, Vice Chair Campos, members. I guess we're going to talk about dead people now. Columbariums are memorial walls used to store the cremated remains of a loved one. As cremation rates rise nationwide, the demand for burial options like columbariums have also risen. However, Texas law restricts their use to cemeteries, limiting the number of locations and options for families seeking a final resting place for the cremated remains of a loved one. So HB 2814 would allow licensed funeral homes to provide columbarium storage services under the regulation and oversight of the Funeral Services Commission of the state of Texas. According to the Cremation Association of North America, in 1970, only 5% of Americans chose cremation, 5%. In 2020, 56% of Americans who passed away were cremated. It is estimated by 2035, nearly 90% of individuals will choose cremation. So HB 2814 seeks to address this growing preference for cremation by allowing licensed funeral homes the ability to provide columbarium storage services, thereby increasing the number of columbariums to meet the growing demand for cremation and allow greater competition. I want the members to know I've met with some of the people that have that oppose this legislation, specifically the cemetery industry, and they laid out a valid concern to me. That is, cemeteries, they exist, they're there pretty much forever, whereas a columbarium, you could find yourself in a situation where it's at a temporary site. So think, for example, the example I was given was a strip center, and you have a columbarium there. It could change ownership, all those types of things. So I thought that was valid. So what I'm doing is there are changes to the legislation that I'm going to make that will essentially make funeral homes would be required to follow the same regulations as cemeteries. And I'll just walk you through those and then I'll be done. But the funeral homes would be required to own the land that they intend to use as a columbarium. It cannot be leased. The bill already has established a maintenance fund for the continued care and oversight of the columbarium. But in addition to that, I'm going to update the legislation to require a funeral home to make a plat, so actually plat other property that shows the space dedicated to a columbarium, and they will be required to file that with the county clerk. It will require the funeral homes to dedicate the land for the columbarium purposes, and then once dedicated, the property must remain for columbarium purposes and cannot change unless it complies with the same steps that are already in statute if you want to change the use of a cemetery, which rarely, if ever, happens. But if we do find a case where a columbarium does want to make those changes, they have to follow the exact same steps as a cemetery. With that, members, I'm happy to answer any questions and reserve the right to close.
Members, any questions? No, thank you.
Thank you.
The chair calls Ted Dickey. Thank you, sir, for being here. I show that you're registered as Ted Dickey. You're against the bill, and you're with the Ted Dickey Funeral Home and yourself. Is that correct?
That is correct.
Thank you, sir. You may continue.
Thank you. Again, my name is Ted Dickey. I live and work in Plano, Texas. This summer, I will celebrate my 53rd anniversary in the funeral service business. And the two funeral homes that have my name on the front door have a combined 72% cremation rate. So I'm pretty comfortable in speaking with, about this subject and knowledgeable about this subject. My concern here is that this bill, excuse me, undermines the sanctity of where we place the remains of our loved ones. All my years of business, I've never been asked by a family, hey, if we bury grandmother across the street, will her casket need to be moved because the cemetery is sold to a developer? That doesn't happen. That question isn't asked because you guys have enacted legislation. The State Department's oversight, State Department of Banking oversight has created a sense among the consumer that where they place their loved one's remains will remain sacred in perpetuity. This bill doesn't do that. Funeral homes are sold for real estate. Families own a funeral home in downtown somewhere, and over the years, the highest and best use of that property is no longer a funeral home. It's a big box retailer, and they sell that. I'm worried about what happens to the 250 urns with the cremated remains in the funeral home. That's a real concern. You know, here's an interesting fact. The bishop, Catholic Bishop of Dallas, has placed a moratorium on the construction of columbarium in churches. And he did it for a very simple reason. He was the bishop in another state. He was forced to sell some churches because of financial conditions. And the closing and sale of those churches was a nightmare when they contained a columbarium. He said, no more, not on my watch. So there's a concern on a lot of people about what happens when something has to be moved like that. This bill speaks of a maintenance fund, not a perpetual care fund, a maintenance fund. I'm concerned about that. There's no trusting requirements. There's no provision in here that that fund would be audited by the State Department of Banking. In fact, the State Department of Banking is not even mentioned in this bill. And that gives me and the consumer, I think, some heartburn. I don't believe that this legislation is being offered to protect the consumer or to give the consumer a product that he or she needs. I think the legislation is being offered to give the funeral home owner another revenue stream.
Mr. Dickey, I'm sorry, your time is up, sir.
Can I?
Are there any questions?
Yes.
Representative Collier?
Mr. Dickey, will you please continue with that last thought, please?
Yes, I believe this is being offered to give funeral homes another revenue stream, and that's just fine, but it's doing so in a way that exposes the consumer and our industries to some significant risk going forward. And one last final thought. I sold my businesses to a publicly traded company, and I've been working for a number of years seeing families. That company has 175 funeral homes in the state of Texas. This bill represents 175 additional revenue streams for a publicly traded company. You'd think they'd be all over this bill in support of it, but they're not, just like I'm not, because they see very clearly the risks to the consumer and to our industry in doing something like this. Thank you.
Thank you.
Thank you. Any other questions? Representative Tenderholt?
Thank you. You know, I find it intriguing that you're here against the bill, because I've had people from both sides come talk to me, and I think my biggest concern is the sale of the property. If it gets sold, I mean, you could get I'll give you an example. Arlington has a funeral home in the entertainment district that also has one in Fort Worth.
Mm-hmm.
And after I talked to both sides, I was really concerned about the fact that they're selling the one in Arlington. You probably know which one I'm talking about.
Sure.
And it's right in the middle of the entertainment district. And what would they do with a wall like this? I don't know what they would do. And I think it might be really difficult to move it. But I didn't expect, to be honest, to have people from the funeral home industry to be here and be against it. I expected all y'all to be for it. So I'm surprised, and not in a bad way.
If I were still in business, I would be opposed to it because the little cemetery that's right across the street from my funeral home has worked diligently to create new products for the cremation consumer. They have an ossuary, they have an above-ground columbarium, they have an urn garden, and they have a $10 million endowment fund to take care of those things. Why would I want to get in the business to compete with them? I couldn't. There's all kinds of issues, the security issues going forward. I just don't think it's a good thing for our industry.
I think it would be weird to sell a building that becomes office space or becomes something else, and it's either attached to it. I like the changes that were made to the bill, by the way, but I have serious concerns. I was interested that someone from the funeral home industry was here talking against it, so thank you.
Thank you.
Thank you, Representative Price.
Thank you, Madam Chair. Mr. Dickey,
Mr. Dickey,
I've got a question for you real
Sorry.
quick. Yeah, that's okay. How many years did you say you've been in the industry?
53 this summer.
53. And in that time, are you aware of any competitor that's established a columbarium that is not able to be used today because it's not legal, but if this bill passed, it would be legal?
Well, I don't know of a competitor that has a columbarium, except cemeteries.
Right.
Which are wonderful and they're trusted and, yeah, but no, I don't know of anybody who has a columbarium.
Okay, all right. Well, I have heard that there is, not used, but that there is. And I've got a little concern about that.
Yeah,
but I also have a concern of the same as Representative Tenderholt. But thank you for traveling down here to testify.
Good.
Appreciate it.
Any other
guys.
questions? Thank you, sir.
Thank you.
The chair calls Jimmy Lucas. Thank you for being here. I show that you're registered as Jimmy Lucas. You're with Lucas Funeral Home and you're for the bill, is that correct?
Yes, ma'am.
Thank you, sir. You may proceed with.
Madam Chair, members of the committee, thanks for the opportunity to speak in support of House Bill 2814. My name is Jimmy Lucas, and I serve as co-owner of my family-owned funeral home and cremation business, which consists of 15 funeral homes, an online cremation business, 2 crematories. I'm honored to lead 110 full-time and part-time coworkers, of which we serve approximately 3,100 Texans, families a year. I'm also the past president of the Texas Funeral Directors Association, and was past co-chair of the Legislative Committee for 2 years. I'll start by saying that the days of most Americans choosing casket and traditional graveside burials for their funerals are declining steeply. Cremation became the top choice in 2015 and has been climbing in popularity ever since. According to the statistics from the National Funeral Directors Association, more than half of all Americans who passed this year will be cremated. And in 20 years, that prediction is 80% will opt for cremation. And as Americans opt for cremation, the demand for cremation memorial services like columbariums will also increase. Today, Texas law restricts the use of columbariums to cemeteries and provides exemptions without regulations or oversights to religious groups, universities, and colleges affiliated with religious groups. House Bill 2814 would expand Texas law by allowing licensed funeral homes the ability to provide columbarium services to families who do not seek traditional plot and burial services. These columbarium services would be permitted under the oversight and regulatory authority of the Texas Funeral Service Commission, just as Texas funeral homes operate today. As I mentioned, current law only allows cemeteries to offer columbarium services, but that's largely because they originated alongside cemeteries as a place of traditional plot-based burial. In reality, there are 2 very different types of burial options with very different processes, cost, and long-term maintenance requirements. Additional columbariums options are needed for Texas families and should not be opposed. Unfortunately, you will hear opposition to this bill for a variety of reasons, but let me be clear, the opposition is rooted in the desire to prevent competition from entering the space. That's because Texas law allows cemetery owners to operate as a one-stop shop for funeral home services and burial options. In some cases, this works fine, but in many cases, consumers want other choices. Our law should not pick winners or losers to the detriment of consumers. the author of House Bill 2814, has listened to the concern of the cemetery industry, and the substitutes set forth for these restrictions are most comprehensive.
Mr. Lucas, I apologize, your time is up, sir.
Okay.
Does anyone have any questions? Representative Johnson?
So you want to get into the business of storing remains?
My family's, we're in our 163rd year of serving families in Texas, and lots of change has changed. And I think folks called us to serve us and to hand them off to another entity. I think we can do a better job than that.
So I'm just trying to, in my mind, deal with what I know traditionally
Sure, yes.
and where you're trying to go. So you currently cannot store people's remains.
Not for long term, not for forever, no.
And that's one of the things that has caught me is we're talking about in perpetuity.
Yes, ma'am.
Which means forever.
Yes, ma'am.
So if you start storing people's remains, you forever have to maintain. So what is your business model? What are you offering in the storage that I can't get at my church or the cemetery where my parents are buried?
I think just that it would be fully cremated remains. I think the design and the designation of that space forever, as outlined, is to overcome some of these points. I feel like that we could do a better job.
Why?
By designating that space, that we can create an atmosphere for healing for the families that call upon us. And I don't think this is a bill that every funeral home in the state of Texas would want to take on. But I think for the responsible ones that have been doing this for a long time, and there's a plan in place to do it, I think it's an option for families that are choosing cremation more than they ever have before.
Why can't you just designate yourself a cemetery?
There's a whole different kind of laws to go about owning and operating a cemetery.
So would passage of this law keep you from having to jump through hoops that you would currently have to jump through to become a cemetery to do the same thing?
It's already jumping through hoops without this. I wanted to own a cemetery, but I don't have a desire to own a cemetery. I'd have a desire to have a columbarium park, is what I would call it, on site of a funeral home, with that property being designated strictly for that forever.
Thank you.
Thank you. Representative Jones?
Was that a question? I'm sorry.
Yes, if you know, for cemeteries, let's say, I mean, I don't even know, can you sell cemetery lights? I mean, for the businesses that do cremations, what happens if they decide not to do that? I mean.
So that's a great question. There's so many things that families have the option for cremation, after cremation. Certainly columbarium is one of them for final placement. But folks are making diamonds out of their loved ones' cremations. They're launching their loved ones' ashes into space, making rocks out of their loved ones, or making keepsake jewelry out of their loved ones' cremated remains. So it goes on and on. But what I'm talking about is permanent, respectful placement.
And then my colleague said something about into perpetuity, and I've been reading the bill, maybe I'm missing something, but does it say in perpetuity somewhere?
I didn't craft the language of.
Okay, then I'll just wait for Rep. Shaheen, because I just don't see it on what I have here before me, so maybe I don't have the latest version.
There were 4 points that were brought forth for substitutions.
Oh, for the committee sub?
Yes, ma'am.
Okay, thank you.
Any other questions? Thank you, sir. The chair calls Rick Allen. Thank you, sir. I show that you registered as Rick Allen, and you're for the bill. You're with Alley Family Funeral Options, is that correct?
Yes, ma'am, that is correct.
Thank you, sir. You may proceed with your testimony.
Thank you, Madam Chairman, members of the committee. Thank you for the opportunity to speak today in support of House Bill 2814. As stated, my name is Rick Allen. I am the owner of Allen Family Funeral Options, also in Plano, Texas. I've been a licensed funeral director and embalmer since 1980 and have held various positions within our industry, excuse me, both with large and small companies and in the public and private sector. When our business was founded in 2006, we were entering a market that was quickly trending to cremation over burial. We established service offerings that allowed families choosing cremation to pay respect and honor their loved ones in a variety of ways, and the market has responded very well. One of the ways a family can memorialize a loved one is through a columbarium wall. It's used to store cremated remains of loved ones. The spaces, or niches as we refer to them, contained in these walls have memorial messages engraved on the outside and have space on the inside for stored cremains of loved ones. As funeral directors, we often find ourselves dealing with families who have chosen cremation, they've had a meaningful memorial service, but they're at a loss of what to do with their loved ones' cremated remains. Some people will choose to scatter the cremains, but there are limitations on that option. Others will bury the cremains at a cemetery if they have that option available to them. Some keep them in their home, and others who belong to a church with a columbarium might choose to place their loved ones' cremains there. But what we're talking about are the families who don't belong to a church that has a columbarium. They may be opposed to scattering. They may be opposed to burying because they don't have a place that they'd feel comfortable burying those remains, and they don't like to keep them at home. These are the examples that give us the biggest dilemma in dealing with these families. I am often asked if it would be possible for us to hold cremated remains within our funeral home until they can find an acceptable means of storing those, and funeral homes in Texas and all across the country have done that for a long time. Unfortunately, we do find ourselves holding them for a long time, sometimes even forever. Some families don't come back and we can't contact them. Oddly enough, Texas law does allow me to store those cremains in my funeral home right now. Texas law also provides me the ability to have a memorial wall on the outside of my building where we can inscribe names, messages, scriptures, verses, whatever. The problem is that may be only 20 feet away from one another. So while I'm able to hold those cremains in my funeral home, the law is prohibiting me from taking those 20 feet away and putting them in a columbarium wall with a niche that's designed for this purpose. And that part really doesn't make sense. We're not looking to bury people on the grounds of our property. We're not looking to erect monuments on our lawns. We're just simply asking to be allowed to do something that we're already doing for the most part, but to be able to do so by offering a grieving family a meaningful memorialization, not just simply storing someone's remains in a room. So our request is that state law bridge the existing
Mr.
gap
Allen?
between the storage of cremains and the proper
Mr. Allen?
placement.
I apologize, your time is up.
I'm sorry.
That's okay. Do we have any questions? Representative Price?
Thank you, Madam Chair. Mr. Allen, thank you for your testimony. My question really just goes back to the idea of what happens, you know, if this law were to pass and then a funeral home established a columbarium and then it's sold to a publicly traded company or another entity that decided that location was not, you know, appropriate for them anymore. So, you know, without being regulated the same way as a cemetery, exactly what would happen? And where would people who maybe for years have purchased space in your, or, you know, any funeral home's columbarium, who maybe live minutes away and that's why it was convenient at the time, you know, what are they gonna do and how does that all work out?
Absolutely, and that's a great question, and I would encourage you all to not be of the impression that cemeteries are in perpetuity. Cemeteries have been relocated as well. There was one near downtown Dallas that was relocated a few years ago. So cemeteries aren't always there. They do get moved. But to answer your question more specifically, I think the substitute language that Representative Shaheen has introduced into the bill will address that, because it will guarantee that through deed restrictions, that wall would remain permanent, or that there would be a permanent memorialization, or that there would be suitable replacement for that for the families who are there.
That's going to limit the number of available buyers for real estate with a wall that's a columbarium, I'm guessing, in terms of who wants to purchase that property.
Well, it's true. Our building started out as a leased facility. We now own our property, which is important, but that's now a barber shop. So, you know, those people didn't have a problem with us being a funeral home, but I don't want to sound argumentative, but I think this bill, as it has been crafted in the substitute language that's been introduced, it's going to limit the number of funeral homes that are going to do this simply because of all the barriers that we have to do that. I think only the strongest and the most stable and the ones with the intent to be permanent and not sell out to a big box store are the ones that are going to be doing this.
I'll look for that language in the substitute, but no, I meant to ask the second witness. I asked the first witness, so I'll ask you. Are you aware of any funeral home that's already invested in this infrastructure who would benefit if this bill passes that, would allow them to do something they can't do today if the bill were to pass, would be able to?
You're looking at him. Yes, sir.
Okay, you have that.
Yes. When we built our new building in 2018, it was our intent to offer this. We had hoped to gain the same exemption that churches enjoy as establishing columbariums without being considered a cemetery.
Okay.
We did get some opposition to that, so we were wanting to approach that from a different angle. But again, the point of me being able to hold them in the funeral home and put a memorial plaque on a wall outside, we're just trying to make it simple and join the two together, something we're already doing with something that families are really asking for.
All right. Thank you for answering the questions.
Yes, sir.
Thank you, Madam Chair.
Any other, Representative Collier?
Thank you, Madam Chair. You mentioned about the cemeteries having to be moved. Who pays for that when that happens?
I'm sorry, I didn't hear your question.
You mentioned about a cemetery in Dallas being moved.
Yes.
Who pays for the removal of the remains and then the reburial of them?
I think it depends on the origin of the need for the move. In that particular case, I'm not sure, but I would think the city of Dallas might have.
Okay, so maybe the city would pay for it. So under this provision of this bill that, right now, there's nothing that says that the person has to, preserve the, I guess, the land. It says perpetual, establish a perpetual care and maintenance fund. But I don't see that it has to have the, ensure that the land or wherever the columbarium, what is it? Is located. Like, there's nothing that says that you have to own it forever or you have to make sure that it stays in good care if you sell the land.
No, and I don't think cemeteries have that either. And I think in our language, there's a word, maintenance fund as opposed to perpetual care fund. And if you think about the cost of maintaining a cemetery versus the cost of maintaining a memorial wall with granite niche fronts, they're two very different animals, if you will. There's cutting the grass, mowing the grass, fixing damages, things of that sort with cemeteries that are normal that wouldn't be normal procedures with us. And I don't know that there's anything that states that a cemetery must remain owned by the same organization in perpetuity.
Okay, because it just says that you have to own the property where the funeral establishment and columbarium are located. That's just like today, you got to own it, but it doesn't say tomorrow.
Yes, and I honestly think that language was put in because there are funeral homes that are establishing.
The shopping strips.
Yeah, the shop. And that's trying to eliminate the possibility of that because the risk would be greater for that business to move and be faced with that problem.
So are there any zoning issues that you foresee by having permanent, placement of the loved one in a columbarium at the funeral home?
None that I'm aware of.
So I'm just trying to figure out, because I don't know if cities have, something for cemeteries and then something for funeral homes where they say, oh, well, neighbors, they're only going to be there for a little while, so don't, worry.
Right. When we built our funeral home, we had to request a zoning hearing, and we did have to notify neighbors in the area, and our zoning is just under general business. What we would be doing with this particular wall, delineating a section of that, identifying as something that would be in perpetuity, I guess you could say, but it would always be intended through deed restrictions to be that. Isn't really zoning, but it's a deed restriction more than anything else.
Okay, that's not in there now, but you think that that's going to be in there eventually?
Well, I think that's going to be part of the substitute
Okay.
language that's coming with the delineation and the identification of that with deed restrictions.
So visiting hours, how do you envision the visiting hours?
I think it would depend on how the wall's established. Ours that we foresee is outside. It would have 24-hour access. it's lit. It would be a very safe visiting place for people 24 hours a day.
Safe because,
Just not dark, not a place that people would feel uncomfortable going to. It would be a well-lit place if they wanted to go after hours to see their loved ones niche or to leave flowers there or something of that sort.
at the wall?
Yes, ma'am.
Is there something there that they can put the flowers in?
No.
They lay them on the ground?
Hours, and I'm only speaking for hours. We do have a ledge across the bottom that people will leave cut flowers there. We just remove them when they become unsightly and they bring them again.
Okay, so the visitation hours would be whatever they want.
And most cemeteries are that way, except they're sunrise to sunset.
Yeah, and so this is outside. These walls are outside. They're not inside the funeral home.
The ones that we are looking to establish this way, yes, ma'am.
But the bill doesn't prohibit them from having a columbarium inside the funeral home?
No.
Okay, all right, thank you.
Any other questions? Thank you, sir, for your testimony.
Thank you very much for your time today.
You're welcome, sir. The chair calls Jay Carnes. Jay Carnes.
Then James White.
James White. The chair calls James White.
Good evening, Madam
Good
Vice
evening.
Chair, members, James White, Executive Director, Texas Funeral Service Commission, on the bill as a resource.
Representative, any questions? No questions. Thank you, sir.
Thank you. Have a nice evening.
Good to see you. The chair calls James Kernling.
I guess it's good evening.
Yes, it's good evening. You're registered as James Kennerly?
Kennerly.
Kennerly, and you're with the Texas Cemeteries, is that correct?
Yes, ma'am.
And you're against the bill.
That's correct.
Thank you, sir. You may proceed.
Thank you. My name is Jim Kennerly, and I'm a Secretary Treasurer of the Texas Cemeteries and Crematories Association, made up of about 170 cemeteries and crematories across the state of Texas. But I'm also CEO of Greenwood Funeral Homes and Cremation in Fort Worth, so I've worked for funeral homes and cemeteries. And I'm also an attorney. I want to draw your attention to two statutes. One is Chapter 711 of the Texas Health and Safety Code. That is the chapter of the code that governs all cemeteries in Texas. Under that code, a columbarium is defined as a cemetery element. It's used for cemetery purposes, and that's important. It's used to inter human remains permanently. Section 711.021A says, an individual, corporation, partnership, firm, trust, or association may not engage in a business for cemetery purposes in this state unless the person is a corporation organized for those purposes. B, a corporation conducting a business for cemetery purposes, including sale of plots, may be formed only as provided by this section. Cemetery corporations are a very special entity in Texas. From its inception, a cemetery corporation must be organized for the purpose, for cemetery purposes under the Health and Safety Code. When the Department of Banking send its auditors to audit our perpetual care cemeteries, the first thing they want to see, or one of the first things, is our articles of incorporation. And one of the things they're looking for is that we were formed for cemetery purposes. And our articles go back to 1952, so this is not new. This is well established. Let me read another section, 711.052, criminal penalties. A person who is an individual, firm, association, corporation, or municipality, or an officer, agent, or employee of an individual, firm, association, corporation, or municipality commits an offense if the person engages in a business for cemetery purposes in this state other than through a corporation organized for that purpose, if a corporation is required by law. So, in my opinion, I think they not only can't do this, they really can't do this. The other statute I want to direct your attention to is the Occupations Code, and that's what governs funeral homes and funeral directors.
And the article they're trying to amend is section 651, 351. And D2 says, a funeral establishment must be located at a fixed place that is not tax-exempt property or a cemetery. You can't build a funeral home on cemetery property. Cemetery property, when you dedicate property for a cemetery, it's not subject to fees or public taxation. And we see funeral homes next to cemeteries all the time, but a funeral home is not built on cemetery property. It's on retail taxable property. And yet this bill somehow is going to allow us to go into our funeral homes and dedicate this wall or this room or this wing for cemetery uses. It just doesn't make sense.
Sir, your time is up.
Oh, I have a question.
Question, Representative Colley?
Can you finish your statement, please?
It just doesn't make sense. There's one unintended consequence. I don't think this is the reason for this law, the intent, but when you dedicate cemetery property, as I said, that property comes off the tax rolls. So if I dedicate a wing of my funeral home, why don't I just take it off the tax rolls? Can you imagine 1,600 funeral homes across the state of Texas designating rooms and wings and walls? You don't think they're going to want to take it off the tax rolls? That's a lot of real property taxes that can be saved. Now, they're going to say that's not what we want to do, and that's probably not. That's not the intent. But that's a consequence, I think. That's an unintended consequence. So we've dealt with this for 3 sessions now. And it's all coming out of Plano. And I would just ask that, can we please put the final nail in this coffin and let this be over? And I'll take any questions.
Any other questions? Thank you, sir. The chair calls Harvey Hildebrand.
Good afternoon.
Good evening. I show that you're registered as Harvey Hildebrand. You're with the Texas Funeral Directors Association. You're for the bill, is that correct?
Yes, ma'am.
Thank you. You may proceed.
I'm here, Jay Corns had to leave. He's our legislative chair. He would have spoken. Texas Funeral Directors Association, also well known as TFDA, supports columbariums in funeral homes under appropriate rules and regulations administered by the Texas Funeral Service Commission. We believe that 2814 is filed, made steps in that direction, but the committee substitute, as we understand it, has made more steps in that direction, which we applaud, and we have additional changes that we recommend to take the regulations further, and we would support the bill for that. We would support the bill now, but we want to improve the bill and perfect it through the process.
Thank you. Are there any questions? Thank you, sir, for your testimony. Is there anyone else wishing to testify on, for, or against House Bill 2814? The chair recognizes Representative Shaheen to close.
Thank you, Madam Vice Chair. So again, the whole concern about, relocation or sale of the columbarium, totally valid. When the cemetery industry came to me with that concern, I totally agree. So the committee sub that we were talking about, here's what that's going to do. It's going to take all the restrictions that are on cemeteries today in current statute. It's going to overlay them into this committee sub. So when you all see the committee sub, have your staff see if that comparison actually happens. So just have them do the comparison of my committee sub with the cemetery restrictions that are current state statute. That should address the issue, because it's a valid issue. I don't want, my relative's remains who was cremated in a columbarium that's in a strip mall that one day is going to be next to a Dickey's Barbecue or something. That's a totally valid concern. The committee sub will address that. And with that, Madam Vice Chair, I'm happy to answer any questions, and I close.
Thank you. If there is no objection, House. Okay. No questions? If there's no objection, House Bill 2814 will be left pending. The chair hears no objection. House Bill 2814 is left pending without objection.
Thank you, members.
Thank you.
Okay, the chair lays out House Bill 81 is pending business. We're going to go ahead and vote some bills so that the chair offers.
Chairwoman, may I have a moment of personal
Sure.
privilege on this vote?
Sure.
I would ask that last Friday morning, I was called into executive session in the General Investigating Committee. I sent a staff member to our meeting Friday morning to inform the chair and the committee that I was not currently available and hope that you might wait for a vote on 1686. 1686 is known as the trans bill. It is significantly important to a number of constituencies within my community who obviously want to know why my vote was not there. I was unable to be here, but I feel significantly that my absence, as well as my colleague Vinton Jones, who was also known to not be able to be here Friday morning, and also a personal member of the LGBT community, has struck a chord of cruelty with our folks. And so I would ask this committee, we know how this vote is going to go, but there are a lot of folks that feel like there's something wrong with our opinions not being able to be expressed and our vote not being able to be heard before this goes to committee. So I know that I can't make this motion to reconsider, but the majority can. And I would ask that one of you that voted to pass this out, please reconsider the fact that two members that painstakingly have spent a lot of time on this issue and working on our membership and our constituencies did not have their voices heard. We feel it's really important that we get our vote, which I know will be a no vote from me, on this bill before it gets to the House floor. And I would just ask that if there is a member of this majority that has the compassion to do that, to please do so.
Okay. The chair lays out House Bill 81 is pending business. The chair offers a complete committee substitute. Members, this is Representative Harrison's vaccine bill. The committee substitute clarifies that a doctor is not coercing or compelling a patient if they simply recommend a vaccine. Exempt entities that are subject to the CMS regulations requiring vaccines, specifies that the prevailing party can recover reasonable expenses, provides an affirmative defense for a healthcare provider if a person stated prior to receiving the vaccine that it was voluntary, and strikes language exempting the bill from the Civil Practice and Remedies Code. Are there any questions?
I don't have a question. I just want to make a statement that I don't support the findings of the legislature, but I will vote for the bill. But the findings I don't agree with. I just wanted to make sure I was clear on the record on that. I have questions about the finding in the bill.
I mean, you're voting for or against the bill.
Okay, we're voting for or against the bill. That's the matter before us. Is there any objection to adoption of the committee substitute? The chair hears none, and the substitute is adopted. Representative Price moves that HB 81, as substituted, be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Click.
Aye.
Campos. Aye. Collier. Aye. Jeton. Aye. Johnson. No. Jones of Harris. Aye. Jones of Dallas. Aye. Oliverson. Aye. Price. Aye. Smith.
Wow, I'm sorry.
This is. Tenderholt.
Aye.
It's 10-1.
There being 10 ayes and 1 nay, the motion prevails. The chair lays out House Bill 1973 is pending business. The chair offers a complete committee substitute. Members, this is Representative Harris's itemized billing bill. The committee substitute clarifies that it applies to the attempt to collect payment after services and has been provided that the amount due is not contractually agreed. Further, the provider must submit the itemized bill no later than the 30th day after the provider receives a final payment on the provided service or supply from a third party and updates the administrative penalty and other disciplinary action by licensing authority by adding a $1,000 penalty against the healthcare provider who violates the bill. Are there any questions? You should.
It's in Dropbox.
It's in Dropbox. You should. Are there any objections to the adoption of the committee substitute? The chair hears none. Do you see it in there, in Dropbox? Okay, the chair hears none. The substitute is adopted. Representative Smith moves that HB 1973 as substituted be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Click.
Aye.
Campos. Aye. Collier. Aye. Jeton. Aye. Johnson. No. Jones of Harris. No. Jones of Dallas. Aye. Oliverson.
Aye.
Price.
Aye.
Smith. Tinderholt.
Aye.
9-2.
There being 9 ayes and 2 nays, the motion prevails. The chair lays out House Bill 2651 is pending business. Members, this is Representative Howard's bill requiring certain training for persons providing care to sexual assault survivors. Are there any questions? Representative Alverson moves that HB 2651 without amendment be reported favorably to the full House with the recommendation that it do pass and be printed and sent to the local and consent calendar. The clerk will call the roll.
Click.
Aye.
Campos. Aye. Collier. Aye. Jeton. Aye. Johnson.
Yes.
Jones of Harris. Aye. Jones of Dallas. Aye. Oliverson.
Is there no sub on this one?
I don't think so.
Let me see. 26. I could be wrong.
Donna Howard's 2651 by Representative Howard.
I'm not seeing one.
I thought she was gonna change some things. She did. Well, I'm voting nay then.
Well, let me call
Hang
someone.
on just a second. We don't have it.
I want to be able to amend it if she did. She promised me certain things, so I can send it to local.
Right.
And let me check my email too, see if I missed one.
Give us just a minute.
This is the training bill, right? Yeah. She wanted 4 hours of training for everyone in the emergency room. Yes.
Those that deal with sexual assault,
The sexual assault
I think. Wasn't it sexual assault?
survivors.
What's for staff though, right? Not for survivors, it's for.
Right, the
everyone that
training,
works in
the
emergency
staff.
room, including the secretary behind the desk.
I'm not seeing.
We don't, we're not showing.
Why don't we?
I'm gonna vote nay.
Should. I think what we could do is go ahead and vote.
We're going to go ahead and vote, and we can reconsider the vote
If she does have something.
if she does in fact have one.
I
Okay.
would vote for it if we were sending it to general calendar. We
Okay.
had certain agreements that I don't see as.
Okay. Can we resume calling the roll? We'll send it to the general calendar then.
Rep. Oliverson,
So we're gonna send it to general now, or do you want me to vote nay, so it goes to general?
If you vote nay, it will go to general.
Okay, I will vote nay.
Rep. Price. Rep. Smith. Rep. Tinderholt.
Aye.
10 to 1.
Okay, there being 10 ayes and 1 nay, the motion prevails. We'll find out.
Except that it didn't reach the local consent.
And that's fine, and that's fine. It just automatically goes to general.
Is that it?
I think so.
All righty. We will call up some more bills.
Let's see, I think it's again. He's here.
Is he here?
Mm-hmm.
Okay, the chair lays out House Bill 4404 and recognizes Representative Guillen to explain the bill.
Thank you, Madam Chair. Members, Texas currently faces a shortage of healthcare providers, particularly in rural areas. This has resulted in limited access to care for patients in these regions and added burdens on advanced practice registered nurses who practice across state lines, requiring them to obtain and maintain multiple licenses. Presently, 230 of the state's 245 counties are designated as county primary care provider shortage areas.
For some reason today.
House Bill 4404 proposes that Texas enter an interstate compact for APRNs, similar to the nurse licensure compact for registered nurses and licensed practical nurses that Texas has been a member of for over 20 years. This would enable APRNs in Texas to hold a single license that permits them to practice both in person and through telehealth in Texas and other compact states. This additional mobility will reduce the burden on APRNs practicing across state lines. Moreover, the compact will benefit military families who relocate frequently, reducing barriers to employment for spouses and increasing access to care in Texas. The APRN compact has the potential to yield the same benefits for Texas patients, communities, facilities, and APRNs as the nurse licensure compact has for RNs and LPNs. I can help answer any questions if y'all have, and we do have an expert witness here from the National Coalition of State Boards of Nursing to help do so as well. Thank you.
Yes, ma'am. Thank you very much. Good evening, Madam Chair Click, Vice Chair Campos, and committee members. I am Bob Hawthorne, testing on behalf of myself in opposition to HB 404, APRN. I'll be using the phrase NP instead of APRN because it allows me to speak clearer and more rapidly. I'm the face of who this bill would affect. I'm a patient. Some people will believe the NPs are going to be a medical blessings to rural Texas and save medicine. However, that's simply not the case. They currently have no barrier to prevent them from going to rural and underserved areas to practice. The majority do not do that, even though most of Texas is rural and underserved. From my perspective, we shouldn't want them to go to vulnerable populations to practice medicine without the education or supervision to do so. No patient deserves lesser than care. Already, even now, when I call to make an appointment with the doctor, I'm always advised the doctor is not available, and an NP is available and just as good as the doctor. If I persist enough, I'm able to get the appointment with the doctor. This resistance at the level of the front desk in the education and marketing is heightened when my doctor's office was bought by private equity last year. I receive email blasts and constant tech pushes to get me into the office and preferably see a nurse or PA. Most people aren't educated on the issue and would cave to the driver of this corporate train, void of seemingly any ethical accountability. I will be a voice for the patients who do not know about this. It seems insincere and deceptive to try to pull this off. It is deceptive to bring a bill that claims to increase patient care, when in reality is serving some other purpose, to increase profits perhaps, not the sake of we, the patients. Physicians have a higher level of accountability for the care they provide. They are held to a higher standard in care compared to NPs. This level of accountability provides patients with a sense of reassurance and confidence in the care they receive. I do not want to see physicians pushed aside from the patient's medical care team, and that is what bills like this do. I hope that my perspective has provided some insight into the patient's point of view and helps facilitate a deeper understanding of patients' preferences and needs. Thank you.
Yes, ma'am. Yes, ma'am. Good evening, Vice Chair Campos and the rest of this. House Bill 4404, while at first glance it seems to be a nice, sweet little law for reciprocity of licensure between the states. There'll be several states that'll be involved with this in a compact. But it's really a Trojan horse for the expansion of the scope of practice. And they're going about it in a strange way. But instead of being a direct with what they say, they want to divorce the physicians who oversee the APs and allow them to do their own, basically, practice of medicine. They're going to hide the independent practices in these licensure bills. It is you, the legislators, as well as the physicians themselves, to protect the people from less than adequate care, as far as I am concerned, regarding the APs. In my 39 years of medicine, I've seen a lot. A lot of it's good, some of it's bad. But some things I don't think will change, and I don't want to see this happen to Texas. I thank you. I'm happy to answer any questions that you may have.
Any questions, members? No questions. Thank you, sir, for your testimony.
Thank you.
The chair calls Tilden Childs. Thank you, sir, for being here. I show that you registered as Tilden Childs. You're with the Texas Medical Association, Texas Radiology Association, and yourself, and you're against the bill. Is that correct?
That's correct.
Thank you, sir. You may proceed.
Good evening. My name is Dr. Tilden Childs, and I'm a radiologist from Fort Worth. On behalf of the Texas Medical Association and its more than 57,000 members, as well as the Texas Radiological Society and myself, we thank Chairwoman Click, Vice Chair Campos, and the members of the House Public Health Committee for this opportunity to respectfully testify in opposition to House Bill 4404. The TMA opposes this legislation because it is not really an advanced practice registered nurse license portability bill, but instead it is a bill that would preempt Texas scope of practice laws. It would grant independent practice authority to both Texas nurses as well as out-of-state nurses who obtain a multi-state license under the APRN Compact. The compact would authorize an APRN to assume responsibility and accountability for the patient care independent of any supervisory or collaborative relationship. The multi-state license would also include prescriptive authority for non-controlled prescription drugs. These provisions would supplant Texas law requiring APRNs to practice and prescribe under physician delegation and supervision. We respectfully ask that you consider the goal of this bill when you decide your position on this legislation. Is it to increase the number of APRNs in the state? Research by the Texas Center for Nursing Workforce Studies shows we have more APRNs than the projected need currently. The number of nurse practitioners in Texas is expected to grow by 117% by the year 2032, with an excess of 19,000 nurse practitioners over projected demand at that time. Physicians are united in the belief that no matter where you live in Texas, you deserve the highest level of team-based care led by a physician. I am proud to say that Texas has done an amazing job in growing our physician workforce. Physicians view our state as a good place to practice medicine. Even with decades of high population growth, Texas physician population is growing faster than the overall population of Texas. Last year, for example, Texas had over 7,000 applicants for medical license and licensed 6,500, more than 6,500 of those applicants. Those are both historic numbers, and 80% of these physicians were educated outside of Texas. We would also like to thank you and your colleagues for prioritizing state funding for graduate medical education. This has enabled the state to reach the state's target goal of 1.1 to 1 first-year GME slots for every medical school graduate. This is absolutely necessary in order to be prepared for the growing number of medical school graduates who are coming as a result of the new medical schools in the state. These efforts will allow patients, whether rural or urban, to have the same standard of care. I'm
I
through.
apologize, your time is up.
Thank you for this opportunity to testify.
Any questions?
I just wanted to make sure you've got to finish your last point.
Last point was, these efforts will allow patients, whether rural or urban, to have the same standard of team-based care.
Thank you so much. Thank you.
And I have some handouts. Do you want me to leave them on the desk here?
Sure.
Thank you, sir.
Thank you.
The chair calls Jimmy Wedmer.
I'll get him in a minute.
Thank you for being here. I show that you registered as Jimmy Wedmer, and you're with the Texas Medical Association and yourself, and you're against the bill. Is that correct?
Widmer, but yes.
Widmer. Thank you, sir.
Thank you.
You may proceed.
Good evening. My name is Dr. Jimmy Widmer, and I practice internal medicine in Temple. On behalf of the Texas Medical Association and myself, I want to thank Vice Chair Campos and members of the Public Health Committee for the opportunity to respectfully testify in opposition of House Bill 4404. As an internal medicine physician, I practice in both the hospital and outpatient settings and provide primary care for my patients. Primary care physicians provide complex chronic disease management, and in doing so, play a pivotal role in containing the cost of healthcare. Correct and effective treatment is critical to preventing more complex health conditions that can lead to increased specialist care, ER visits, prolonged hospital stays, and not to mention more time away from jobs and family. While APRNs are a critical part of my healthcare team, expanding their scope of practice is not the answer for better patient care. We can learn from experiences in other states that have tried this. One example is the Hattiesburg Clinic in Mississippi, which conducted a pilot allowing APRNs to function with separate primary care panels side by side with their collaborating physicians. After assessing outcomes over a 2-year period, the clinic reverted to their original model of physician-led, team-based care. Their findings revealed, number one, physicians performed better than non-physician practitioners on 9 of 10 quality measures. Things like blood pressure control, diabetes control, vaccination rates. Number two, patients who had a non-physician as their primary care practitioner cost almost $43 more per member per month than those who had a physician. When adjusted for patient case complexity, the difference increased by almost 3 times to $119 per member per month. And third, non-physician practitioners had a 7% higher rate of referral to a specialist. TMA strongly opposes this legislation because this bill is not really about advanced practice registered nurse licensure portability, but as has already been said, it's actually a vehicle to supplant existing Texas law and expand APRN scope of practice. Again, this bill would allow APRN licensed through the compact to, number one, independently practice, and number two, prescribe non-controlled substances. This would supplant Texas law limiting APRNs to practicing and prescribing under physician delegation and supervision. Access to care improves with appropriate physician-led, team-based care models, which promote oversight and collaboration while keeping patient safety the priority. Each member on the healthcare team serves an incredibly important purpose. To dissolve this care model by supplanting state law is the wrong thing to do for healthcare. Thank you for the opportunity to testify, and I'll take any questions.
Doctor, thank you for being here.
Yes, sir.
Tell me again what it is you believe is within this Trojan horse, so to speak.
So, yes, sir.
Would expand upon Texas law?
Yes, sir. So number one, allowing for the independent practice of nurse practitioners, APRNs, and the prescribing of non-controlled substances without that physician supervision.
And so if those two things were taken out of the bill, would you be in favor of it?
I would take a look at that and take it back with the Council on Legislation and review.
Okay, all right, thank you.
Any other questions? Thank you, sir. The chair calls Nicole Livanos. Thank you for being here. I show that you're registered as Nicole Livanos. Is that correct? You're for the bill and you're with the National Council of State Board of Nursing?
Yes.
Thank you. You may proceed with your testimony.
Thank you so much, Chair Click, Vice Chair Campos, members of the committee. Thank you for allowing me to be here today. Again, Nicole Livanos with the National Council of State Boards of Nursing. So House Bill 4404 would enter Texas into the APRN compact, and this bill should look familiar. The compact is modeled after the nurse licensure compact. It's the first healthcare licensure compact, and Texas has been a member of that compact for over 20 years. So the APRN compact, just like the NLC, works by an APRN holding one license, which is issued in their primary state of residence, with the privilege to practice in all states that are party to the compact. Like the NLC too, the APRN compact adopts the highest standards for licensure, education, certification, and accreditation to ensure that multi-state licensees are safe and qualified providers as they practice across state lines, either in person or electronically. Importantly, prior to obtaining a multi-state license, all applicants must first meet uniform licensure requirements and their home state requirements in their primary state of residence prior to practicing on a multi-state license. The APRN compact has a similar governing structure to the NLC, and that is there is an APRN compact commission, and that commission does not have any authority over scope of practice. They're not going to be making determinations that are going to increase the scope of services that APRNs practicing and treating Texas patients can provide. Rather, the rulemaking and by the commission is solely for the operations of the compact. Again, identical to the compact that Texas has been in for registered nurses and licensed practical nurses for over 20 years. The compact also maintains Texas's Board of Nursing's authority over licensure and enforcement of the Texas Nurse Practice Act. And under the APRN compact, just like the NLC again, practice takes place where the patient is located. So the scope of services a multi-state license holder can provide to patients that are located in Texas, whether providing that care electronically or in person, is identical to those services that APRNs in Texas can provide today. APRNs in Texas have prescriptive authority today. The same laws, rules, and regulations governing controlled substances in the state of Texas will apply for any APRN practicing here under the compact license. APRNs are highly trained professionals that patients across the state already rely on today for primary specialty and anesthesia services. APRNs with a multi-state license can reach more patients, whether it be through the rapidly evolving and advancing telehealth industry or in person, especially on bordering states or around the bordering states. APRN Compact can also be a necessary tool for disaster preparedness and for addressing the current healthcare access emergency in the state. Thank you.
Thank you, ma'am. Any questions? No questions. Thank you for your testimony. The chair will call Anisha Mahorta. Is that correct? Please state your full name, who you're with, and your position on the bill.
My name is Dr. Anisha Malhotra. I'm testifying on behalf of Texas 400 and myself in opposition to House Bill 4404. Good afternoon, Vice Chair Campos and committee members. I know you guys have heard a lot, and I was actually going to say a lot of the same things that had already been mentioned, but I'll try to stick to some of the newer stuff. So as it's already been said, that it seems like this is really just about reciprocity between states, but unlike other compacts, this one will supersede Texas law and cedes the Texas legislature's authority to determine how advanced practice registered nurses would treat and prescribe. So in the way I see it is that this bill is basically undermining this committee's ability to determine, if NPs really should be having independent practice or not. I think one thing that we also need to make sure is understood is that when we're talking about APRNs, this is including nurse anesthetists, nurse midwives, nurse practitioners, and clinical nurse specialists. So I believe the gentleman with the TMA was saying that this bill will, it has language that's going to basically, excuse me, sorry, I lost my place. So this bill is going to have language that's going to remove prescriptive authority for nurse anesthetists. So what this means is that they can administer anesthesia without an anesthesiologist, which I think is very dangerous. Texas 400 is objecting for the same reasons that you've already heard. I just would really urge you to consider the actual wording in the bill, because there is one part that says that it will allow APRNs to practice, quote, independent of any supervisory or collaborative relationship, end quote. Thank you.
Thank you. Any questions? No questions. Thank you for your testimony. The chair calls Teresa Tran. Thank you for being here. I show that you registered as Teresa Chan. You're with TMA and you're against the bill. Is that correct?
Yes, ma'am.
Thank you. You may proceed with your testimony.
All right. Thank you, Chair Click, Vice Chair Campos, and committee members. Again, my name is Teresa Tran. I'm an emergency medicine physician out of Houston, and I'm representing the 57,000 members of the Texas Medical Association, reverently in opposition to House Bill 4404. I've been practicing emergency medicine for 10 years, during which time I've had the opportunity to supervise some amazing nurse practitioners. But I can't say that my clinical observation is that having them practice independently would be good for patients. And in fact, there's a study out of Stanford that was written for the VA and for the National Bureau of Economic Research that shows that independent practice nurse practitioners cost the VA system $74 million a year extra due to a lack of skill. They have a greater hospital utilization rate that is unnecessary in 20% extra unnecessary hospitalizations and more studies that are unnecessarily performed. But more importantly than cost is the issue of patient safety. Standing in the back is one of my trainees, Dr. Lauren Bayless. She's here as an emergency medicine resident, and by the time she graduates, she will have completed 10,000 hours of training before she's even allowed to apply for certification versus the 750 hours of a nurse practitioner. So imagine if you or I had our lives in the balance and we had to go to the emergency department. It is Dr. Bayless who is qualified and has the gestalt and the instinct that is well educated by her education that I would want leading my resuscitation team. So allow me to close on that point by actually quoting another study written this time by nurses, 8 nurses, 4 of which are nurse practitioners, published in 2022 in a nursing journal, a public health study that spanned the nation. And I'm going to quote verbatim. In conclusion, extensive variability exists across the academic preparation of NPs working in the ED setting, as well as in the licensure and certification requirements governing NP practice in EDs. Until this variability is resolved, we conclude that NPs should not perform independent, unsupervised care in the ED, regardless of state law or hospital regulations, in order to protect patient safety. I pray that it stands that this committee supports patient safety for Texans, and therefore I thank you for allowing me to testify in opposition of 4404.
Question, members? Thank you. Chair calls Patricia Aronen, and she will be followed by Alina Scholler.
Representative Click and other members of the committee, thank you for allowing me to testify today. I am Dr. Patricia Aronen, and I'm here representing myself and Texas 400 in opposition to this bill. As you've heard, while it's suggested that the purpose of the bill is to increase the healthcare workforce in Texas by making it easier for the APRNs to get their licenses, it's actually another scope bill, increasing the risk to public safety by removing the ability of the state to regulate the licenses of those who want to practice here. Earlier this year, the Federal Office of Inspector General announced the results of Operation Nightingale, a multi-state law enforcement action against individuals engaged in a scheme to sell transcripts from accredited nursing schools and fraudulent documents to allow people to sit for the NCLEX exam to get a nursing license. And then many of those people went out and were hired to practice in hospitals and nursing homes across the country, including Texas. Many of them also went on to get additional online training and became APRNs.
Excuse me, I have no evidence that they became APRNs. Can you provide the evidence?
I don't know that in Texas, but it has happened. There are documented.
We've taken action with other legislation on that issue, but none of them were APRNs in Texas.
Okay.
I verified that.
Okay. I will go back and check on that. In any event, there were certainly nurses who got nursing license through this process. Is that correct? So many of those individuals went on and practiced as nurses. The indictment of an individual from Texas involved in the scheme specifically says that the nursing compact that we are already a part of for RNs and LPNs facilitates licensing by allowing nurses with a license in a compact state to be licensed in another compact state. State nursing boards rely on the diplomas and transcripts attesting that that individual actually attended an accredited nursing school. Unfortunately, as this Operation Nightingale demonstrated, that didn't happen. And so individuals were allowed to become nurses. What's distressing is to realize that this was a well-intentioned thing, the nursing compact. It sounded good to begin with, but it allowed, because of lack of rigor, it allowed for mishaps to occur. This event should raise some serious concerns about expanding the nursing compact to APRNs. There's already a lack of standardization of nurse practitioner education. Removing further control of licensing from the APRNs by allowing those licensed in other compact states to automatically be licensed in
Your time
Texas is a risky move. Individuals who are residents of Texas who were involved in that scheme. And so there's no reason to think that it couldn't continue on.
Your time has expired. Thank you. Questions, members?
Madam, can I just tell
Your time
Representative
has
Smith just
expired.
one thing? If you want to just look in the section, it's Article 3, Section H, that specifically indicates in the bill that it will grant them full practice authority.
Chair calls Alina Scholler. Up next on deck will be Sava Rizvi.
Saba had to leave, so you can skip over her. Good afternoon, everybody, again. Madam Chair, Click, and committee members, I'm Dr. Alina Scholler, here for Tex 400 in opposition to House Bill 4404. Texas 400 is a group of 600 plus patient advocate physicians across the state, and we appreciate the opportunity to have shared our concerns today on HB 4404 relating to the APRN compact. We find that entering into this specific compact would directly undermine the Texas legislature's authority to determine how APRNs treat patients and prescribe for Texas patients. First, from a pragmatic perspective, although intended to simplify licensure reciprocity, joining the compact would in fact complicate Texas's existing compact for nurse licensure enacted by the 85th legislature. It's not clear how its provisions would interact with House Bill 4404, with both addressing similar subject matter and both allowing their respective compact commissions to engage in rulemaking that has the force and effect of statutory law. Second, the compact would circumvent legislative authority to allow APRNs with its multi-state license from out of state to come into this state with its commission authority instead of Texas legislative authority, according to Article 3, F, G, and H in this bill, which, quote, assumes responsibility and accountability for patient care independent of any supervisory or collaborative relationship, end quote. And goes further to say that multi-state license would also include non-delegated independent prescriptive authority for non-controlled prescription drugs. These provisions would undermine existing Texas law and keeps patients safe, that keep patients safe with APRNs practicing and prescribing with physician delegation and supervision. Third, and finally, the AANP has itself opposed this very compact bill since 2020 because of its inclusion of a minimum number of practice hours as a prerequisite for multi-state APRN licensure. They claim that APRNs are prepared for safe entry to practice at the point of graduation. Even a physician at the point of graduation would never say that they are ready for independent practice. That's something that we just wouldn't claim. Yet here they are with 500, 600, 700 hours of clinical shadowing, claiming to be safe at the point of graduation. So in our estimation, House Bill 4404 can't proceed past this point. Thank you, and I'm ready for any questions.
Questions, members? Thank you.
Thank you.
Chair calls Anna Allred. I show you registered as Anna Allred, and you're representing the Texas Society of Anesthesiologists, the Texas Medical Association, and yourself. Is that correct?
Yes, ma'am.
Alrighty, please, and you are against the bill. Please proceed.
Chair Click, Vice Chair Campus, and members of the committee. My name is Dr. Anna Allred. I am here today representing the Texas Society of Anesthesiologists, the Texas Medical Association, and myself in respectful opposition of 4404. I am a board-certified anesthesiologist practicing in Richmond and serve as a Governmental Affairs Committee Chair for the Texas Society of Anesthesiologists. I appreciate the opportunity to speak to you today in opposition to HB 4404, which, if passed, will decrease the quality of healthcare in Texas. The bill would authorize a new license for advanced practice registered nurses, which includes certified registered nurse anesthetists. The bill would allow all APRNs and therefore CRNAs to practice in multiple states and to do so without supervision of a physician. More specifically, This bill explicitly supersedes state law and allows for unsupervised nurses to practice medicine in the state of Texas. Article 3, Section H states, quote, "An APRN that is issued a multi-state license is authorized to assume responsibility and accountability for patient care independent of any supervisory or collaborative relationship, and that this authority may be exercised in the home state and in any remote state in which APRN exercises a multi-state licensure privilege," unquote. Unlike other compact bills this committee has already discussed, this bill expressly supersedes state law, overriding the will of this legislature and effectively lowering the standard of care for Texas patients. In addition, this bill would create a new independent interstate commission of APRN administrators that will write its own rules, bylaws, and regulations, as well as governance and procedures. While this is not uncommon for compacts, the powers given to the non-elected members of this new commission are concerning. For instance, this bill states that, quote, "The commission will promulgate uniform rules to facilitate and coordinate implementation and administration of this compact. The rules will have the force and effect of law and shall be binding in all party states," end quote. The commission, not the state legislature, nor the Texas Nursing Board, would regulate APRN practice in the state of Texas. This bill is a threat to patient safety and the practice of medicine in Texas, and I ask for your respectful opposition of HB 4404. Thank you for your time, and I'm happy to take any questions.
Question, members? Ready, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 4404? The chair recognizes Representative Guillen to close.
Thank you, Madam Chair. Members, we'll work with all parties and see if we can get you something better as soon as possible.
All righty. If there's no objection, House Bill 4404 will be left pending. The chair hears no objection. House Bill 4404 is left pending without objection. The chair lays out House Bill 1105 and recognizes Representative Price to explain the bill.
Thank you, Madam Chair, members of the committee. I appreciate the opportunity to bring up House Bill 1105 that involves immunization by a pharmacist. For most of you, this is not a new issue, nor is it a new bill. This bill passed this committee unanimously last session and passed out the House floor 137-7. For more than 20 years, trained and certified pharmacists have been safely vaccinating Texans via physician's written protocol. Current Texas law permits pharmacists to independently order and administer the influenza vaccine to anyone 7 years of age or older. Also, Texas pharmacists may order and administer any vaccines or immunization without a doctor's written protocol for anyone 14 years and older. During the COVID-19 pandemic, however, in August of 2020, the federal government preempted state law to allow pharmacists to order and administer all routine FDA-approved vaccines to children aged 3 or older. Basically, this bill extends what pharmacists have been doing for the last 3 years. House Bill 1105 seeks to make permanent in Texas statute the authority for pharmacists to order and administer all recommended vaccines for patients aged 3 and up. It amends the occupations code to allow pharmacists to independently order or administer an immunization or vaccine to a patient who is at least 3, clarifies the ability of a pharmacist to administer a vaccine to a patient younger than 3 under a physician's written protocol, requires the pharmacy to report administering a vaccine to the physician of record, if any, and to report to the state immunization registry, directs the Board of Pharmacy to specify the conditions and ensure adequate certification and training under which pharmacists may order or administer an immunization or vaccine, removes the condition precedent that a licensed healthcare provider is not reasonably available to administer a vaccine, eliminates the prohibition on in-home administration, and allows the pharmacist to delegate the administration of immunization to a certified pharmacy technician under the direct supervision of a pharmacist. Again, this has been allowed for almost 3 years, and the bill allows this practice to continue. Pharmacies are located everywhere, virtually everywhere, making access very convenient and often accessible without an appointment, even after hours and non-school hours. Members, pharmacists immunization has been essential in rural areas of the state, which has more limited access to health care. HB 1105 does not require that people be vaccinated, whether at a pharmacy or at a physician's office. The bill is not a mandate, nor does it require all pharmacies to provide these valuable services. The bill simply allows the pharmacies that want to provide immunizations the ability to continue to do so and allows parental choice for, when, and how they choose to get their children immunized. I respectfully ask the committee favorably report the bill, but I'm happy to answer any questions and would like the opportunity to close.
Question, members? All righty, we'll reserve your right to close.
Thank you, Madam Chair.
And begin public testimony. Chair calls Randy Martin. Up on deck next will be Valerie Smith, and then Ellie Studard. I have you registered as Randy Martin.
Yes, ma'am.
And you're with the Texas Society of Health System Pharmacists and yourself, and you're for the bill, correct?
Yes, ma'am.
All
Thank
righty,
you.
please begin your testimony.
Thank you again for your time. I'll be brief. I know it's been a long day for you all. As stated, I'm the president for the Texas Society of Health System Pharmacists, and I want to thank you for the opportunity to testify. As you all know, childhood immunization rates have decreased over the past few years. Pharmacists are able and willing to help. Pharmacists and pharmacy technicians have capacity to meet the need. From 2019 to 2021, as vaccine need increased, we saw the number of vaccines administered by pharmacies quadruple in the state of Texas, from 5 million to just over 16 million. For decades, pharmacists have demonstrated their ability to safely administer vaccines. Pharmacists have the necessary educational background, receive adequate training to safely administer vaccines, including 20 hours of comprehensive education specific to vaccine administration, in addition to CPR certification. Today, all Texas pharmacy graduates receive an immunization certification, which is regulated by the Texas State Board of Pharmacy. Pharmacies, as mentioned by Representative Price, are more convenient to patients. Over 30% of all vaccines administered in a pharmacy actually occur outside of traditional office hours. Lastly, there may be some questions about how pharmacy technicians fit into this and if they're qualified and if they're capable. One thing that's important to mention here is that pharmacy technicians, first off, have been administering vaccines over the past few years. And they're kind of an important and often overlooked part of our workforce. We actually already entrust pharmacy technicians with some quite critical tasks. If you've been in the hospital and you've received a compounded IV medication, it's most likely been prepared by a pharmacy technician under pharmacist supervision. My point being is that there are far more delicate tasks that we already ask of pharmacy technicians. And I'm happy to take any questions. Lastly, if I may, there were some inaccuracies that were stated for the record earlier by my medical colleagues about the education and training of pharmacists. I would love the opportunity to correct that if you would allow me.
Members, do you have questions?
Thank you, Madam.
Representative Price.
Thank you, Madam Chair. Mr. Martin, that last comment, I just wanted to ask you to go ahead and expand on that, please.
Thank you. So I've actually had the privilege of being faculty at both College of Pharmacy and 2 colleges of medicine, one an MD program, the other a DO program. Earlier, my medical colleagues suggested that our education was primarily pharmacology, and that we don't learn about treatment and drug interactions and those types of things, and that simply isn't the case. We actually have a comparable number of hours that physicians do, between 180 and 220 hours to complete our degree, as well as physicians. The key difference is the lens at which we look through the patient. We both treat patients centrically. However, we do focus more towards the medications, but we're not oblivious to the other things peripheral to that. We do learn how to treat, we do learn how to prescribe appropriately, and we do learn how to monitor that therapy appropriately. Thank you.
Other questions, members? Thank you for being here.
Thank you.
Valerie Smith, Ellie Studard. I show you registered as Valerie Smith, and you're representing the Texas Pediatric Society, TMA, the Texas chapter of the Academy of Family Physicians, and the American College of Physicians of Texas, and yourself. Is that correct?
Excuse me, sorry, for this bill, it's the Texas Medical Association, Texas Pediatric Society, and the American College of Physicians. So not TAFP.
Okay, I'm sorry, which one?
The Texas Academy of Family Physicians.
Okay, and you're not representing that one?
Correct.
Okay, and can we change that on your registration?
Yes.
Okay, and you're against the bill?
Correct. Good evening. Thank you for the opportunity to provide testimony today. My name is Valerie Smith, and I'm a pediatrician from Tyler. I appreciate the chance to testify on behalf of the combined membership of the Texas Medical Association, the Texas Pediatric Society, and the American College of Physicians, Texas chapter. We are testifying in respectful opposition to House Bill 1105, but we want to thank Representative Price for his time and open door when discussing this important topic. While we understand the intent of HB 1105, we want to ensure that we take a holistic approach to maintaining comprehensive best practice healthcare for Texas children. This bill allows pharmacists to provide all vaccinations to children down to age 3. Current Texas law only allows pharmacists to administer vaccinations to children aged 14 and above and flu immunizations to children 7 and older. Flu was specifically carved out like this for public health purposes. Our flu vaccination rates in Texas are consistently low, and it's a vaccine that's required annually, making it challenging for physician offices to vaccinate all eligible children. Routine childhood vaccinations, on the other hand, are best delivered in a medical home. Our current system allows physicians and pharmacists to collaborate within the best practice guidelines to ensure that the health and well-being of children is served. We know that the best practice provision of health care for children occurs within a medical home with a physician-led team. As a pediatrician, I can holistically address each child's unique health needs, develop relationships with families, and foster trust. For families who have questions about immunizations or are hesitant, it's these trusting relationships between physicians and patients that can help parents understand the benefit of vaccination. The data shows that physicians in Texas already do an exceptional job of delivering vaccinations to Texas children. While pharmacies support seasonal vaccinations like flu and COVID-19, it is important. It should not replace the best practice care that is already provided in the medical home. No group appreciates the importance of vaccines more than physicians. However, fragmenting children's care via one-off visits at pharmacies leaves children vulnerable to missed screenings, diagnoses, and care that a child's primary care physician could catch. For example, I recently saw an adolescent who was in clinic for a visit to receive their HPV vaccine. Her depression screen was positive during that exam, and we were able to connect her with outpatient behavioral health resources through the Child Psychiatry Access Network, develop a safety plan with her parents, and arrange follow-up. This child now has a path to healing before she was in crisis or developed suicidal ideation. Otherwise, I likely would have seen her when she reached that crisis. Physicians overwhelmingly participate in the Texas Vaccine for Children program, while pharmacies refuse to do so. TVFC provides free or low-cost vaccines to children who are uninsured, underinsured, on Medicaid or the Children's Health Insurance Program. More than 52% of children in our state. Nearly 2,800 physician offices, clinics, and hospitals across the state participate in VFC, while only 14 pharmacies are currently enrolled. Despite being able to provide flu to children down to 7 and being granted authority to administer all vaccines during the COVID-19 public health emergency through the PrEP Act, pharmacy engagement remains low. The corporate pharmacies claim this bill is designed to improve access to vaccines in communities without participating in VFC. We are failing to serve a significant portion of our population. While TVFC requirements do create considerable administrative and financial burdens for providers, physicians are willing to take on this extra layer of complexity, often at a financial loss, because they believe so strongly in the benefit of vaccination for their parents, and we want to take care of all children. Finally, I'd like to point out that the current system is working well and ensures high vaccination rates. The federal authority granted to pharmacists during the pandemic has not curbed drops in vaccination rates.
Your time's expired. Thank you. Questions, anyone? Yes. Representative Price?
Thank you, Dr. Smith. I appreciate your respectful opposition. I respectfully disagree, but thank you for coming today to testify. the points that were made were almost identical to the points that were made before this committee 2 years ago. And so I guess a couple of questions. Do you know how many Texas children have a medical home right now?
It's a really great question. And we know that all children who are enrolled in Medicaid are required to have a primary care physician in a medical home. We don't have great data on privately insured children.
In 2021, the Kaiser Family Foundation study indicates it's 42.7% of children in Texas have a medical home. And so I take some exception to the fact that, you know, that argument means that kids won't get a well checkup, because a lot of them, over half of them, if that's true, aren't getting that care right now anyway. And so while I think counseling is part of the process is very important, and I don't think anything should take the place of a well visit. I really don't. I think that is something we heard 2 years ago. And, you know, if you can point me to all the adverse outcomes that have occurred over the past 3 years, because I've talked to Dr. Schufert at DSHS, I've looked at the data myself, I don't see it, and I'd be interested in how many, you know, you can point to.
Yeah, so I'd like to speak to that study just a little bit. That study was asking families whether they had received a set of 16 different services that essentially is what you would call a capital in medical home. That is a process that physician offices and clinics can go through to be certified in a very specific way. So it's really not a good proxy for who has access to a pediatrician and routine preventive health services. That's where I think that challenge is with that 42% number.
So we can agree to disagree on that, but what about the adverse outcomes statewide?
So the other thing that I would just point out is that during the time that, during the COVID pandemic and the PrEP Act, while pharmacies have had the ability to vaccinate all children, nationally, they've only provided 2.48% of routine
I'm not talking
childhood
about
vaccines.
nationally, I'm just talking about here in Texas, what we've done in 3 years. What can you point me to specifically? Because you're here testifying, and you said that all these things would happen, but I'm curious about what has happened. Because unlike other bills that we've heard today, this has actually been practiced now for 3 years. So we have outcomes to measure, we have things to look at. But the testimony I heard was almost verbatim what I heard 2 years ago.
So I'm not sure exactly what kind of adverse outcomes you're looking at. I will say that during that.
But let me ask you this way, maybe this is an easier way. And it would be fine if it is, but is the opposition more based in, you know, like this lane is for this practice, this lane is for our practice, and you know what I mean, like a scope or a crossing of the lines? I mean, is that more what it is? Because if that is, I mean, again, I can understand that.
So we certainly are concerned that if children are receiving vaccines in the pharmacy setting, that they won't be receiving other preventive care potentially that they need. I would just also point out that as we have had the ability for pharmacies to provide all of these vaccines for children, they've chosen, again, overwhelmingly not to participate in VFC. And our vaccination rates have actually decreased, right, during that time frame. So it hasn't changed access, or it hasn't improved vaccination rates. I really think the way to improve vaccination rates is education about vaccines and development of relationship with families.
Okay, thank you for answering the questions.
Other questions, members? Dr. Alverson?
Thank you, Madam Chair. Yeah, I guess I wanted to ask about this too, because I think, and I've sort of been listening to this whole conversation all session long. So there are requirements for vaccinations with regards to schools and certain other activities and things like that, right? And so it is the case then that with respect to some of the concerns you raise, it certainly is the case that for a lot of families, for a lot of parents, that's sort of what gets people's foot in the door as far as a well child visit, right? I mean, a lot of that other stuff is critically important, but it doesn't prevent a kid from registering for school or it doesn't create a barrier. And so if you have a family that, you know, for whatever reason decides, well, they're just going to get the shots and go, and they're not getting a school physical for sports or something like that because it's a young child or whatever, or maybe, I don't know, maybe daycare or whatever, it does actually impact the possibility of getting those other preventive, you know, milestone checks. And there's a lot going on, right? At a young age, there's a lot going on in a child's life that needs to be assessed way above and beyond just, you know, the ability to give a vaccination, that you can pick up on disorders of growth, you can pick up on metabolism disorders, vision, hearing. I mean, there's a lot of things, right? Fine motor. I mean, you probably pick up kids that have muscular dystrophy and other things during those years, and those are things that need to be addressed. So, I mean, if you do miss that physician visit, I guess that's the thing is, I mean, just try to figure out, I'm sensitive to what the author is trying to do, because I do think it'd be great if we could increase vaccination rates, but
Me too.
we don't want people to not go to see the doctor and get all that other really important preventive stuff that the pharmacists are just not properly trained or equipped to do.
It's not even that they're not trained, it is just not what they do. It's not the scope
Well,
of their job.
I mean, agreed. I think we're in agreement. They don't have the training, nor should they be involved in the medical care of the child, right?
So I will,
I mean, how do you make that, how do you bridge that divide?
I mean, I will use another example from one of my own patients who came in for 11-year-old vaccines. As those of you all who have children may know, that's a time where often children are required to receive vaccines at 11 for school attendance. And so came in to get those vaccines, but in doing their growth assessment, their nutrition assessment, doing their physical exam, I recognized that there were some concerning findings related, he had obesity and some other concerning physical findings. And we screened at that visit for type 2 diabetes, and he in fact had type 2 diabetes, and started to receive, saw the endocrinologist and started to receive treatment for that. The vaccines are what brought him into my office. It wasn't the concern about the dark spot on his neck.
Yeah, and so I think the thing is, like, I would say, like, I'm not, as a fellow physician, I'm not totally, opposed to the idea of doing whatever we can to make sure that kids are getting vaccines, but I share your concern that I have not heard any legitimate solution presented that would help connect those kids with the pediatrician's office, that I've been convinced that they would actually make those appointments if the only thing bringing them in at that point was to get the vaccine. So, I mean, I'm obviously looking for a solution too, and I want to see, as I know you do, I want to see that, that we're getting those things done, but I also don't want to see kids miss out. So I just want to say, I hear what you're saying, and I'm still looking for the answer myself. Thank you.
Other questions, members? Thank you.
Thank you.
Chair calls Ellie Studdard. Up next on deck will be Anisha Malhorta, and then Michelle Evans. I show you registered as Ellie Studdard, and you are representing the Texas Pharmacy Association and yourself, and you're for the bill. Is that correct?
Yes, ma'am.
Okay, please begin your testimony.
Thank you. Good evening, Madam Chair and members of the committee. My name is Ellie Studdard, and like mentioned, I am a pharmacist. I am a director of immunization services for Terrytown Pharmacy here in Austin. I am testifying today on behalf of myself and the Texas Pharmacy Association in support of House Bill 1105. Pharmacists are highly educated, well-trained, and experienced immunizers, well-positioned to collaborate with primary care physicians to improve the childhood immunization rates. From 2016 to 2020, Texas pharmacists administered more than 20 million vaccine doses across the state, and those numbers skyrocketed during the pandemic as patients chose to receive immunizations at their local pharmacies over other healthcare settings. I want to share with this committee some of what our pharmacy did in response to the need for increased vaccinations across vaccination access during the pandemic. Terrytown Pharmacy also operates a long-term care pharmacy and has provided pharmacy services to group homes across the state serving individuals with intellectual and developmental disabilities, or IDD. When the COVID-19 vaccine became available, we were contacted by these group homes serving the IDD population because they did not have an access point to obtain necessary vaccinations. We created a mobile clinic team that ended up traveling across the state, including El Paso, the Rio Grande Valley, East Texas, Amarillo, providing over 30,000 requested immunizations to this fragile population. Pharmacies like ours were willing to step up and fill this healthcare void then, and we are willing to continue to do so and be a critical access point in the future. I want to remind the committee that the Federal PrEP Act authority was granted to pharmacists prior to the approval of any COVID-19 vaccine. This was in response to the need for pharmacists to play a role to help get children vaccinated, as childhood immunization rates for the recommended vaccines has fallen behind during the pandemic. Patients regularly bring their kids to our pharmacy for their needed childhood vaccinations. Many of them may not have a regular pediatrician or primary care doctor, or perhaps they cannot book a timely or convenient appointment. Besides offering a full range of the recommended immunizations, we continue to provide children with the recommended vaccinations for measles, mumps, and rubella, polio, chickenpox, as well as catch-up for hepatitis A and B vaccines. We also receive referrals from pediatricians who may not have a vaccination in stock or choose not to carry it due to the large quantity order size. Additionally, we counsel patients on the importance of the annual well-child visit when we administer any vaccination to a child. We work closely with pediatricians in our community, and some of them simply do not want to stock or provide immunizations when they can instead coordinate with our pharmacy to serve their patients. The pandemic showed us just how important pharmacies are as an access point for immunizations. Our pharmacists and thousands like us have gone above and beyond to serve our fellow Texans, and we want to continue to do so, but beyond the expiration date of the Federal PrEP Act in October of 2024. I also wanted to touch on the point that was previously made about the Texas Vaccine for Children program. While it is true that many pharmacies do not participate currently, that's because this has been a temporary act and we weren't previously allowed to vaccinate children under the age of 14. So should this bill pass and that become permanent, you'll see pharmacies like ours looking into becoming providers into that program as well. Thank you for providing me with the chance to testify. I urge you to support House Bill 1105, and I'd be happy to answer any questions that you have.
Question, Representative Smith.
Yep. Thank you for your testimony. You alluded a little bit a moment ago to the history of the PrEP Act. And for the ignorant folks here like me, can you please kind of give us a little bit of history on how long we've been doing this, what we've been doing, so that I can have a little context?
Yes, absolutely. So the PrEP Act, if I'm correct, was enacted in August of 2020, which was prior to any vaccination approval for the COVID vaccine, which happened in the late 2020, early 2021 when those became available. It was in order to increase access points for immunizations during the pandemic when many providers were only seeing patients virtually, and a lot of patients were not able to come or did not want to go into offices for vaccines. And we saw that with children as well, parents not wanting to take them into pediatricians' offices, primary care offices, while everyone is staying home, being extra careful at the height of the pandemic. So it increased.
I don't want to put you on the spot, but
yes, of course.
You said it was enacted before the pandemic. What was it enacted before the pandemic for?
So it was enacted before the COVID-19 vaccines were released, but it was during the pandemic too.
As a result of the pandemic?
As a result of the pandemic,
oh,
yes,
okay,
sir.
I see. All right.
Yes, thanks for clarifying.
Okay, thank you.
Other questions, members? I want to thank Tarrytown for all the work they did in long-term care. That was a really blessing to, especially the IDD community around the state. Y'all really stepped up to the plate and filled a need. So thank you for that.
I appreciate that. It was the most special thing I've ever been a part of, for sure.
Thank you. Other questions, members? Ready? Thank you for being here.
Thank you for your time.
Anisha Malhorta and Michelle Evans. I show you registered as Anisha Malhorta. and that you are representing Texas 400 and yourself, and you're against the bill.
I promise I'm not against every bill. So I do also just want to say, with regards to the pharmacy education, I completely agree. Their knowledge of medications are very in-depth. My point was more about the ability to do a physical exam, differential diagnosis, and all the other parts that we need to do in order to provide full care, holistic care. So my main concern about this bill is that, and it's kind of been touched on already, is that, and I want to say I get my flu shot, my COVID shot from my local pharmacy as well. Those vaccines are not live vaccines. Some of the childhood vaccinations are live vaccinations, and that matters because there are certain kids, especially those who have weakened immune systems, who we need to be careful about when we're giving that. There is also considerations, for example, if they recently were on extended period of steroids, we want to be careful about giving them live vaccines as well. So I'm not a pediatrician, but the reason I'm bringing that up is because pharmacists aren't pediatricians either, right? So we really want these kids to go to the pediatrician where they can have a holistic picture of the patient. They know the patient's history, any complications they might have if they're given the wrong vaccination at the wrong time or the wrong dose. My final concern is that pharmacists are not trained in immunology. And so if parents have questions about vaccines, my main concern with that is this going to create more misinformation? So I really think that, as the doctor was saying earlier, this would be better for the pediatricians to really continue taking care of, and hopefully we can find another solution that would also provide increased access to vaccines, because I agree the intention behind this bill is good.
Questions, members?
Yeah.
Representative Smith?
Doctor, thank you for being here. I know you've been here all day, I think.
Yeah.
But anyway, so you were talking about the live vaccines.
Mm-hmm.
Are there some vaccines that if you accepted them out specifically in this bill that would make this bill okay for you?
I would defer to my pediatrician and family doctor colleagues on that, just because I don't personally administer vaccines, but I think that would be a great thing to discuss.
Okay, thank you.
Representative Price?
Yes, and Doctor, thank you for being here. Bringing that up, are you aware of any instance where a live vaccine has been administered by, a vaccine with a live virus has been administered by a pharmacist? It's caused a negative reaction, like in your practice? I know you're an ER physician, but
So yeah, I don't.
anything personally you're aware of?
Not personally.
Okay, thank you.
Okay.
Other questions, members? Great, thank you. Michelle Evans. Next on deck will be Amy Lesson and Patricia Aronin. I show you registered as Michelle Evans, and you are with Texans for Vaccine Choice and yourself, and you're against the bill.
Correct.
Okay,
Thank you.
Please begin.
Each of the many concerns I'll be addressing today has been brought to Representative Price's attention as of last week, but to our knowledge has not been heeded. To be clear, TFVC does not oppose safe access to vaccines. We support equitable access without jeopardizing necessary guardrails, recognizing that the third leading cause of death is medical error, defined as caused by inadequately skilled staff, error in judgment or care, system defect, or preventable adverse effect. The changes in the domain of care for pharmacists and pharmacy techs created under the PrEP Act were done so in response to a recognized public health declaration and were narrowly applied to preventive measures for COVID-19 only. This public health emergency has all but ended, and a subsequent emergency does not exist to justify making these changes permanent, nor to apply them more broadly. TFVC sought the insight and advice of practicing pharmacists in reviewing this bill, and their response was one of deep apprehension. Pharmacists have very specific and limited duties which prevent them from transgressing upon responsibilities typically designated to physicians. Their training and education is specifically crafted for the practice of dispensing, not practicing medicine. Providing vaccines for children as young as 3 requires specific knowledge in developing organ systems and should involve a familiarity with the patient's unique medical and family history. These are crucial in determining susceptibility to reactions, medical necessity of the vaccination, and whether precautionary measures should be taken before, during, or after the vaccination. Without supplemental formal education and a prerequisite for having a documented, established relationship with the patient, HB 1105 falls short in ensuring patient safety. An additional concern is that the reporting period during which a pharmacist is expected to notify a physician that their patient has received a vaccine is significantly extended. HB 1105 proposes lengthening that from 24 hours to 14 days, a period during which the patient could experience life-threatening adverse reactions that are not properly diagnosed or treated, or face a situation in which they are double vaccinated because the pharmacist has yet to report the original vaccination. In short, it's in the best interest of all patients that any medical procedure they undergo is done so under the supervision of a healthcare provider who has more in-depth knowledge of medical history, family history, and medical needs. Limiting the number of professionals for whom vaccine administration is authorized avoids conflicts of interest and helps with the provision of individualized care, ensuring accurate, timely reporting and treatment of side effects. Thank you.
Question, members? Representative Tinderholt.
Thank you, Madam Chair. You and I were talking, and you were telling me about your concerns in regard to pharmacists potentially doing something that seemingly looks like practicing medicine, but you and I didn't get to finish that conversation. So can you kind of explain that?
So as has been alluded to earlier in prior testimony, we have shared concerns that a pharmacist or a pharmacy tech who doesn't have full history of that patient, doesn't really understand where their, if there may be allergies or susceptibilities to reactions, anything like that. They don't have that information at their disposal like a primary care physician or pediatrician would have. And so to order and administer a vaccine is practicing medicine in place of a pediatrician or a primary care physician. And we feel that it's in a patient's best interest to keep those two lanes very separate. Thank you.
Other questions, members? Representative Alderson.
Thank you, Madam Chair. Michelle, I appreciate you being here today. I just want to ask you the same question that my colleague asked the previous witness, and that is, are you aware of any children or are you aware of any families that have experienced an adverse reaction to a childhood vaccination?
Do I personally know?
Do you know of anybody?
My own daughter, yes.
Okay, and so the management of those adverse reactions, is that something that you think could be handled through the pharmacy, or is that something that requires a physician to manage?
It requires a physician to manage.
You said you've had this with your own daughter?
Yes.
Do you want to tell us a little bit about that, or would you feel comfortable?
Protracted adverse events that took place over the course of about 6 months after a Hib vaccine at her 1-year appointment. And so
what is that, Haemophilus influenza B? Okay.
So it wasn't something that could have been easily recognized at the time that she was given that vaccine. It was something that sort of played out over time. And we eventually learned that she had a genetic disorder, or has a genetic disorder that likely made her susceptible to such
Goodness,
reactions.
I'm sorry. Did she have any symptoms initially? And if so, what were they?
Nothing that we immediately recognized. There was, in hindsight, right. So it's a little bit different, but having the high fever and sort of.
So she did have high fever?
Yes.
Yeah, because I've heard that's kind of common.
It is. And we were told to basically, just kind of treat it, that it's a normal reaction to vaccines, that it's just your immune system.
And did the person who administered the vaccine, or the location where it was administered, did they provide the medical follow-up as you went through this course of
Yes,
sort of figuring out what happened to your daughter?
Physician.
So, okay, so there was continuity of care.
Yes.
Okay, all right. Well, I just figured that maybe you had an experience that maybe the previous witness didn't. And so I'm sorry that your daughter experienced that, and I hope that she's doing better. And
She's doing very well. Thank you so much.
okay, all right, thank you.
Other questions, members? All righty, thank you.
Thank you.
Chair calls Amy Lesson and then Patricia Aronen. Amy, I show you are registered for the bill and that you're representing the Texas Federation of Drugstores and yourself. Is that correct?
That's correct.
All righty, please begin your testimony.
Thank you. Good evening, Chairwoman Click and members of the House Public Health Committee. My name is Amy Lesson, and I'm a pharmacist and Director of Pharmacy and Retail Operations for Walgreens. I appreciate the opportunity to testify today in support of HB 1105 offered by Representative Price. I have provided a handout that shows some of the data that I'm going to mention today. Recently, it has been argued that children that receive their vaccine from a place other than their primary care doctor will not go to their physician for a well-checked child visit. According to the Kaiser Family Foundation, only 42.7% of kids have a medical home. This leaves over 57% of children in Texas to find their vaccines from another source. I think it's important to mention too, the Kaiser Family Foundation, in order to meet that criteria of having a medical home, they needed to have a personal doctor or a nurse, a usual source of care, and it needed to be family-centered. So Kaiser Family Foundation really had 3 criteria to meet that case for having a medical home, and 57% of children in Texas do not. Recent national survey data reveals that preventative care visits to pediatricians in Texas fluctuates from year to year, with the lowest year in 2018 of 64.8%. Data from the COVID-19 pandemic years of 2020, 2021, and the year 2021 show a drop in preventative health visits to 72.9%, but increasing to 74.1% the second year. As you can see from the second chart on the first page, preventative visits fluctuate prior to pharmacies getting the authority to vaccinate, the lowest preventative visits occurring in 2018, well before the COVID and the PrEP Act. Due to the fluctuation prior to the PrEP Act, it is impossible to draw a direct correlation to a drop-off in preventative care visits to children obtaining a vaccine from another source. Today, parents can take their children to the local back-to-school vaccine clinics, a state or local health department, free vaccine clinics that are set up by their schools or other locations during the school year, urgent care clinics, and under the PrEP Act, pharmacies to obtain these preventative vaccines. Many parents were already seeking alternative sources to vaccinate. Under the PrEP Act, our pharmacist must inform his or her child vaccination patients and the adult caregiver accompanying the child the importance of the well child visits with the pediatrician or other licensed primary care provider. Well child visits are annual and typically occur in the birth month of the child. Immunization requirements for school attendance often need to be prior to the start of school in August. The CDC advises that you get your flu vaccine in September, October every year. So depending on when a child's birthday is, they may have to have multiple visits to get the vaccines that they need, as well as getting their well child visit. So it could take separate appointments. Many parents found pharmacies to be accessible, safe, and convenient to receive preventative vaccines. The charts on pages 2 and 3 come from data collected by DSHS. As you can see from the first chart, parents of 44.63% of the 3 and 4-year-olds received their COVID vaccine, chose to receive them at private practice, but 28% of those parents chose the pharmacy. What we will see at our stores are families often come in to get all their children vaccinated at the same time versus one going to the pediatrician and the rest of the family coming to the pharmacy. During COVID, Walgreens and many other pharmacies enriched our online system so parents can either pre-book appointments for vaccines, generally on the same day, or look for availability of vaccination slots at a given pharmacy in a slot time that really worked for them. Most chain pharmacies remodeled their space to have an enclosed space to provide the vaccines and make areas that included a small waiting room. Pharmacy stepped up and worked hard to make vaccinations available to people that want to be immunized, allowing that choice to continue after the PrEP Act expires. In closing, I hope the members of the committee agree with the valuable role that pharmacists and technicians in our community have provided the needed services to adults and children, and support HB 1105. Thank you very much.
Questions, members? Thank you.
Thank you.
Patricia Aronin, followed by Tim Purser. And I show you as Patricia Aronin, I'm sorry.
Long O. That's okay.
You are representing, are registered for Texas 400 and yourself, and you're against the bill, is that correct?
Yes, ma'am. Thank you.
Okay, please begin.
Yes, thank you for allowing me to testify again. I'm sorry I seem so negative about testifying against everything. In any event, two things I just want to add to the prior testimonies that have been given. One, to kind of follow up on what Dr. Oliverson said, is that one concern I would have is what happens if someone has an anaphylactic reaction in the pharmacy, and how capable in that setting are they to be able to deal with that sort of a problem. But beyond that, I'll give you my own testimony. And I will acknowledge right from the start, Representative Price, that I think that pharmacists have great training. I've got a niece who's a doctorate in pharmacy, and I think they get wonderful training in being pharmacists. But we're trying to give them a different role that I'm not sure makes a lot of sense for children. And I appreciate the testimony that was just given about how many kids get seen by their pediatrician, but I want to just kind of comment about what my experience was as a pediatric neurosurgeon. Many children only get taken to their pediatrician because they're going for their shots. And that well child visit is not just to get their shots, it's the opportunity for the pediatrician to assess a lot of other things. You've heard about picking up diabetes, they pick up on nutritional status and growth of babies, pick up on developmental progress, and other safety aspects of what's happening in the home. And all that happens because they're in for their well child visit that the parent would only do because they're going for their shots. Otherwise, they wouldn't take the time for the visit. And a lot of times, parents will see things that they think are just kind of minor nothings, but actually there's something bigger brewing. And I'll give you some examples that when I was trying to put this testimony together, that just off the top of my head, events I could remember. So for example, a child having a retinoblastoma diagnosed because the pediatrician recognized an abnormal light reflex. The child hadn't yet developed any visual symptoms that the parents could recognize, but the pediatrician could see it. And so that was picked up and could be treated early rather than much later. Children coming in where a child was referred to me for treatment of hydrocephalus that was picked up when they went in for their shots, where the pediatrician saw the child's head growth was expanding too rapidly. And the parents simply thought, oh, well, he's just got a big head like dad. Or a child whose parents brought him in because when they went in for their shots, thought that their child, their baby, had already developed dominant handedness, that, oh, he's going to be left-handed. Well, a 12-month-old should not have dominant handedness. And so that led to the pediatrician scanning the child, and that child had a brain tumor that was picked up and could be treated early and do well. My colleagues will talk about picking up heart murmurs and picking up other medical problems when the kid is in to get their shots that wouldn't happen if those visits didn't occur. And so I think it's important to understand that a lot of parents will not bother the pediatrician or take the effort to make an extra doctor visit if they think this is a minor thing.
Your time is expired.
So those visits are really important. And I think that just simply saying, can a pharmacist give a vaccination? Yeah, sure they can. But it's missing out on the rest of childhood care.
Your time is expired. Questions for the witness members? Great, thank you.
I just hope as you deliberate on this, please don't miss out on what's important for the development of children.
Tim Purser.
Good evening, Madam Chair, Madam Vice Chair, and committee. Thanks again.
Yeah,
my name's Tim Purser. I'm a pharmacist and the Director of Pharmacy for United Supermarkets. I'm here on behalf of myself and United Supermarkets.
Perfect.
I'm in support of House Bill 1105. Yeah. Thank you. Thanks again for the opportunity to chat with y'all. As has been mentioned several times, we understand why we're asking for this. This is basically a continuation of what pharmacies have been doing for the last 3 years. This is something that will allow our Texas families to continue to obtain vaccines for their children in their trusted neighborhood pharmacy. Again, we're not asking for anything out of bounds from what we've been doing over the past three years. We operate 62 pharmacies across Texas under the banners of United Supermarkets, Market Street, and Amigos. Our roots are in rural Texas from Perryton to Pecos and Muleshoe to Brownwood. We know in a sampling of our immunizations over the last 3 years that 30% of vaccines that we gave in our pharmacies to children over the age of 3 were not COVID vaccines. And more than 30% were given outside of traditional office hours based on our sampling. Expanding access to immunizations is an important piece of the healthcare puzzle, especially in areas where providers are scarce. In addition, we serve larger population centers as shown on the map that I just distributed to the group. When COVID-19 caused the shutdown of brick and mortar, retail stores, grocery stores, and pharmacies remained open. As vaccinations became available, pharmacists were first providers to persons in nursing home and mass clinics. Our store pharmacies could administer both adult and children vaccines so the entire family could come to one of our locations and be vaccinated in a comfortable manner. When a person comes to our pharmacy for a vaccine, I want to talk a little bit about the process. They fill out an intake questionnaire like those that are completed at a physician's office, asking the patient a series of health questions, such as, are they feeling sick that day? Do they have any known allergies? Do they have any allergic reactions to a previous vaccination? The questionnaire also asks if the patient has a primary care doctor. If the patient identifies a primary care doctor, then the pharmacy must notify the doctor within 14 days. Today, pharmacists graduate, as you've heard, with training for immunizations and are held to continuing education requirements every 2 years, in addition to cardiac life support and CPR. Under the PrEP Act, pharmacy technicians are permitted to be trained to administer vaccines, and those pharmacy techs must also comply with all training requirements and education. But an important part is that the pharmacist is the only person permitted to review the intake information, the person's vaccination history, and authorize the immunization. So House Bill 1105 provides the state with the authority when PrEP Act expires to continue. Proud of our Texas pharmacists, and the pharmacies have helped to maintain access to critical preventative care. And again, this is preventative care amidst an increasing demand for healthcare services in rural climates.
Representative Price.
Thank you, Madam Chair. Tim, first of all, I want to thank you for traveling, making the trip.
Bet.
It's a long trip, and you've been here all day since before 8 o'clock this morning. Thank you for sitting through the day of public health. Hopefully you learned something besides this bill, and I'm sure you did, listening to all the bills we've heard. But I did want to ask you a couple questions. First of all, how many pharmacies you say you oversee?
Well, we have 62 in Texas.
Okay, 62 in Texas. What is the number roughly of vaccines, you all have given?
We gave about 800,000 vaccines over the last 3 years.
Okay.
Yeah.
And when you're giving those 800,000 vaccines, there was a witness earlier a couple of witnesses ago that said, I think mistakenly, that this bill is going to extend the time that pharmacies have to report that to the physician treating them, and said that, they have to do it in 24 hours. My understanding, that is not the current state of the law. Is that correct?
Correct.
So, I think that you all probably do it every night as a matter of practice.
We do. So, obviously during the pandemic, some of the requirements around the COVID vaccine itself required a little more prompt reporting.
Right.
So that was part of the reporting process.
So that previous testimony was completely inaccurate on that issue?
Right.
Okay. So then, with regard to, we heard some speculation regarding allergic reactions. Tell us kind of, what do you counsel somebody that comes in? What do you look for? How do you handle
Yeah.
potential allergies?
Absolutely. So again, as mentioned, we have an intake and we do a screening form, much like you'd see in a physician's office, that checks for, potential allergies or previous reactions. And so obviously that's part of the pre-screen process. Then we also require anyone who receives an immunization to stay in the pharmacy or the area for 15 minutes, so we can observe for any reactions that might come up. And of course, our immunizers are trained should there be a reaction happen with CPR training and training for reactions to those type of potential allergies.
Probably a dumb question, but do you have EpiPens in the pharmacies? Okay.
We do.
That's what I figured. Well, I really do appreciate you being here. Thank you for answering my questions, and thanks again for your testimony.
No problem.
Other questions, members? Thank you. Is there anyone else wishing to testify on for or against House Bill 1105? Chair recognizes Representative Price to close.
Thank you, Madam Chair. Members, thank you for allowing me to lay out the bill. And I really do appreciate the discussion, the questions, the answers that were provided. I'm very sensitive to the idea that this, bill would replace, a well visit, because that is certainly not the intention. And I don't think that this committee would have unanimously voted it out last session, and the House would have supported it overwhelmingly last session if that were even the case, but that's not the case. So I'll tell you what the bill's not. We also heard a lot of speculation today, but what we didn't hear, what you never heard, was how bad the outcomes were the last 3 years when basically what we're asking to be extended was in place. You heard a ton of speculation, but you didn't hear any facts. So I think this is overwhelmingly supported by a lot of parents, a lot of working parents who look for the convenience of not taking their child out of school, not taking time off work, going to have a routine Tdap booster, a measles, a mumps shot, trying to get that done, but not replacing that visit with what they do when they go see their pediatrician. I think it's safe. I think this improves access, and I would appreciate the committee's favorable consideration and close on the bill.
Thank you. If there's no objection, House Bill 1105 will be left pending. The chair hears no objection. House Bill 1105 is left pending without objection. The chair lays out House Bill 1240 and recognizes Representative Alverson to explain the bill.
Thank you, Madam Chair and committee members. I appreciate the opportunity to lay out House Bill 1240. This is sort of the other side of the scope of practice coin. This bill allows physicians the ability to dispense certain medications directly to their patients in their office. 46 out of 50 states already allow this. Texas is one of the few that prohibits this, except in Speaker Craddock's district, oddly enough. According to a 2017 study, between 20 and 31% of prescriptions go completely unfilled. Poor adherence to medical treatment plans obviously leads to worse outcomes and higher healthcare costs. There are also physician models now that involve direct access without insurance being involved, and these models tend to favor prescription drugs being able to be dispensed generics at the cheapest cost possible, which is always going to be according to the way that we've laid it out in this bill, where essentially a physician can dispense the medication essentially at their cost. And essentially, we've statutorily prohibited the ability to charge a dispensing fee on this. So essentially, the physicians that would engage in this type of dispensing are those who are only seeking to lower pharmacy costs for their patients for medications that are commonly prescribed. We've also carefully carved out controlled substances, so to prevent there from being a sort of a pill mill situation that might pop up, a physician using direct dispensing under my bill would be unable to dispense controlled substances. I've gotten some good feedback from different stakeholders, including many in the pharmacy community, and their suggestions are valid and reasonable. And so we do have a committee sub that we're working on that I'm not going to lay out, but I did want to briefly tell you that we will be requiring doctors who engage in direct dispensing to follow certain labeling requirements to make sure that should a prescription find its way into a patient's hand and then the patient goes to a pharmacy later, that there's some ability to communicate in a standardized language where that pharmacist would be able to look at. So it's not just like a envelope with something scribbled on it that says, here's your diabetes medicine, take one every day. But it actually meets all those labeling requirements. Furthermore, physicians engaged in direct dispensing under my bill would have to comply with all applicable pharmacy board rules. So although they wouldn't be under the direct supervision of the pharmacy board, and they certainly wouldn't have to be co-managing with a pharmacist, they would essentially the medical board would be responsible for making sure that they're in compliance with all storage, record keeping, labeling, and dispensing requirements. And additionally, physicians engaging in direct dispensing under my proposal would also be responsible, even if they delegated to another person, they themselves would have to do the final check and the counseling that is what has become, I think, a very good standard of care in all of our pharmacies, where the pharmacist directly engages with the patient to ask if they have any questions, actually does the final check on the medicine, make sure that everything's done. So I think we have a really nice tight box here for this. I don't think this is drafted in a way to where the people who are interested in just making money are going to find this to be of much help to them. But I do think that those that are doctors who are literally just trying to get medications in the hands of their patient at the most affordable price possible, especially as part of a value-added service in a cash pay type relationship, that they will find this to be incredibly valuable. And I think it will significantly increase, in certain circumstances, the percentage of patients that actually take their medications as prescribed, since it will prevent them from having to make an extra trip. I'm happy to take any questions that you have, and I'd like to reserve my right to close.
Question, members? All righty, we'll begin public testimony and reserve your right to close. Chair calls Randy Martin. Next on deck will be Jack Franklin, and then Rodney Cox. Show you registered as Randy Martin.
Yes.
And you are representing the Texas Society of Health System Pharmacists and yourself, and you are against the bill. Is that correct?
Yes, ma'am.
Okay, please begin.
And I'm going to start by specifically saying thank you for considering a committee substitute, and we certainly look forward as an organization working with you on that and helping craft language and seeing what we can do. So thank you for that. Do appreciate that. Also, I did want to make another comment. I also appreciated the fact that even though you addressed considerations of potential, bad actors and ethical considerations, I do like to highlight in hearings like this that the top 3 trusted professions right now are nurses, physicians, and pharmacists. So I think we're all in good company. So thank you. So my original testimony is actually oriented towards the original text of the bill, so I'll try and trim the irrelevant elements off. Johns Hopkins patient safety experts estimate that 250,000 deaths per year can be attributed to medical error in the United States. And it's not just physicians, just to point out, and it's certainly not. And it's also not a jab at any of my colleagues or my own profession. I have the pleasure with working with many exceptional physicians, but as the Institute for Safe Medication Practices wisely reiterated, to err is human. Healthcare is complex, and it takes a team of professionals to care for just one person safely. Pharmacist review of a prescription is one of the most important safety checks in primary care. In a study by the American Academy of Family Physicians, they found that 70% of medication errors in primary care were prescribing errors. And in the same study, they actually found that pharmacists were 2.5 times more likely to catch medication errors than their physician colleagues. The act of dispensing intersects. It's interesting, someone made a comment earlier that was pretty inaccurate. It said that pharmacists just learned about dispensing, and I don't think they meant it that way, but it may not be all that we learn, but it does intersect with everything that a pharmacist does. And all the interventions and activities that we do are peripheral and secondary to that act. And so to remove pharmacists from that dispensing aspect pulls them completely out of the healthcare equation and places patients at risk at an increased risk for medication error. I have laid out the many risks there. The one thing I would also point out is I think that it's a wonderful idea in the substitute to require that those physicians that would dispense to adhere to the pharmacy rule book. I would, however, point out that that may be a very daunting task for our already burdened medical board, since there are 350 pages of regulatory statute, or regulations, excuse me, with pharmacy practice. Thank you all for your time. Happy to take any questions.
I'm sorry. Any questions, members? Thank you for your testimony.
Thank you all very much.
The chair calls Jack Franklin.
Good evening.
Hello, sir. Thank you for being here. I see that you're registered as Jack Franklin. You're here on behalf of yourself and you're for the bill. Is that correct?
That is correct.
Thank you, sir, for being here. You can begin your testimony.
My name is Jack Franklin. I am a family medicine doctor, or a rural family medicine doctor in Llano County, about an hour and a half west of us. Goodness, haven't used my voice all day. First, I'd like to thank y'all for what you do. I thought I worked long hours. This is pretty amazing. I'm a rural physician. I wear lots of hats, but I'm going to try to skip to the one that makes the most sense. I'm a direct primary care physician. One of the doctors that Dr. Olson was talking about, my clinic is all about saving patients money. We try to give them the lowest cost care that we possibly can. For that reason, about 65% of my patients have no form of third-party payer. There is no insurance, there is no Medicare, there is no Medicaid. These are folks that are working paycheck to paycheck, and we try very hard, therefore, to lower the cost of their care by getting the best prices we can on laboratories, the best prices we can on x-rays, and with your help, the best prices we can on medications as well. As Dr. Overson said, there are 46 states that allow physician dispensing. The direct primary care model in those states tends to thrive because of the ability for physicians to dispense. Most of them provide about 40 to 50 medications. These are usually, almost always, simply generic medications. They're very inexpensive, very easy to get. And in those cases, those physicians are able to get about a 30 to 40% decrease in the cost compared to GoodRx and the Mark Cuban Pharmacy, which I think is incredible considering those are two of the lowest cost places I can find here in Texas. I think the second big component with this bill is compliance. The figure I read was that 30% of prescriptions are either never picked up or never started. If you can imagine me giving Jim 30 lisinopril and telling him, look, really is very important that you take this, going over the prescription in detail, and then telling him at the end of the conversation, I need you to take this for the next 30 days, and I want you to come back and see me. By the way, that'll be $1.50. I think we can go a long way with this bill. Again, this is for my patients, patients that don't have much in the way of resources. This is for the folks from the direct primary care standpoint. So I'd be happy to take any questions you have.
Franklin, any questions? No questions. Thank you for your testimony.
Thank you.
The chair calls Rodney Cox.
Good evening.
Thank you for being here, sir. I see that you're registered as Rodney Cox. You're here on behalf of yourself and you're against the bill. Is that
Correct.
You may begin your testimony.
Okay. I'd have to echo the physician comments. Your stamina and attention during this meeting has been admirable, so thank you for your service. My name is Rodney Cox. I've practiced pharmacy for about 24 years, half of which has been in the retail, the other half's been in the health system, where I'm currently a director of pharmacy and respiratory therapy at a community medical center in Houston, Texas. So I want to talk a little bit about some of the unintended consequences that you may not see if this bill is passed as it's currently written. A recent study identified that medications were involved in about 88% of emergency hospital admissions, and this largely is due to older adults. And this is what we call polypharmacy. They come in with a half a dozen or more medications that have all sorts of interactions. So priority one for my staff in the emergency department is to get an accurate medication list, what we call the medication history, to the prescription, to the physician that's going to do the admitting. This usually requires a great deal of detective work. Our first order of business is really looking at the claims data, where we can really see, without calling a Walgreens or a CVS or any Randall's Pharmacy, an accurate list. Well, if this bill is passed the way it is, these physicians will not submit those prescriptions through that claim processing, so we won't have that information. The next step, if they can't get it through the database, is to contact their pharmacy. And again, the pharmacy has medications that are being written by probably 5 or 6 physicians for these older adults. And they can put the whole history together. Last but not least, we'll call the physician. And again, you know, the physician's hours are usually 9 to 5, and emergency medicine visits happen 24/7 and 7 days a week. So going through the traditional physician practice makes this a really serious problem, particularly when you're dealing with serious medications that require antidotes. With this bill, the work of creating an accurate picture of patients' current medication will be severely hampered. It will potentially require multiple calls to maybe half a dozen physicians. The difference in being able to readily speak with a peer as we do now versus trying to connect with someone in physician practice who's already overwhelmed would likely result in leaving a message. And this would probably lead to a more lengthy hospitalization. On the same time, during discharge, you'll find pharmacists working to create an accurate list for physicians to reconcile. So when we do this, we make our recommendations and we attempt through our health systems IT platform to point that prescription to a retail pharmacy. Now, what do you think would happen if patients were allowed to select their physicians for us to send those prescriptions to? They may want to send the antibiotic to an infectious disease. They may want to send a heart medication to the cardiologist. And those physicians don't have the systems necessarily in place to capture those. The most important thing in this time frame is to get the medication to the patients early, and so that we can try to prevent a 30-day readmission, those 30-day readmission when those patients are bouncing back into our hospital. Because we have such good coordination and good practice with our retail pharmacies,
Mr.
we can submit those claims.
I apologize, your time is up.
Okay, thank you.
Are there any questions? No questions?
Thank you.
Thank you so much. The chair calls Cliff Porter. Thank you for being here. I see that you're registered as Dr. Cliff Porter. You're here on behalf of yourself and you're for the bill. Is that correct?
Yes, indeed.
Thank you so much. You may
Say
begin.
good morning once upon a time, but good evening.
Oh, good evening.
Yeah, so my clinic is Texas Direct Medical Care, the primary and urgent care practice in Austin and Buda, also using the direct primary care model. It's a non-insurance clinic. So many of my patients can't afford the just exploitive drug prices, just to call it what it is. The drug prices at the large retail pharmacies, CVS, Walgreens, are largely determined by the middlemen, primarily the PBMs, the pharmacy benefit managers. CVS, for example, is owned by one of the PBMs, Caremark. So the direct dispense legislation can cut drug costs 90% in 46 states, so why not Texas? So the PBMs and the middlemen, they'll lose money on this legislation, and they're putting a lot of resources in it to fight it, to be blunt. But the purpose of patients, which is all of us, is not to make other people's profit margin higher. So examples of what we can do. EpiPens cost $150 to $300, but we can offer equivalent for $10. Walgreens and Bastrop, for an example, tried to charge $320 for a $5 blood pressure medicine to one of my uninsured patients. We can provide, at the point, antibiotics to avoid treatment delay, which is a very frequent problem, and better compliance. We also bypass the prior authorizations that are very common even for cheap drugs. It gets quite frustrating. So independent pharmacies, and some of the independent pharmacies here will point to this, they actually lose money on some of the generic drugs. Just the insurance reimbursements are actually quite low. Direct dispense doesn't financially harm the independent pharmacies. In other states, it just hasn't. So the retail chains, the PBMs and insurance, they're the ones doing the harm. United Health Insurance, for example, is owned by the PBM Optum. And so they discriminate against independent pharmacies. So this isn't a challenge to them, it's not a competition with them. Now, opponents also use fear, claim that direct dispense is unsafe. A lot of the data is saying physician prescriptions have medication errors are actually from insurance-driven clinics, whether corporate, private, or government, where they have to go so fast. All of us have had the experience of being in a clinic where you're on a treadmill. Go as fast as you can, do a prescription, do a referral, and then move on. That's not direct primary care. I spend 30 to 60 minutes with patients. And so, you know, all of us, you know, we take 100% responsibility for what we prescribe. So in contrast, do a search engine, Walgreens safety investigation, multiple news stories pop up in investigations. So one last point, I think there's an opportunity for physicians and pharmacists, independent primarily, to actually come to some good compromises here. I think we can do a lot for the patient. Thank you.
Thank you, sir. Any questions? Thank you. Thank you, Dr. Porter, for this information. I'm just trying to figure out how is it that you're able to have a savings? Because if you have to purchase the medication, you buy it at a cost.
Right.
Do they give a doctor discount? I'm trying to figure out, and then, like, how is your purchase cheaper than what the pharmacy gets?
Well, a couple ones. For the actual generic drugs, blood pressure medicines, metformin for diabetes and so forth, get it directly from the generic pharmaceutical manufacturers. And it's 95% less. It's shocking how much lower it is. Now, epinephrine, EpiPens, they're 0.3 milligrams per EpiPen. You get a pair in a box. And you look on GoodRx, $150 to $300 for a pair of them. A vial of epinephrine is $15. So you take that, you just do a pre-filled syringe, you educate the patient on it, because people are doing self-injecting all the time anyway, testosterone and insulin and so forth. You give them a pre-filled syringe for $5.
Okay, so is that a compound or not? It doesn't become.
No, it's just straight epinephrine. So
Okay,
I have epinephrine in the clinic for emergencies, of course. And actually the pharmacists, many pharmacists keep epinephrine for anaphylaxis for vaccines, for example. Same thing. We just put it in that pre-filled syringe.
I'm just trying to figure out where the markup comes, because.
PBMs, ma'am. Pharmacy benefit managers. They make just, it's really obscene how much money they make.
Okay, thank you.
Other questions, Representative Alverson?
Thank you, Madam Chair. Dr. Porter, it's always good to see you. Thank you for being here today. So you heard me lay this bill out, and you heard me talk about a lot of the guardrails that we're putting in place and the kind of this construction that we've put around this to make sure that we're, you know, doctors are complying with a lot of the same safety rules and things. Was there anything that you heard that you found you would be a problem in your practice or you wouldn't be able to live with?
No, not at all. Actually, I think it's designed very well. Because most of the things we're prescribing are very common medications. And then the cost savings, what you're allowing to do is more narrow group. The specialized medications, compounding and so forth, well, that's what the pharmacies, that's where they help a great deal. And new things like during COVID. Worked a lot with pharmacies on how to do things. Common things be different.
So, I mean, one of the other things we've talked about is, you know, making it clear that we're not intending to allow the physician that's dispensing to bill an insurance plan, a PBM, or some sort of a pharmacy benefit, that this is sort of a true cash and carry type deal. That wouldn't negatively impact your practice in any way. You could operate with that. That would meet your needs if it was just sort of cash only.
Yes, it'd be extremely favorable because patients can avoid the cost. Because quite often the copay that many people are paying can be actually, in one case, 10 times higher than the actual direct cost of the drug.
And the lastly, I was just going to ask you, so I thought it was, well, actually two things. So one is, you don't have any problems with me, so I've basically put it in the statute that you're not allowed to charge a dispensing fee. You can only cover your direct costs.
Correct.
You're fine with that?
Yes, because that actually offers, it's a value added. So if patients come to me one place, they can get those things where it is harder to get it in other areas or they're being gouged.
Right, so it's a totally different model for you. You have a direct primary care agreement with a patient. You're providing the medicine literally at cost as a value add as part of that direct primary care.
Yes, and it's things I do with other things like lab costs. We get it similar, we get tremendous discounts. Same sort of thing we're doing. We're not trying to make money on that. We get paid on membership, and that's fine. And then I can actually practice medicine.
Right. I thought that was interesting what you said. I hadn't really thought of that, but you know, actually, I see an allergist, you know, once a year. Had asthma for years and allergies and stuff like that. I mean, he comes in and he visits with me and he does the physical exam, and I think he spends a reasonable amount of time. And I mean, it's an insurance visit, so like you said, it's probably 10 minutes or less. But what I noticed that you made me think of is that all the medication information that's entered and all that data that's gathered during that visit, he never does that. That's the MA, or I'm filling it in myself online before I get there and all this kind of stuff. So to your point, I mean, in your practice, you have the ability to slow down and really talk with the patient about other medications they may have been prescribed by other doctors and side effects and things like that. I hear what you're saying. I guess I hadn't thought of it, but in this era of EMR and all that kind of stuff, I bet you it's rare for a doctor to really, you know, in that insurance model, as you described, to do a lot of that entering of data. It probably just gets put in the EMR by somebody that works in the office and they just kind of click it, right? Whereas you're actually, in your practice model, you have the time and the wherewithal to sit down and really provide that comprehensive level of care.
Right, and one of the pharmacists mentioned polypharmacy is something I could spend a good deal of time on. So with Medicare patients in particular, I'll spend 1 to 2 hours. I've actually opted out of Medicare, which makes it easier to see Medicare patients, which is
appreciate
a curious way of
it is. I appreciate you being here today. Thank you for waiting so long to testify.
Questions, members? All righty, thank you.
Thank you.
Chair calls Carter High. I show you registered as Carter High, and you're representing the Texas Pharmacy Association and yourself, and you're against the bill, is that correct?
As filed, correct.
Thank you.
Good morning. Testifying today on behalf of myself and the Texas Pharmacy Association, respectful opposition to House Bill 1240 as filed. Pharmacists are highly trained professionals since the year 2000. We've been the standard for all new pharmacists to receive a doctorate in pharmacy, which requires 4 years of professional study in biological, chemical, and physical properties of medication. Pharmacist education is medication specific and offers a unique value to the healthcare system. Pharmacists serve as a necessary check to ensure that medications are dispensed safely and accurately. And a pharmacist ensures medications is safe to dispense to the patient, including a check for potential adverse reactions with patients' other medications. In addition, there's an obvious conflict of interest in having the same person both act as prescriber and dispenser. A former Secretary of Health and Human Services and other federal agencies have pointed out the potential for perverse incentives for pharmacists to choose higher priced drug products. Pharmacies are highly regulated by the State Board of Pharmacy and the Federal Drug Enforcement Administration, known as the DEA, to ensure patient health and safety. In addition to the on-site inspections regularly by agencies, pharmacies must follow regulations regarding to labeling requirements, compliance, record keeping, new prescription counseling, drug utilization reviews, and written information. And of course, the final check is actually performed by the pharmacists themselves. That is not delegated out to anyone else. All these elements are related to patient safety and are strictly enforced upon pharmacies. We strongly believe that those protections should apply to any prescription medications dispensed to a patient. Pharmacists are the most accessible healthcare providers, and we do not believe there is an access or cost problem that would be solved by allowing physicians to dispense medications under this bill. We appreciate Chairman Alderson for his openness to engage with us on this pharmacy matter and as many other issues. We're happy to continue to work with him in his office, improving healthcare for all Texans, and we're looking forward to reading your substitute that you presented. Thank you.
Questions, members? All righty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 1240? Chair recognizes Representative Alderson to close.
I close.
If there's no objection, House Bill 1240 will be left pending. The chair hears no objection. House Bill 1240 is left pending without objection. The chair lays out House Bill 4365 and recognizes Representative Johnson to explain the bill.
Thank you, Madam Chair. If I may proceed from the dais. House Bill 4365 deals with the issue of surgical smoke, which is produced by the thermal destruction of tissue by use of lasers or electrosurgical devices. About 90% of surgical procedures generate surgical smoke, which translates into consistent exposure for an estimated 500,000 healthcare workers every year. This smoke contains over 150 hazardous chemicals and carcinogens, with a daily impact to the surgical team of the equivalent of smoking about 27 to 30 unfiltered cigarettes. Surgical smoke can safely be eliminated, and what this bill seeks to do is join about 11 other states in putting together procedures for surgical smoke evacuation. I do have a committee substitute, and what that committee substitute addresses is, one, removing mental hospitals from this bill, and two, clarifies that hospitals that it would impact have the flexibility to choose a surgical smoke evacuation system that works best for them. Thank you, Madam Chair and members. I believe we have witnesses to testify, and I reserve the right to close.
Questions, members? Okay, we'll reserve your right to close and begin public testimony. The chair calls Renee Collar. Hope I'm pronouncing that correct. You'll state your name.
Yes. I'm Renee Kaler, RN, and I'm here with Texas Collaboration of Operating Room Nurses. And I'm also the Vice President at Austin Area ARN, and I'm in support of the
You've
bill.
registered with T-Corn and yourself.
Correct.
And that's who you're representing?
Correct.
And you're for the bill?
That is correct.
Okay, thank you.
I'm here to express my support for HB 4365, a bill to require surgical smoke evacuation for hospitals and surgical centers. Surgical smoke contains, as you heard, over 150 hazardous chemicals and carcinogens and mutant cells. It contains toxic gases and vapors such as benzene, hydrocyanide, formaldehyde, bioaerosols, dead and live cellular material, blood fragments, and even live viruses. In addition to causing staff respiratory illness, asthma, and allergy-like symptoms, there are documented cases of staff transmission of the human papilloma virus. Surgical smoke is absorbed by our patients with documented cases of cancer cells migrating, causing metastasis. Babies born in C-sections actually inhale their mother's surgical smoke at birth. As a perioperative nurse for over 45 years, 25 of these years in Texas, surgical smoke and its hazards are more than a statistic or a data point. They are very personal to me. For the last 25 years as an operating room nurse, as soon as I entered the operating room suite, I would have continuous profuse nasal discharge. That may sound quite benign, but think about that for 8 to 12 hours behind a mask. I had to seek medical treatment. The ear, nose, and throat doctor said it was exposure to an irritant, probably surgical smoke. I was placed on a nasal spray daily, commonly used for respiratory illnesses. With a nursing shortage and retention problems, many nurses would just leave the profession rather than experience this daily. I thank you for this opportunity to share with you the dangers and prevalence of surgical smoke in our local operating rooms and how this issue impacts our patients, staff, and me personally. The Texas legislature must act to protect patients and surgical team members by adopting HB 4365 now. And as an aside, I'm retired and I no longer use the nasal spray.
Question, members? All righty, thank you for your testimony. The chair calls J.D. Boucher. Up next on deck will be Fung Tran and then Darlene Murdoch. And I hope I pronounced your name properly.
You did this time, yes. It's good to see you again.
And I have that you're registered to testify on behalf of the Texas Collaboration of Perioperative Nurses and yourself, and you're for the bill.
Yes, I am.
Thank you.
Thank you, Chair Click, Vice Chair Campos, and the whole committee, and especially you. My name is J.D. Boucher. I'm the president for the Texas Collaboration of Perioperative Nurses, and I'm here to express my support for 4365 House Bill. This bill requires surgical smoke evacuation policy for the hospitals and ambulatory surgical centers. I've been a nurse for 35 years in the operating room for most of my career. I was also a combat nurse. I was in 16 combat missions and worked in the OR on the battlefields. I've been shot, received shrapnel. However, it was the surgical smoke that made me leave the operating room, which I love. So I had to leave the operating room after having 12 respiratory infections in the last 2 years of my service in the operating room. I now work as a workforce safety manager that focuses on the safety for the workforce providing care to our civilian population. Opponents of this bill may argue that smoke evacuation is too costly. The cost to replace perioperative nurses who leave the OR like I did is $50,000 to $80,000. Most of the hospitals and ambulatory surgical centers already have smoke evacuation equipment. You will find this in front of you in the results of a survey conducted 2 years ago when this bill was last up. The cost difference in using a smoke evacuation pencil like this is $15 to $20. You can also use a smoke inline filter like this in an office setting for $8. This will last 100 hours. In most of the facilities, if most of the facilities already have this equipment, why do we need this law? Well, it's simple. It's because it's not being used. Agencies like OSHA and the CDC and providing organizations like AORN, the American College of Surgeons, and the Association of Technologists have long recommended evacuation for surgical smoke. But these are just recommendations, and stories like mine and others are proof positive that smoke evacuation must be required. Surgical smoke is a workplace health hazard and presents a risk to patients as well. Surgical smoke in the patient's belly from a laparoscopic procedure can limit the surgeon's visibility, leading to longer surgical times. Surgical smoke evacuation exposure also has been linked to increased levels of carbon monoxide in patients' blood. Sadly, working in the OR was more detrimental to my career than saving lives on the battlefield. Please vote yes on House Bill 4365 and help ensure OR staff in Texas can continue to treat patients in a safer environment.
Questions,
I can answer
members?
any questions.
Thank you for your testimony. Chair calls Bung Tran. Okay. Darlene Murdoch. And then May De La Rosa.
Chair Click and members of the committee. My name is Darlene Murdoch, and I am here to express my support for HB 4365, which requires surgical smoke plume evacuation policy for hospitals and ambulatory surgical centers.
And I show you registered on behalf of AORN, the Association of Perioperative Registered Nurses, and yourself. Is that correct?
That is correct.
Alrighty, thank you. Please begin.
So I am the National Vice President for AORN, the Association of Perioperative Registered Nurses, representing over 43,000 perioperative nurses who are members. I have been a perioperative nurse for over 30 years, and I am employed in Houston, Texas, as a staff nurse in the operating room in one of the busiest level 1 trauma centers in the nation. I am in the business of helping to save lives and limbs at my level 1 trauma center, and I do this by helping to stop and control bleeding, and that is a must. And to stop and control hemorrhaging blood vessels, we use electrical devices to cauterize major bleeders so the patient will not bleed to death, and so that the surgeon can quickly see what needs to be fixed or taken out. And an adult patient who has been critically injured can bleed out in a matter of minutes. The essential use of these devices to control bleeding generates surgical smoke. This surgical smoke is a health and safety hazard that impacts operating room nurses, surgical technicians, surgeons, patients, anesthesia providers, and all who pass through the doors of an operating room. An estimated 90% of all surgical procedures generate surgical smoke. C-sections, mastectomies, knee replacements, hip replacements, all generate surgical smoke. All trauma life-saving surgeries generate surgical smoke because there is usually a lot of bleeding. When we walk down the hallway in the operating room, you can smell the smoke. When I remove my scrubs before I leave for the day, I can smell the smoke. When I go to the break room, I can smell the smoke. I remember 30 years ago when I first started working in the operating room, when I got home, my significant other asked me, had I been smoking? And I told him no. It's the smoke from the operating room you smell. And since that incident, I let my windows down in my car when I'm driving home to get rid of the smoke smell. So I am very concerned about the health of the surgical team, especially the nurses who work and smell the surgical smoke day in and day out for 8 to 12 hours. I can't imagine our new generation of nurses and doctors, anesthesia providers, and surgical technologists spending another 30 years smelling the smoke. So please vote yes on HB 4365 so that we can work in a smoke-free environment, especially for our health. Thank you.
Questions, members? Ready, thank you.
Thank you.
Next up is May De La Rosa.
Yes.
And I show that you are registered with the Texas Collaboration of Perioperative Nurses and yourself, and you're for the bill, is that correct?
That's correct.
Okay, please begin.
Thank you. My name is May De La Rosa. I've been a registered nurse practicing in the ORs in Texas since 2013. I'm a nurse educator and an active member of the Texas Collaboration of Operating Room Nurses. I stand before you in support of HB 4365, a bill to require a surgical smoke evacuation in hospitals and ambulatory surgical centers. Back in 1996, the CDC, through NIOSH, the National Institute of Occupational Safety and Health, published a statement acknowledging that surgical smoke is hazardous and should be appropriately evacuated and filtered. Since then, the most trusted voices in healthcare who focus on safety in the medical workplace have published their own guidelines acknowledging the need for surgical smoke evacuation, including OSHA, Emergency Care Research Center, ECRI, SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons, and AORN. Unfortunately, none of these guidelines or recommendations are requirements to evacuate surgical smoke. So what is surgical smoke? You've heard some statistics already, but let me tell you how it's created. Cells are made up of 95% water, 5% particulate matter. So when we use electricity to apply to the tissue to cut or coagulate, as has been described, that combustion, that chemical reaction, boils the fluid, and those particulate matters get aerosolized into steam, and that's what we see and smell as surgical smoke, okay? So basically, whatever you're operating on, if it's cancer cells, if the patient has an infection, if they have TB, HIV, Hep B, anything that those cells are that you're burning or drilling or sawing become aerosolized, and that's what we breathe as surgical smoke. It circulates throughout the room at 40 miles an hour. So not only are the people in the sterile field affected, but everybody in the room is. The circulator in the corner, the anesthesiologist, anybody coming in to deliver something, people in the hallway, because it travels out in the hallway too. If you've never smelled surgical smoke, let me tell you, it is not pleasant. It smells very bad, it's noxious, it's difficult to breathe, okay? There's a mountain of evidence proving that the chemical constituents found in surgical smoke are the same mutagens and carcinogens found in cigarette smoke. But surgical smoke is much worse for the reasons I've already stated. For this reason, Research has shown that perioperative staff are more than twice as likely to suffer from respiratory issues than the general public. But some procedures create more smoke than others. And those staff who operate in those procedures are even that much more susceptible to these illnesses. And when I say respiratory illnesses, what I'm talking about is chronic fatigue, headache, like she described, runny nose, your allergies that you think you have every year, maybe you wouldn't have them at all, or maybe they're much worse because you work in the perioperative space. That cold that you get every year could turn into a hospitalization or pneumonia. All these things are worse, or conditions that you may not have at all, are worse because we work in the perioperative space for these reasons. To put into perspective, burning 1 gram of tissue creates enough smoke that's the equivalent of smoking 6 unfiltered cigarettes. So I want to amend it a little bit, your statistic that you stated earlier. 1 gram is the weight of a paperclip. So in most surgeries, we're burning a lot more than that. Okay, so someone who works 12, 14, 16 hours a day, which these days is, almost the norm for perioperative staff, are breathing a lot more smoke. Okay.
Your time is expired.
Okay, thank you.
Questions, members?
I have a lot more info if you want to hear it. Okay, thanks.
Chair calls Cesar Lopez. I show you registered as Cesar Lopez with the Texas Hospital Association, and you're neutral on the bill. Is that correct?
Yes, ma'am. Good evening, Madam Chair and members. My name is Cesar Lopez with the Texas Hospital Association. We are respectfully on the bill this evening with a few concerns. We have been working with Representative Johnson's office on these issues and this bill. I think the last round of emails was actually sent this morning with some proposed edits, and so I expect that we're going to continue that discussion and see if we can find a compromise here. We at THA have been working on this issue, I think, for at least 4 sessions now, at least the 4 sessions I've been at THA. We worked with Representative Rose's office last session, and we're working with Senator Miles's office this session, so a number of emails have gone back and forth between us and all the interested parties. We just want to make sure that the bill allows for the surgery team to continue to use whatever equipment they feel is appropriate when they're in the OR. There is currently a number of requirements, state and federal, for hospitals to clean the air in the OR. You can do that a number of different ways. We just want to make sure that we don't wind up with a bill that requires us to mandate the use of something that the surgery team ultimately doesn't want to use or doesn't care to use. So we'll continue to have those discussions. Hopefully we can find a compromise, and I appreciate you all having us this evening.
Great. Questions, members?
No, I just want to thank you for working with us. I'm glad we're working together.
Yes, ma'am. Happy to do it. Thank you.
Great, thank you. Is there anyone else wishing to testify on, for, or against House Bill 4365? The chair recognizes Representative Johnson to close.
I want to thank our witnesses for the moving testimony and appreciate favorable consideration of this bill, and I close.
Right. If there's no objection, House Bill 4365 will be left pending. The chair hears no objection. House Bill 4365 is left pending without objection. The chair lays out House Bill 4687 and recognizes Representative Campos to explain the bill.
Good evening, Madam Chair Cliff and fellow members. Thank you for the opportunity to lay out House Bill 4687. Relating to the coordination of mental health, substance abuse, and public health care services in Texas. The COVID-19 pandemic highlighted many opportunities to improve critical public health support systems. The mental health, substance use, and the public health systems need more intentional coordination because these are typically managed separately, which limits their impact on improving population health despite our acknowledgement that human experience cuts across these systems. The bill creates a framework to drive serious collaboration between mental health, substance abuse, and public health in the critical areas of funding, data sharing, and workforce training. HB 4687 creates a trust to address challenges near the long term and will create a way of improving service coordination, building much-needed infrastructure. Investment in an adequate public health workforce is an effective strategy for covering the gap between community conditions and access to the health care delivery system. The trust fund would be established outside of the state registry and separate from the general fund, managed by 12-member council appointed by HHSC, and would be administratively attached to DSHS. A one-time financial request will be deposited into the account, and that money cannot be used other than to gain interest. Interest gained will fund the grant program also created under this bill to improve coordination between programs, provide evidence-based preventative measures, education programs, and more. The council will annually establish procedures for the applications and approval process and will coordinate biennially with the statewide Behavioral Health Coordinating Council for the grant evaluations. A pending committee substitute adds 2 members to the council, totaling 14. I'm open for questions and respectfully reserve the right to close.
Questions, members? Ready? We'll reserve your right to close and begin public testimony. Chair calls Leila Rice. And next on deck will be Allison Boulware. And I show you registered as Leila Rice, and you're representing the Texas Council on Community Centers, and you are for the bill. Is that correct?
Yes, ma'am.
Okay, please begin.
Thank you all so much for sticking it out for this long day. We really appreciate Representative Vice Chair Campos for filing this bill. I think bringing a public health approach to the issues of substance use and behavioral health in general is going to be really beneficial for people across the state with these issues. The grants provided through the trust will help with coordination, which, as you noted, is sorely needed. We're very happy that the committee said you were willing to add a representative from the local mental health or behavioral health authority. I think their role, their statutory role in doing local community planning and coordination in their individual areas, as well as their experience providing substance use and mental health services to people, will make them an invaluable member of the committee. And then also adding a person with lived experience with substance use or mental health, I think, is always key to have the people who are actually affected by the programs be able to be involved. So that's it. I'll keep it short. Thank you all so much. If you have any
questions? Thank you.
Thank you.
Allison Boulware. And I show you registered on behalf of the Hogg Foundation, and you're neutral on the bill. Is that correct?
That's correct.
Please proceed.
Good evening, Chair, Vice Chair, and Committee. My name is Allison Moore-Bulber, and I am the Director of Policy at the Hogg Foundation for Mental Health. As an affiliate of UT Austin, I'm here on the bill, and I just wanted to share a little bit about how this would really bring 3 sectors together: mental health, substance use, and public health. We know that the state has additional mental health and substance use needs since the start of COVID-19. Researchers previously predicted that social isolation and stress related to the pandemic would worsen mental health across multiple populations. Our own personal experiences, along with data, prove that these predictions were correct. We all know fellow Texans who have struggled with their mental health or misused substances. While some were able to access timely treatment, not all could. On top of our personal stories and all that you have heard from your constituents, the research is clear. More is needed, and this is not just an adult problem. Youth's mental health and well-being have undoubtedly been affected by the pandemic, it is more accurate to describe the pandemic as exacerbating already existing poor mental health. And legislators face a unique situation in the 88th legislature. We acknowledge that great strides have been made in mental health infrastructure and funding. However, there is need for an equal amount of focus on substance use and public health. And this bill would bring these three sectors together. There is no easy way to do this, and we know that this bill would be a step in the right direction. There is significant need to remove silos between these three sectors, and all need improved prevention, early intervention, treatment, and promotion in order to help Texans achieve well-being and recovery. HB 4687 would offer a formal opportunity to focus on these three crucial issues at once for the first time in our state. And these coordinated efforts are essential to get resources out to the community that would benefit all Texans. Again, that lived experience is key, and we think that's a great addition to the bill. I'm happy to answer any questions that y'all have. Thank you.
Questions, members? Ready, thank you.
I just want to say thank you for being here, for waiting all day.
Thank y'all. I know it's a long day.
Is there anyone else wishing to testify on or against House Bill 4687? Chair recognizes Representative Campos to close.
My intention is to aid in a culture shift for our approach to public health. With that, I respectfully ask for your support, and I close. Thank you.
If there's no objection, House Bill 4687 will be left pending. The chair hears no objection. House Bill 4687 is left pending without objection. The chair lays out House Bill 1447 and recognizes Representative Campos to lay out a bill for Representative Cortez. So do we have the right number? Okay.
Good evening, Madam Chair, Click members. Thank you for the opportunity to lay out committee substitute for House Bill 1447 on behalf of Representative Cortez. This bill, also known as Sergio Lopez Food Allergy Awareness Act, would require food service establishments to display an information poster related to food allergies awareness in areas primarily accessible to employees. The Department of State Health Services would be required to determine the form and content of the poster and post a sample poster on the agency's website. The act will potentially save lives by simply making restaurant employees aware of the serious risk an individual can face when having a severe allergic reaction to common food allergies with the use of the poster and training. I would like to give my thanks to the Department of State and Health Services and the Texas Restaurant Association for their help on a committee substitute. I would also like to thank Belinda Vaca for their tireless advocacy. We don't have a sub.
But that's okay.
We're good? I would like to also thank Belinda for their tireless advocacy on behalf of their son, Sergio Lopez, for the past 4 sessions. With that, I reserve the right to close.
Questions, members? Okay, we'll begin our public testimony and reserve your right to close. Chair calls Belinda Vaca. Next on deck will be Serge de Golovine.
Yes, I am Belinda Vaca, mother of Sergio Lopez, who the law is named after, the act, sorry. And I am for the bill 1447.
And you're representing yourself.
I represent myself. I've been coming here, many of you have seen my face, have heard my name. I've been coming here since 2015. My son died June 26th of 2014. After eating at a restaurant, he asked 3 times, does it have peanuts? He asked when he placed his veggie taco order, when he received it, and while he was eating it. They told him only spices. He died within 8 hours. He was my only child. I raised him by myself, single mother. When I went the next day with one of my, I worked at the U.S. Attorney's at the time at IT, as IT staff. One of the attorneys went with me, Ms. Rigney, and they asked, they ordered the same taco. And she said, oh, what is in this taco? It's so good. They said, peanut butter. She told them, my co-worker's son died. He asked, and it's on his phone. We have it here. A minute and a half he spoke to you. And his girlfriend said, he asked before ordering the taco and after. And they said, oh, but he asked for peanuts, not peanut butter. My son died of ignorance. As soon as that, the next day, I start calling food allergy associations. What can I do to stop this? You know, and one of the things is awareness. When I go into restaurants, I talk not for sympathy. I'm telling them to aware. So many people at restaurants, they tell me, I didn't know someone could die because of food allergies. They think it's like gluten. You know, they're going to get upset stomach or a headache. No, I don't want this to ever happen again. I beg you, please. What has happened in the past, I get it. You know, I get so close, but it's not because some people are opposing it. The House isn't opposing it or Senate. It's because of time. Please get this. You know, all I want is awareness. Just a poster, just like a Heimlich maneuver poster is just an awareness. That's all I want. It's not going to be a cost to the state. Other states have this. New York has had this since 2012. They download it from FAIR. It's very easy. I have a sample behind my flyer that I gave you. You know, so it's not going to be cost to the restaurants. And some people say, well, I've heard that it's because it's going to be controlling restaurants and stuff. It's not. It's just awareness. There's such a high turnover, and that's all I want is awareness. And I just want, you know, since my son died, my son isn't the only one. After my son died in 2014, I go through agony. I joined all these allergy association groups, and I hear of all these deaths, and after my son died, Connor, 12, Edward, 8, Jack, 18, Joseph, 7, Chambers, 19, Jaime, 16, Edward, 24, Casey, 29, Newton, 16. That was just in 2014. You know, every year there's so, you know, people don't believe. In 2022, Emerson at 10, Jess 24, Omar 26, Akia 20, Shiv 18, Perry 17, Sarah 15, Tanya 24, Jagger 11, Hannah 31. As you hear, most of them are young deaths, and most of them were because most of the deaths for food allergies is eating out. So all I want is just to be preventative. And please, let's help, you know, when people might say, you have food allergies, well, don't go out to eat. No, why should they live in a bubble? That's all I'm asking. So please help me, you know, get this law passed in the honor of my son and his legacy, for that he will save other lives in the future in Texas. I do appreciate your time, and I know I've been to all your offices every year. This year I didn't get out as I've gotten older, bad knees, as you see I'm walking. But I'm going to try to get out now, and I'm walking a little better than I did in the beginning. I thought I was going to have knee surgery, but thank God, not yet. But so please, I will be back, you know, to support other bills, but, you know, it's hard for me to knock on everybody's door again. Thank you, and please get this, let's not let it pass the time. Thank you, God bless, and thank you for time, and please support this.
Questions, members?
Thank you.
Thank you. Sergey Degolovin.
I prepared my speech with good morning, but I will switch it with the...
I show you're registered with the Texas Allergy, Asthma, and Immunology Society in yourself,
Yes, ma'am.
and you're for the bill, correct?
Yes, ma'am.
Thank you. Please proceed.
I have to paraphrase what other doctors said. I went through internal medicine training, rheumatology training, immunology training, allergy training, and I got board certified in all of those. But I thought that it was hard for me. This is incredible. I learned a lot tonight, so thank you for your work, seriously. In any case, I am an allergist now, and I'm also the CEO of the oldest allergy clinic in Texas. It was founded by the great Dr. John P. McGovern. It's McGovern Allergy and Asthma Clinic. And yes, I am representing 350 other allergists. We're not many in the country. So I'm representing the Texas Allergy, Asthma, and Immunology Society. And yes, I'm also an assistant professor at Baylor, where for over 10 years, I trained internal medicine and allergy and pediatricians to become allergists. So the Texas Allergy, Asthma, and Immunology Society was helping to initiate this bill. And of course, we support it. Now, why is it important? We just heard why it's very important, but since I started talking to you, already some poor soul is in an ER right now with a terrible food allergic reaction. Right now in this room, not anymore, but this morning, I can guarantee you there were 4 people with food allergies because 1 in 10 adults have a food allergy, 1 in 13 children. Last year only in the United States, 200 people died, okay? So last year in the US, 200 preventable deaths, okay? If you translate from French, my name is Sergio. I didn't know about Sergio until today. I was born in Argentina, by the way, where my name is Sergio. In any case, in Texas, 3.5 of our fellow Texans, I've been living in Texas for 20 years now, 3.5 million Texans have a food allergy. 32 million in the United States. So almost a little bit more than what we have in Texas, right? We have 29.2 million Texans. So that amount in the United States have food allergies. I would be dead right now when I had my shellfish anaphylaxis if the people who are around me in that restaurant would have not known what a food allergy is. I will not be treating food allergic patients and children, and I will not be annoying you here right now. In any case, food allergy is an issue. So what is this bill? Education and prevention. You know, I'm the 5th generation of doctors in my family, but I have not learned to treat death. I can only prevent it. So that's what this bill is about. So I hope you can support it. So everything that we want to use is already in the website of the Department of State Health Services. It's just going to be a poster and some education. It's required already by law in Texas to educate people who work in the kitchen. We just expand that. I hope you support this bill and thank you greatly for your time.
Questions, members? Thank you very much.
Thank you. Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 1447? Chair recognizes Representative Campos to close.
Thank you. I respectfully ask for your favorable consideration so that we can continue to save lives. I close.
If there's no objection, House Bill 1447 will be left pending. The chair hears no objection. House Bill 1447 is left pending without objection.
The chair lays out House Bill 4173 and recognizes Representative Click to explain the bill.
Thank you. During the interim, there were several hearings on the fentanyl crisis. One of the things that stood out to me was the number of different data streams that currently exist to address overdose response and prevention. But what also stood out was how this data is not consolidated anywhere for better usage. House Bill 4173 creates an overdose mapping and response system at Dishes that brings together data from law enforcement, emergency medical services, coroners, or medical examiner's office from across the state. Dishes would be tasked to create metrics to be able to identify spikes in overdoses and develop and implement an overdose spike response plan. Dishes would submit an annual report to the legislature with this information. House Bill 4173 also creates a defense to prosecution for certain individuals that request or require medical assistance due to an overdose. Finally, House Bill 4173 would require DPS and Dishes to do a study on fentanyl and report back to the legislature with recommendations for next session. The goal of this bill is to utilize data to identify spikes and overdoses, push needed resources into the communities, and hopefully save lives. I'm open for any questions and reserve the right to close.
Members, are there any questions? There are no questions. The chair calls Leela Rice. Thank you again for being here. I show that you're registered as Leela Rice, and you're with the Texas Council of Community Centers, and you're for the bill. Is that correct?
Yes.
Thank you. You may proceed.
And I think I neglected to mention before, but the Texas Council represents the 39 local mental health and IDD authorities around the state, which together provide services across all 254 counties in Texas for mental health treatment, substance use treatment, services for people with IDD. And sort of similar to what I said with your bill, Vice Chair Campos, we really appreciate the public health aspect and bringing in public health and bringing in Dishes in the response, particularly to the opioid crisis. I think a robust public health response is clearly necessary right now for things like fentanyl and the damage that it's doing to our communities. So we really appreciate that. And I've been in communication with your office. We're really hoping that you'd consider adding local mental health or behavioral health authorities to potential grantees of the Dishes grants, in addition to the FQHCs and the law enforcement agencies. I think it would be a good match with all of the things that they do in their communities. But yeah, overall, we just really appreciate it, and thank y'all for sticking it out today.
Thank you, members. Any questions? No questions. Thank you for your testimony. The chair calls Betsy Bell.
Good evening.
Thank you
I'm
for being
tired,
here
so
this
I can imagine
evening.
y'all are very tired.
Thank you for being here. I show that you're registered as Betsy Bell. You're here on behalf of yourself and you're for the bill. Is that correct?
Yes, ma'am.
Thank you. You may proceed.
I'm here on behalf of myself and Shatterproof, which is a nonprofit as well.
Hold on a moment. We're gonna.
She'll let me change her to include that.
Do you mind if we change?
Is that okay?
Yeah, we just got to add the organization. What's the name of it?
Shatterproof.
Shadowproof? Okay, thank you. You may proceed.
Thank you.
You're welcome.
My name is Betsy Bell. I'm from Waxahachie, Texas. I am a single mom with 2 teenagers. I do not have a background in the medical field, but don't tell them that because they think I have a doctorate from WebMD. It's said that a well-told story is remembered more accurately and far longer than learning derived from facts and figures. Unfortunately, I only have a handful of memories from the 4 months that I was completely lost on fentanyl patches. After my double spinal fusion, I was sent home with a box of pain medicine. After no one in the family, including me, had any idea what this medication was. But it was a very high dose of fentanyl. Even if we did know what it was, we wouldn't have known the danger of this deadly drug. I was unable to change my own patches, so I'd have family members that would help me with that. There were many times that the kids would crawl into bed with me because I couldn't walk, and my patches would fall off. It wasn't until months later, whenever I was unable to function. I have no memory of that time. other than calling my doctor weekly, crying hysterically, because I couldn't even control my emotions. There were quite a few things that happened during that time, but the biggest point that I wanted to bring to y'all today is that my doctors did not even know how to take me off this medication. At the time when I was married, we had great health insurance. I saw the best surgeons in the DFW area. I had what I think was one of the best pain management specialists. Granted, my surgeon probably put me on that medication because I had a high tolerance. I had already been on pain medications prescribed for 3 or 4 years because of back problems. There was no one to help me. And because I had to go back to work and function and be a parent, I had to get off of this drug. And I had to do that on my own. So we finally found some pain management specialist that was able to help me. So in order to get off of fentanyl, we had to replace it with prescribed opioids, Valium, morphine, and muscle relaxers. That took a good 30 to 45 days of just being sicker than I can imagine. I never went into any surgery ever worried that I was going to not make it through the surgery. But when the times that I've had to withdraw from any of the medications that I had been prescribed by trusted physicians, and it just upsets me by no end listening to all of these medical professionals talk about how they do what's in the best interest of their patients. And as the term is that Representative Oliverson said, to improve the health outcomes of their patients. Yet that was never, ever addressed, nor did the doctors act like they had any idea of how to get off of the medications that they prescribed.
Ms. Bell, I'm sorry, your time is up.
Okay, so
Do you have any questions?
Can you finish
Yes, ma'am.
that thought, please?
So I'm here to just say I completely support this. I think it's phenomenal that y'all are here to save lives by education. I mean, if we could all carry this around, or at least even encourage the people that are in the medical field to tell those that they're prescribing this medication to at least have naloxone or Narcan on hand. Imagine all the lives we can save. The CDC reports that 27,000 lives have been saved just by this being handed out to family and friends. So thank you so much. God bless all of y'all, and I'll pass one on too. Thank y'all.
Thank you. The chair calls Leanne Bordetta. She had to leave, okay.
We submitted her testimony electronically.
Okay, thank you. The chair calls Ariel Britt. Hi, thank you for being here.
How's it going?
And I show that you registered as Ariel Britt. You're with the Addiction Research Institute at Steve Hicks School of Social Work at UT Austin, is that correct?
Yes.
And you're neutral on the bill?
Yes, on the bill.
Thank you, ma'am, for being here.
Thank you so much. Thank you, Madam Chairwoman, Vice Chairwoman, all the representatives here today. So my name is Ariel Britt. I currently am the Associate Director of Policy and Community Impact at Steve Hicks School Social Work Addiction Research Institute, and I'm representing Dr. Casey Claiborne on this issue and on this bill, but I'm also person in long-term recovery, which for me means I haven't used any mind or mood-altering substances in over 11 years. Also super pregnant, so bear with my breath. So something that's so important since Dr. Claiborne has come onto the scene, really looking at overdose prevention and adding that into the framework of what we're working on, is that during our research on overdose prevention, we found anecdotal evidence which suggests that 50 to 90% of overdoses may go unreported in Texas due to the existing data reporting infrastructure that we have. So it's siloed, it lacks consistent methodology to track the overdoses. And as things change and as iterations, as the illicit drug supply gets more creative, what are we gonna do then? We need access to that real-time data. And so requiring real-time data, overdose reporting in a centralized platform will result in improving data collection and save lives by distributing resources where they're needed most. So if we don't have all that data, how can we have a right-sized community response? So at ARI, we've been working on a software platform called TechScope, which stands for Texans Connecting Overdose Prevention Efforts to Improve Overdose Surveillance Across the entire state. It was developed by Texans for Texans using state-targeted opioid response dollars and Project Connect funding by the state's Health and Human Services. And it was built by a team of prevention experts across Texas, Baxter County, El Paso, Travis, Williamson, across the line of community providers, outreach workers, academic scientists, and of course, technology. So the goal of this is to not only track fatal, but also non-fatal overdose incidences. We need to count our wins. We need to see what things are working. And also allow us to track naloxone distribution and administration to make sure that those are going to the places that they need to go to and being utilized. So what we have in TechScope is something that bridges the gaps in overdose reporting by enrolling providers and first responders around prevention and intervention strategies. So we currently are working to onboard 25 organizations across the state, and we really see Texas having this opportunity to implement an innovative approach and lead the nation through enacting policies and supporting to improve overdose and surveillance efforts. So we're just asking, again, as we have already talked about before, we can't implement these things without good policy, and that's just important as we move forward on this issue. So thank you for your time.
Thank you. Any questions? Representative Collier?
Thank you, and I want to say how grateful I am that everyone who is here, stayed here. It warms my heart to see so many people, Texans, that participated in this process. One question I have for you, I'm on page 3 of the bill, and it says a report under the section must include the date and time of an overdose, the location, whether they had the Narol or any opioid, what is it word? Antagonist, thank you. I don't work in those worlds. And whether the overdose was fatal or non-fatal, and then the sex and the age. Do you think it would be helpful to have the race or ethnicity of an individual included in this report?
Yes, I think when we think about the most vulnerable and where we can improve access to resources, that is important, but it's also important to note that all of that data would be anonymous within TechScope, making sure that it is shared with who needs to know on a need-to-know basis. So this isn't performative, this isn't anything, it's really to save lives and to provide resources where they need to be and have an adequate response, and then also improve research on that as well, ma'am.
Well, of course, and so I see the location, but I don't see race and ethnicity included, but I just want to see.
So in TechScope, it does, within our framework of what we're working on, the software platform that we already have existing, it does have that as well.
Okay, all right, thank you.
Any other questions? Thank you for being here. The chair calls Cynthia Humphrey. Thank you, ma'am, for being here. I show that you're registered as Cynthia Humphrey, and you're with the Association of Substance Abuse Programs, and you're for the bill. Is that correct?
That's correct.
Thank you, ma'am. You may proceed.
I started, as he said, with good morning, moved to good afternoon, and I'm now at good evening. So good evening. And I appreciate your ability to stay late and listen to our testimony. I'm testifying in favor of HB 4173, and my name is Cynthia Humphrey, and I'm the Executive Director of the Association of Substance Abuse Programs, which is an association, a statewide association that represents substance abuse prevention, treatment, and recovery support providers, and is dedicated to ensuring Texans have access to a full spectrum of quality services. I'd like to begin by thanking Chairman Click for filing this comprehensive bill that addresses several key elements, actually evidence-based elements that are effective in preventing death from overdoses. Includes, the association is supportive of all those elements that are included in the bill: the overdose mapping, the statewide education, the fentanyl distribution via the internet, removing the restrictions for the current overdose bystander law, as well as developing an opioid prevention programs. But because our time is limited at the podium, I'd like to highlight in my testimony today one proposal in particular, and that's the proposal to establish a substance use disorder prevention collaborative. Prevention is critical to reducing overdoses and overdose deaths. And what I've learned, and what someone once said to me, is that prevention is in the eye of the beholder. And so in terms of reducing overdose deaths, all of the policies in the bill are considered prevention strategies, as are addiction treatment and recovery support services. But in terms of the traditional substance use disorder continuum, prevention is primarily based on primary prevention programs and school-based programs. And the goal of primary prevention is actually to get in front of the problem before it occurs or before it worsens. With more than 5,000 Texans estimated to have died from drug overdoses between July 21 and July 22, and of course the disturbing number of youth who are dying from fentanyl poisoning, we believe it is critical to increase the state's focus and its investment in upstream prevention strategies to avoid the downstream costs of addiction and the heartbreak of losing a loved one. So we very much support that component. And I'd also like, there's one recommendation or just one amendment I'd like to suggest in moving forward with the collaborative. The bill basically identifies the Department of State Health Services as the administrative agencies, but because funding and the administration of many of the prevention programs are under the purview of the HHSC Substance Use or Behavioral Health Division, we'd like to recommend that, especially in the incidents of the education campaign, the overdose grant, and the prevention collaborative, that consider that it's more aligned with the duties and the roles of the Behavioral Health Division.
Thank you.
Thank you.
Any questions, members?
Pardon?
Any questions now?
Oh.
Thank you, ma'am. The chair calls Leah Kaufman.
Good evening.
Thank you for being here. I see that you're registered as Leah Kaufman and you're with Shatterproof, is that correct?
Yes.
And you're for the bill?
Yes.
Thank you. You may proceed.
Thank you. Good afternoon, or evening. Chairwoman Click, members of the House Public Health Committee, thank you for the opportunity to testify today. My name is Leah Kaufman. I'm the Assistant Vice President of Public Policy for Shatterproof. We are a national nonprofit organization dedicated to ending the devastation addiction causes families. I want to begin by expressing our gratitude for your commitment to addressing the overdose crisis in Texas. I know there are a lot of efforts ongoing to help improve the well-being of citizens statewide. Shatterproof was founded by Gary Mendel in 2013 after losing his son Brian as a result of his addiction. Heartbreakingly, Gary's story is all too common. And I'm sad that you weren't able to hear from, we brought an ambassador earlier who lost her son. She lives in the Dallas-Fort Worth area. But I encourage you to see her written testimony. So Gary took his crisis and he transformed it into Shatterproof, which is a national organization that works in several different areas. We focus on transforming addiction treatment, ending the stigma surrounding addiction, and educating and empowering communities to confront this challenge. As you're all aware, the overdose crisis in Texas is a pressing issue. We applaud the efforts that are currently underway within the Texas House and also the governor's office to address specific issues such as naloxone access. A special thanks to Chair Click and Dr. Oliverson, who appears not to be here anymore. We see House Bill 4173 as a comprehensive strategy to tackle the multifaceted nature of this crisis. This legislation addresses key gaps, as Ariel and others pointed out earlier, looking at partnerships, prevention, and public health strategies. And importantly, it focuses on building upon the existing infrastructure that Texas has in place. For example, expanding evidence-based prevention programming to cover more schools and students, and ensuring fentanyl-specific prevention education is consistent and broadly shared across the state. In particular, with at-risk populations, we all know adolescents are particularly at risk for fentanyl poisoning. This legislation would establish a prevention collaborative that you've heard about and a grant program, as well as providing funding to the nonprofit community organizations that make up the critical infrastructure for distribution of naloxone and community-based education efforts. And finally, and perhaps most importantly, this legislation will improve the timeliness and accuracy of overdose data, as you heard from my colleague at UT. As fast as the fentanyl crisis is evolving, as she pointed out, the data that we have available now is often 6 months to 2 years old, and it's simply not actionable. So we need actionable data and surveillance to better understand where there are opportunities to intervene, to allocate harm reduction resources, to conduct additional education, and so on. In conclusion, I believe that House Bill 4173 is a vital step to saving lives and restoring hope to countless families. Thank you very much for your time. I'm happy to answer questions.
Thank you. Are there any questions? Thank you, ma'am, for your testimony. That's it. Is there anyone else that wishes to testify on or against House Bill 4173? If not, the chair recognizes Representative Click to close.
Members, overdose mapping gives us the ability to see and respond closer to real time to developing issues. Right now we're thinking about fentanyl overdoses. Well, a lot of the product is also being laced with a product called xylazine, which is a veterinary product. It's not even approved for human use. And people are dying of overdoses of that as well. And Narcan doesn't work on it. So this, going into the future would give us a forward-thinking way to monitor, manage, collect data, to develop a strategy going forward as new agents or products like that arise. Thank you, and I close.
If there is no objection, House Bill 4173 will be left pending. The chair hears no objection. House Bill 4173 is left pending without objection. The chair lays out House Bill 3162 and recognizes Representative Click to explain the bill.
Thank you, Madam Vice Chair. In 1999, Texas passed the Advanced Directives Act found in Chapter 166 of the Health and Safety Code. In recent years, this chapter has drawn increasing scrutiny from patient and advocates believing it lacked sufficient protections for patients and families facing end-of-life decisions. Since August of last year, stakeholders have participated in 8 large group meetings and numerous smaller group meetings negotiating and working through the issues. Hundreds of man-hours have gone into this effort, and I want to thank all the stakeholders for their tireless advocacy. HB 3162 is the result of their continued efforts. There will be a committee substitute to address some areas of disagreement that we were unable to navigate by the time we had to submit a draft to Ledge Council for filing. To be clear, the language before us is not fully agreed to, so you will hear from some stakeholders tonight testifying on the bill. The committee substitute that will be proposed will be a consensus measure to address the shortcomings of Chapter 166 and improve it. When a patient is in the hospital setting, an attending physician believes that the patient's life-sustaining treatment is no longer medically appropriate, there's a process that can be initiated that ultimately allows a medical or ethics committee to potentially override a patient or surrogate's decision and withdraw life-sustaining treatment. HB 3162 makes several changes to this process. It changes the current notice requirement to be delivered to the patient's surrogate for the committee meeting from 48 hours to 7 calendar days. The patient's medical decision maker is also provided more information about the committee's process and how they can prepare for it. In this review process, pre-existing disabilities and quality of life concerns are specifically prohibited from consideration. Should the committee decide life-sustaining treatment should be withdrawn, the current 10 calendar day timer is extended to 21 business days. To find another facility to transfer the patient or of life-sustaining treatment will be withdrawn. The committee sub will change this to 30 calendar days, a similar amount of time. Before this timer starts, certain medical procedures, like a trach and a PEG tube, have to be done to facilitate transfer to another facility. Long-term care, they don't have the ability to do those procedures, and so those procedures need to be accomplished in an acute care setting before transfer can be accomplished. There's also a reporting requirement that's been added for whatever facilities use this process so that we can have data for future review. The do not resuscitate process is cleaned up to remove duplicative notices that appear to be required under statute. Finally, the do not resuscitate process itself is cleaned up to prevent surrogate decision makers from overriding the express wishes of the patient when they become incapacitated. The bill sets a patient expressed wishes as the gold standard and surrogate decision makers' decision at a lower level so that they cannot override the patient's wishes. Additionally, it clarifies that a higher level surrogate can override a lower level surrogate's medical decisions. We will hear from several stakeholders this evening regarding their thoughts on this proposal. In the end, I hope that this bill will have a little something in it that everyone can live with. And I'm open for any questions and reserve the right to close.
Members, do we have any questions? No? We'll begin testimony. The chair calls Miranda Wilborg. Thank you for being here, and I see that you registered as Miranda Wilborg. You're with the Texas Right to Life, and on behalf of yourself, and you're for the bill. Is that correct? You may proceed.
Thank you so much. Madam Chair and members of the committee, my name is Miranda Wilborg, and I represent myself and Texas Right to Life in favor of House Bill 3162. And I'm providing a handout here with stories of patients Texas Right to Life has helped. As a trained patient advocate for Texas Right to Life, I have witnessed firsthand the tragic effect of the Texas Advanced Directives Act, particularly the 10-day rule, on many patients and their families. I've taken the initial intake calls and heard the panicked voices on the other end of the line telling me a hospital has given their husband or daughter or mother 10 days to live. One thing all of these cases share in common is the confusion and desperation on the part of the family. One sweet woman named Eugenia called us when a hospital started the 10-day process on her 73-year-old husband, Bill. Eugenia did not even know what treatment was being removed because the notice letter never specified. The only reason her questions were answered was because Texas Right to Life provided an attorney. If you would, imagine yourself in Eugenia's shoes. This was an elderly woman in a hectic hospital environment with no other family support, bearing the emotional weight of her husband's very critical condition. Imagine being introduced to this law for the very first time in those circumstances with no medical or legal background. No one in that situation is in the state of mind to ask level-headed questions about a legal process. The stakeholders involved in this bill know this law inside and out, but these families do not have that advantage. Having handled several of these cases personally, I can tell you with confidence that most families do not understand their rights or even the gravity of this law prior to the Ethics Committee meeting. Families often walk into this meeting not realizing the decision is out of their hands. And when they're handed information about the statute, it's just legal jargon to them. Yet as the law currently stands, families don't even have a right to an attorney in the meeting. I also want to note how difficult it can be to get information about the transfer process. We've had cases where we're filtering through hundreds of pages of medical records to find out which facilities had been contacted. We appreciate the efforts of the TADA stakeholders to craft this compromise bill. It will address some of the concerns I've highlighted today, although we do have a couple of concerns with the committee substitute that our president, John Segal, will address later. To be clear, the solution to a medical team's ethical dilemma over providing care should never be to end the life of a patient. Eugenia had to spend the last precious days of her husband's life desperately fighting his legal battle rather than spending those days by his side. House Bill 3162 significantly increases the rights and the protections available to vulnerable families, and I strongly urge you to vote in its favor. Thank you.
Thank you. Any questions? Thank you for your testimony.
Thank you so much.
The chair calls Mark Casanova. Thank you for being here. I show that you registered as Mark Casanova, and you are with the Texas Medical Association.
Yes, and
And
I'm
you're
also neutral, and I'd also like to add my healthcare system to my testimony, Baylor Scott White Healthcare System.
Okay. You may proceed.
Okay, well, good evening. Mark Casanova. I'm a practicing internist, palliative care physician, clinical ethicist at Baylor University Medical Center in Dallas. And first, let me just extend my deep appreciation to you. It's always a privilege to come testify, but then it's an equal privilege just to bear witness to the work that you do and the hours that you keep. So thank you on behalf of Texans. I also want to extend gratitude to all stakeholders for the effort that your leadership has provided us the opportunity to engage in many of hours since August with rich discussion, rich negotiation. I think hearing stories like were just shared to provide us all greater understanding and shine light where there was darkness. We do agree there's been movement in the right direction. TMA does have, as you've acknowledged, and we're all going to probably say the same thing, have some concerns with aspects of the bill as currently drafted, and then, of course, the ongoing discussions towards committee sub, but I think we as all of the stakeholders, I think are universal in our commitment to stay the course and continue negotiations in good faith. As physicians, we're asked to uphold our ethics and obligation to put the interest of the patient above all else, and specifically to avoid harm or medically inappropriate treatment that prolongs the natural dying process. So that commitment extends to our patients even through the dying process. I think substantial compromises, and you elucidated a lot of these. One of them was clarifying who this process applies to. This does not apply to competent patients. Moving the search period up front-loading it, giving 7 days of notification, giving families, as was just mentioned, information in hand about transfer efforts and what the outcome of those requests have been. Incorporating strong disability protection language as currently written, and in the same vein, providing transparency to the medical ethics deliberation process with, again, the language as currently written. And then what we spoke about 2 years ago, right here in this room, I believe, was removing those barriers to potential transfer for patients, specifically trachs and pegs, provided they can be done safely. Some areas that we personally have concerns over and ongoing discussions right now, the bill is written as 21 business days for a search period after what will be 7 days in a notification period after upfront efforts to transfer TMA stance would look at 20 calendar days, feeling that 27 days of searching plus the additional searching strikes a balance between the needs of the family, the needs of the surrogate, and mitigation of prolonged physical distress and suffering. I'm also concerned about one of the aspects in some of the DNR language, the provision for a physician to enter a DNR order when death is imminent, as per medical standard and American Heart Association recommendations. Again, we want to thank you and sincerely and hope that we can continue this discussion through the committee substitute. Also, last point, just as we navigate the committee substitute, we feel very strongly that substitute language relating to committee standards of disability protections must not result in a Trojan horse situation such that the amended language would negate the 046 process and effectively forcing an ethics committee to conclude that treatment is medically appropriate when it's in fact not. I'll conclude my statements there, and I know this is a very tough topic and be open to any questions.
Thank you. Any questions, members? No, thank you for your testimony, sir.
Thank you.
Mm-hmm. The chair calls Jennifer Alaman? Hi, thank you for being here, and I show that you're registered as Jennifer Alman, is that correct?
Yes.
And you're with the Texas Catholic Conference of Bishops, and you're for the bill?
Yes, that is
Thank
correct.
you.
My name is Jennifer Allman. I'm the Executive Director of a Texas Catholic Conference of Bishops, and we're here in support of House Bill 3162. We thank Chair Click and the other state representatives and senators and all the stakeholders for engaging in this extensive negotiation process. I will say we've been advocating for reform of this law for 20 years. And come before you many, many times, but never have we come before you with such a substantial improvement in the law across multiple topic areas with broad consensus approaching agreement. So I recognize that not everyone is yet in agreement and for the bill, but we are, because it addresses some of the most sensitive issues, and we're particularly grateful for what we anticipate in the committee sub related to the DNR provisions that were severely in need of reform. And I think we're very close to a final compromise on that language. What I'm passing out for you, what Teresa is bringing to you, is a handy chart that shows the current law and the flaws in red, and the reform measures in this bill in green. So I thought this might be a really helpful side-by-side, especially for those of you who've heard us kind of fighting over this year after year, for you to see exactly what the problem was and what the solution is in the bill. I'm not going to go through every single one of these, but I think from our perspective, a couple of the ones that are most important to us are the first one, that currently the with removal of treatment doesn't have very explicit criteria. It's medical inappropriateness, and that can be subjective. And so putting in place, limiting it to incompetent patients with language added to protect patients with disabilities is really important. On the flip side, it talks about what the ethics committee shall consider as they go through their deliberations. And we think that's really important because it focuses on the patient's known wishes, whether the life-sustaining treatment benefits outweigh the harms it could provide, prohibits quality of life judgments, which are critically important. And so I think that is one of the provisions we've never before seen in a bill. And all the different bills people have brought to reform this law, those elements have never been present. So I'm really pleased to see that they've been incorporated here. The DNR fixes, you heard us testify about that last legislative session, and we thank Chairman Frank for convening some kind of subcommittee meetings to kind of come to some agreement on that clarification. The reporting data will really assist us in better knowing how this law is working and what future reforms might be needed. Finally, on this one pager, I've listed all of the organizations who participated in the negotiation. Very clearly, I'm not stating any of these organizations' position, just that they spent hours and hours and hours and hours with us over months and months and months. And everyone has had some input into the bill, and that's why my hope is none of these organizations are coming before you tonight in opposition, but you will see various positions of support or neutrality. And I'm very pleased to be able to be before you with this bill and this conversation compared to some of the discussions of the past. I've also passed out our full statement on the act and its more detailed flaws in our kind of theological analysis of the issue. I'm happy to answer any questions.
Thank you. Any questions? No? Representative Click?
Thank you for being here and participating in these stakeholder meetings. I mean, we've been working on this for years.
Yes.
And we are very, very close.
I think so too. Thank you for the work that you and your staff has been amazing in putting in lots and lots of hours. So thank you.
Thank you. The chair calls Terry Carey Kirk.
Good evening, Chair Click.
Thank you, ma'am. I show that you're registered as Terry Carey Kirk, is that correct?
Terry Carricker.
And you're with PTFK and yourself?
Protect Texas Fragile Kids and myself, and I registered on the bill, but I'm going to change that to for the bill with some of the changes that we're discussing in the committee sub.
So you registered as a neutral,
Yes,
and now you're for the bill?
correct. Thank you. Can I do that?
But on the bill, she said that she's for the sub, which they're still working on.
Okay, got it.
And
So
she's
you're,
probably still neutral because we're discussing the.
okay, so
bill.
we're still discussing the sub, so are you still neutral? Is that okay?
We're discussing the bill as.
I don't want to do anything that might call a point of order. So if it's better for me to remain neutral, I'll remain neutral.
That's fine.
Okay.
Thank you.
First of all, I want to say thank you all for being here, and I'm very grateful for Representative Click and the staff and all the work. And as Ms. Almond stated, the hours of work that's been put into this by stakeholders. We're very grateful for the issues that were resolved in this process. But even as one of the very few groups that has had direct experience and involvement with patient advocacy for 10-day cases, some of our primary concerns that we voiced in discussions went unheeded to a great extent. Language that we thought had been agreed upon was later replaced by stakeholder groups without any discussion in the larger group or group consent. And that's why we have concerns about fully supporting it. In meetings with 30 to 40 stakeholder voices representative, only 4 or 5 of us were actually representing patient and family concerns. So much like this process itself, even the stakeholder negotiating group reflected this imbalance of power that we as patients and families often experience during these difficult times as our loved ones approach their final hours. So among our continued concerns is a section on discrimination based on disability. The number of days is still problematic for us. Essentially, a hospital has the power and resources to run out the clock if they're not incentivized to help facilitate a patient move. And we as patients have great difficulty affecting a move if the current hospital and treating physicians are not actively supporting and helping facilitate that to happen. The standards by which life-sustaining treatment can be removed against the will of the patient or surrogate is still a little vague, in our opinion, and contains no protections against some of the subjective determinations there. So we believe that most physicians seek what they believe to be in the best interest of the patients. We fully support and know and believe and understand that. But our laws are not written for those who practice with integrity and in good faith, but rather for those who don't and who may seek their own agenda. So we just ask that as you consider this legislation, especially committee sub-language, that you would realize that any one of you at any time could be in this position and may find yourselves subject to this legislation yourselves. Hannah Maida will give more detailed written testimony and suggested language that we believe will strengthen patient and family protections, and I've given a little more detail in my written testimony than my verbal. I'm happy to answer any questions.
Thank you, ma'am. Any questions?
Thank you.
Thank you. The chair calls Cesar Lopez. Thank you once again. And you're registered as Cesar Lopez with the Texas Hospital Association, and you're neutral with the bill?
Yes, ma'am. Neutral on the bill is filed, again, with the understanding that we have been working, I think, even up to today on amended language, and so I think there's a way that we could get to for the bill. I think the testimony that you've heard tonight regarding the amount of work that has gone into this bill is a testament to really everybody that's involved. I really want to give my appreciation to everybody involved, but certainly Chair Click, Brian, Teresa, all of the staff in Chair Click's office for the hundreds of hours that have been spent since this summer, just since this summer on this bill. So there are a lot of, as you've heard, there are a lot of things in the bill that we see as an improvement. There are certainly things in the bill that we prefer to not be in there, but we understand that it is a compromise, that not everyone's going to be happy with everything that's in the bill. That's the nature of this compromise, so we continue to try to find common ground here, see if we can come to an agreement on this bill. Will we commit to continuing this process? I can tell you personally, I have put in hundreds of hours since the summer, oftentimes to my detriment on this bill, and looking forward to hopefully finding a solution and a compromise and an agreed-to bill.
Thank you. Any questions? Thank you for your testimony. The chair will call Tommy Farrell. Thank you, sir, for being here. I show that you're registered as Tommy Farrell. You're with Hendrick Health System, Texas Hospital Association, and behalf of yourself, and you're neutral on the bill. Is that correct?
Yes, ma'am.
Thank you. You may proceed.
Thank you. And I aspire to represent my patients and families. I've been a physician for 23 years. For the past 18, I've been in hospice and palliative medicine. I take care of patients mainly in the hospital, in the ICU, where they have to make terrible decisions. I was frontline during COVID in the ICU. I take care of patients in a cancer center. When they go to hospice, I go follow them on hospice. So I drive home tonight. I'll go tomorrow to one of the 12 counties to see 4 patients that we see in our area. 2 years ago, I was here and testifying against legislation with the concern that physicians weren't invited into the room in the conversations that were had before. So I do very much represent. This time it's been different, and so appreciate Representative Click especially, and Brian Schufelt and so many others who were a part of the process. So we do appreciate that we've been a part of the negotiations, and they've been tough. There's a lot of different perspectives that are being shared. There's some good things that aren't even related to the conflict resolution that I'm most invested in making sure we don't lose. The fact that it's very confusing for healthcare providers and for families that there's one list for who can consent for treatment and and some differences in the list on who can withdraw treatment. And so that's confusing. So matching those lists is essential. It's also very tough on so many people that when a person's wishes, when they're told to you directly, if you told me directly after we've discussed a serious diagnosis in the hospital that you don't want to be resuscitated, and then when you're unconscious, family members come and change that, that's tough. And so we're appreciative that this would fix that and only allow the only person who could overrule that is someone that you designated yourself to be a decision maker on your behalf. So we like that. We like the protections that are there for making sure that we don't consider the wrong things in the ethics committee. I do have some worries. I have worries that we're even focusing so much on the number. I think that's a false security. I think we talked about, I've heard some say that without a certain number, they will not consider this a victory. There's no victory in this process. This is dying, and it's terrible for these families and patients, as you've heard. And one number that's will be a prolonged suffering for patients and families and providers, and that same number can be too short and cause all the harm and abandonment that you hear from other patients today. The number doesn't fix it, it's the process that fixes it. So I'm nervous about the number, and I worry about the impact on the number for the nurses especially, because I know some feel like there might be an overcall on the effect of the nurses in our ICUs that take care of these patients, that they can't really see the suffering that they say they're seeing. I don't believe that. I know the reason I believe that the suffering does exist and can be seen is because we all feel compassion. And y'all felt it today with some of the testimonies y'all have seen. So the fact that compassion exists means that the suffering exists, and if we do too much harm to the nurses in this process and the length of time, we will probably have an impact on the nurses on some level. And so thank you for your time. I can answer questions.
Thank you, sir. Any questions? Thank you for being here, sir. The chair calls Jack Frazee. Thank you for being here, sir. I show that you're registered at Jack Frazee and you're with the Texas Nurses Association, and you're for the bill?
That's correct.
Thank you. You may proceed.
Thank you. I want to say thank you, Madam Chair and members, for taking the time and being here this late. Appreciate you all sticking it out. I also want to thank Chair Click for leading on this issue. She has done a lot to pull everyone together and make sure that we're all working well together as we try and figure out compromise language. And I also want to thank our staff. People have already called out Teresa and Brian, but they have done excellent work on this, and that's something that needs to be said. I also want to thank everybody else that's been involved. It has been a very collaborative process. And as often is the case on these kinds of things, there's going to be stuff that everybody's happy with and everybody dislikes, and that's how you know you found the compromise. So as you heard just previously, the difficult thing for nurses in this situation is just how long they have to spend with these patients while they're going through these really difficult issues. And that can cause all kinds of psychological trauma for nurses that's very difficult to deal with. So I would just caution everyone, and this is what I shared with the group, we want to be careful not to extend the number of days excessively, or you run the risk of causing some real trauma for nurses. So that is one thing that I think was a concern for TNA going into this negotiation, but there are several things in this bill that are improvements on the process that we have. And one thing that I think it's hard to understate how useful this will be, but there's going to be data collection so that if this work group has come up with some sort of solution that ends up being suboptimal in the future, then you will have data and information that helps guide that decision-making process in the future. So I don't want to belabor all the points everybody else has made. I think it's a good thing to pull people together and work on these compromises, and this process that we engaged in is something that I would encourage the legislature to use for other tough issues. Thank you.
Thank you. Any questions? Thank you, sir.
Thank you.
The chair calls Hannah Mathai. Thank you for being here. I show that you're registered as Hannah Mathai. Is that correct?
My name is Hannah Mehta.
And you're with Protect Texas Fragile Kids, and on behalf of yourself, and you're neutral on the bill.
That's
correct. Is that correct?
Yes.
Thank you, ma'am. You may proceed.
Thank you. First, I want to say thank you to Chair Click, as so many others have tonight, for your commitment to reforming this process, and to Brian and Teresa as well, who deserve all the credit for the incredible amount of work that they've put into this just in the interim alone. So thank you for all of that. We are testifying on this bill because we have good faith that Chair Click will continue to ensure that all voices are reflected and that certain forms are addressed before the bill is passed out of committee. In representing thousands of families with medically fragile children throughout the state, I have also been privileged to come alongside of those families personally as a patient advocate. And I have direct experience working with those families who find their children and loved ones faced with these awful circumstances, including the high-profile case of baby Tinsley Lewis. As a reminder, many of you know, in early November of 2019, the 046 process was invoked to remove then 9-month-old baby Tinsley's life-sustaining care for no other reason than that she would never be healed from her underlying disability. In February of this year, baby Tinsley turned 4 years old. She's finally home with her mom, her baby sister, and her grandfather, blowing kisses to grandpa and letting her nurses know when she doesn't like something. Baby Tinsley has defied the odds despite the discriminatory practices and bad faith, which was abundantly evident throughout that process. This 046 process and the TATA process is something which is disproportionately utilized on minorities, uninsured and underinsured, and individuals with disabilities. We have unfortunately seen this in multiple cases, and the limited available data confirms this. There are a couple of primary areas of concern that I want to quickly bring to your attention, which we are asking to be amended and have been discussed at some length in various meetings. We believe that the decision regarding appropriateness of treatment pending transfer must be determined by the physician who will perform the procedure, not the patient's current attending physician who invoked 046. We would ask that you consider adding a central line report if needed to those procedures, and remove the requirement that the receiving facility must confirm treatment necessary prior to proceeding with said treatment. As a patient advocate who has firsthand experience in a number of cases involving transfers, this is not realistic and will render this section ineffective. We also would ask that any days increase be business days rather than calendar days. Additionally, we believe that there must be clear and unambiguous standards under which life-sustaining treatment can be removed, and that any decisions related to quality of life must be left to the family or surrogate. Last but certainly not least, we ask that the discrimination clause based on disability be addressed, as we believe the current language as filed renders the discrimination clause completely ineffective. And I know that there's some work ongoing in the committee sub on this, and so again, we thank you for that and look forward to continuing those discussions. Lastly, I just want to say, if we're going to err on the side of anything, we must err on the side of life. And as one of Tinsley's attorneys stated, inmates on death row currently have more due process than patients under the current process. So we thank you again for your work on this, and we also want to say thank you for including significant data collection, which we believe is critical. Thank you so much for your time.
Thank you, members. Any questions? Thank you for your testimony. The chair calls Patrick Ronehan. Hello, thank you for being here. I show that you're registered as Patrick Ronehan, is that correct?
Rockneen.
Okay. And you're here on behalf of yourself, and you're neutral on the bill?
That is correct. Yes.
You may proceed.
Thank you. Chairman Click, members of the committee, thank you very much for the opportunity to attend today. I'd just like to briefly echo what's been said many times, that it's wonderful to see that so many factions who differ in many ways came together to try and find a solution to what is an incredibly difficult and complex area. I am a cardiac surgeon. I'm a clinical professor of cardiac surgery at UT McGovern, and my experience allowed me the great opportunity to be asked as a physician to render a second opinion on Tinsley Lewis's case. And that was eye-opening to me as a physician in terms of how unbalanced the decision-making can be in such critical matters. I've been a chief medical officer. I'm a surgeon. I've dealt with many patients, DNR situations, and I've always seen it from that side of the fence. But it was eye-opening to me to see the imbalance of power when it came to a young child and decisions being made about her. And that's not because the institutions or many people, Hospital Association, Texas Medical Association, Catholic bishops, people have differing opinions, but I can just say, I think it's incredibly important when we work on the new rendition of the bill that we really make sure that we don't put the patient in that compromised position and fully consider everything from the perspective of the patient, of which we all one day are, or our loved ones will be. So it's incredibly important. Not to belabor my testimony too much, but there's just a few points about the bill as a clinician that I would like to actually echo what Hannah said already, specifically the treatment pending transfer. One thing that as a clinician strikes me as being very important, tracheostomy, gastrostomy are very important, but some patients, and actually Tinsley also required a central line because certain of the medications that patients require really can't be administered through the peripheral venous system. And having the opportunity to include a central venous line, I think is a very important addition to the bill as it currently stands. Furthermore, I do also believe that the decision-making regarding the performance of those procedures and the appropriateness prior to transfer should be made by the physician who performs those procedures and understands the risks and benefits thereof, and not the physician who invoked the 046 process. I understand there is some work being done currently on the language rendered by the TMA recently, the 7 points that they raised, and I think those are very well-intentioned points. I think there is some softness in some of the statements that would be, can improve, that can be looked at and improve the ultimate quality of the bill whilst not losing any of the impetus of the things that the TMA are trying to bring forward.
Doctor, your time is up.
Well, thank you very much. The only other thing, if I may, for 1 second, is just say the discriminatory language that Hannah, I echoed that those appropriate changes also, and the calendar days extending it. But thank you very much for the opportunity.
Thank you. Any questions, members? No. Thank you for being here, sir. Thank you. The chair calls Colleen Wright. Colleen Wright? Yeah, she's coming. Okay. Thank you, ma'am, for being here. I show that you are registered as Colleen Wright, and you're with Texans for Life Community and yourself, and you're neutral on the bill. Is that correct?
Actually, I'm for the bill. That's a mistake.
Okay, just a moment.
Just that for me, please.
So you give us permission to change it to for the bill?
I do.
Okay.
Yes.
Thank you. You may proceed.
Thank you. My name is Kylene Wright, and I'm the longtime president of Texans for Life Committee, the advocacy arm of Texans for Life Coalition, and we work to protect innocent human life from conception until natural death. Over the years, our organization has been aligned with different sides of this issue as we have continually worked for incremental reform. We achieved much of this reform in recent years, starting with the protection of food and water for vulnerable patients. And this negotiation was, as everyone has pointed out, far more substantial and comprehensive than any other. And we're excited about the reforms in this bill. More days to allow for the possibility of a successful patient transfer, fixes to the DNR process, clarification of the rights of surrogates, and the rights of the patients to have their specific wishes honored. These are all important things, and when you add to that the data reporting, which will help us identify any future needed reforms or any of the deficiencies that some of the people have expressed concerns and fears over, will help us inform the changes that we need to make in a timely manner. So I too want to express my thanks to Chairwoman Click and her staff, Brian and Terry and Teresa, and all of the stakeholders who've put so much time into this. I'm very encouraged and optimistic that we might finally see patients and healthcare workers working these matters out instead of having to run to the media or the courts. And I want to thank you again for your time and your effort into this matter. And we'll look forward to what we have always worked for and anticipate being an agreed bill.
Thank you, ma'am. Any questions, members? No?
Thank you.
Thank you for being here. The chair calls John Seago. Thank you for being here. I show that you're registered as John Seago, and you are with Texas Right for Life and yourself, and you're for the bill. Is that correct?
Correct.
You may proceed.
Thank you. Madam Chair, members of the committee, thank you for your attention to this issue. My name is Dr. John Seago. I serve as president for Texas Right to Life. I also have a master's and doctorate in bioethics and have presented academic papers and published articles in bioethics on this specific law that you're considering this evening. I wrote my thesis and dissertation on this very topic in this section of Texas law, but I won't bore you with reading that or even giving you a copy of it. I am here in support of House Bill 3162. Texas Right to Life, we seek to protect not just preborn children and pregnant women, but also vulnerable patients. Our organization a couple of years ago actually had to open a new department in our organization to serve as patient advocates. And you heard from Miranda earlier, who is one of our patient advocates, who takes those phone calls and goes to the hospital, goes to the court if necessary, but helps represent those families. And so we've seen firsthand what the 10-day rule does to families. We've seen firsthand patients lose their life from the 10-day rule. And thankfully, we've seen a lot of victories once we get involved to get those transfers, those patients transferred to a more appropriate care setting. And so this is an important issue to Texas Right to Life, and we're very passionate about it. We have actively been engaged in the stakeholder work group you're hearing about since August. There are only 2 organizations in that long list that actually have that patient advocacy experience of going to the hospital, going to the ethics committee, and we are one of them, and we're really happy with what the direction that this bill is headed. There are 3 things that I do want to clarify about the current law, not the bill, but the current law that the bill is addressed to. The Texas Advanced Directive Act is unprecedented. There is no other state that does it the way Texas does it. Virginia is close, but they have judicial review, which means even after the ethics committee makes their decision, you can go to a court. We don't have that. It is cited in law reviews, in bioethics and medical journals as a unique model to deal with these disagreements, and it's widely criticized. We also believe that this Texas Advanced Directive Act is unconstitutional. The Second Court of Appeals actually ruled that this law does not give patients due process rights. The Attorney General submitted a memo in that case agreeing that this law is unconstitutional. And lastly, the Texas Advanced Directive Act is unethical. It violates patient autonomy by unfairly allowing strangers to make life and death medical decisions and for a patient. This bill doesn't address all of those problems, but it does significantly improve the law. It does return some of the power, some of the rights back into the hands of patients and their families, and that's why we're here in support of this bill. We greatly appreciate Chair Click's work on this. There are a lot of changes in this law, some small, or in this bill, some small and some big, but there are 3 areas we would like to see the bill continue to be improved, as it's already been highlighted by a couple of these people. The anti-discrimination policy still needs work. The principles that the Hospital Ethics Committee uses to remove treatment, and the number of days, the final number. So we do appreciate all of your work on this, and we're optimistic we're going to get this bill across the finish line. Thank you.
Thank you. Any questions, members?
Appreciate
Thank you, sir. The chair calls Ashley Solano. Thank you for being here. I show that you're registered as Ashley Solano and you're with Texas Right for Life. And on behalf of yourself and you're for the bill, is that correct?
Yes, Texas Right to Life.
Thank you, ma'am, for being here. You can proceed.
Thank you, Chairwomen and members of the committee, for your time. My name is Ashley Solano, a patient advocate at Texas Right to Life. I represent myself and Texas Right to Life, and I am testifying in favor of House Bill 3162. There is a handout being provided to you showing patients who we've advocated for, stopping the 10-day countdown, and a result continuing life-sustaining treatment. As a patient advocate, I communicate with families in the desperate situation of hospital conflicts. One example is when a Texas hospital is seeking to remove life-sustaining treatment from a family's loved one in the form of the 10-day rule. I begin by gathering information and provide initial advice. Once I relay that information to our team, our first thought is, how much time do we have? House Bill 3162 expands the allotted time for families to seek and receive the help that they need. And it also increases the time of treatment after a decision is made by the ethics committees. Families face an overwhelming amount of pressure from hospital staff and need time to understand and process the severity of the issue, and not to mention time to seek help. One example is the Salazar family. Robert Salazar called Texas Right to Life on day 9 of the countdown for his brother Jesus. Robert didn't understand the sense of urgency and the severity of the conflict. Robert had a medical power of attorney, deeming him the decision maker for his brother. He believed that this life or death decision would be made by him, not by strangers in white coats. And he was wrong. Jesus was conscious. Robert asked his brother, and Jesus said he wanted to live. The Salazar family also received the registry list only 1 day before the ethics committee meeting, and this did not allow enough time to prepare and seek assistance. Despite the time constraints, Texas Right to Life succeeded in stopping the countdown and secured a transfer, and Jesus lived on for 94 days. More time would also help Texas hospitals.
Physicians and administration would have more time to explain to families the gravity of the situation and equip them with the information that they need. Hospitals will also have more time to transfer the patient. As we can all agree, ending a human life to resolve a conflict cannot and should not be considered a form of resolution. As the current statute stands, I would be concerned to be admitted to a Texas hospital in life-sustaining treatment, even with the knowledge that I now have. Not every family has the advantage. While we do have a few concerns in the committee substitute that were addressed by Dr. Sego, we do support the revisions of this bill to the current law and process. It would help me as a patient advocate in serving these families, but most importantly, House Bill 3162 would provide more rights and safeguards for families, foster cooperation between families and hospitals, and ultimately save lives. Thank you.
Thank you. Any questions, members? No. Thank you for being here. The chair calls Joe Polham. Is that right? Polham? Thank you, sir, for being here. And I see that you're registered as Joe Polham? Polham. And you are with Texas Alliance for Life, and you're neutral on the bill, is that
That's correct.
Thank you, sir, for being here.
Madam Chairman, members of the committee, thank you for being here and hearing this bill. The current dispute resolution process in Texas law can certainly be improved, and this bill goes a long way to doing that. As a person who has been working this issue for 24 years, I was part of the original group that put this bill together in 1999. I can say that this is the farthest we have ever come at an agreement to a truly substantial change to the bill in a really remarkable way. When there's a dispute between the decision makers of a patient and the provider, the goal of the process should be, the dispute resolution process should be to resolve the dispute and agree to the medical interventions. If in rare cases no agreement can be made, the goal should then be to find an alternate provider. This bill increases the notice of the hearing from 48 hours to 7 calendar days. And attempts for the transfer begin at that point. That is a huge improvement, which we strongly support. The time to transfer after the Ethics Committee meeting, if they agree that the interventions are medically inappropriate, is increased from 10 calendar days to 21 business days, which corresponds to 30 calendar days. So we would like to see that increase from 10 calendar days to 21 calendar days, not 30 calendar days. So overall, that's 12 calendar days, in our view, to 28 calendar days. And we think that would be a truly, a really good improvement. Now let's keep in mind, many of these patients are in the process of dying. And the medical interventions are causing great pain and suffering, disproportionate to any possible benefit. We believe that 7 plus 21 calendar days is really a good balance between the attempts to find a transfer and not unduly causing pain and suffering day after day. So we think if we could get this to 7 to 21 days, our organization would be very happy to support this bill. But we are continuing to work with the stakeholders and with the legislators. Thank you to Chair Click for leading the charge on that. Thank you.
Thank you for being here. Any questions, members? Thank you, sir. Is there anyone else that wishes to testify on behalf or against the bill? The chair recognizes Representative Click to close.
Again, I want to thank all the stakeholders for the countless hours that have gone into this bill and look forward to shortly having a committee substitute that we can all find consensus around. Many of us have worked this particular issue for decades, and this is the furthest that we've gotten, and have made some pretty significant changes that I think will be good for patients, providers, and facilities. So thank you, and I close.
Thank you, Representative. If there is no objection, HB 3162 will be left pending. The chair hears no objection. HB 3162 is left pending without objection.
Okay, members, that concludes today's agenda. The chair moves to adjourn. Is there any objection? Hearing none, the committee stands adjourned, subject to the call of the chair.
Oh, he did?
You didn't even look out.
Oh, I know.